Good. Good morning, everyone. Hi, morning. Can you hear me at the back? Well, welcome. Thank you, everyone, for attending, and welcome to the Lipodystrophy UK Patient Day 2026. I'm really grateful for you all making the effort to come today. I know some of you have travelled a really long way, so really, really grateful. I just wanted to say, before we go on, we would really like to take some photos of the day. We do intend to use them on the website and on our social media, so if anyone doesn't want to be in those photos, please could you just let one of the team know, and we'll obviously try and avoid catching you. So my name is Siobhan Dunn. I'm a trustee for Lipodystrophy UK, along with Anna Greenaway, who is here with her lovely daughters. Vanessa Kill unfortunately couldn't make it today, and Catherine Ellison, and of course our founder and chairperson, Becky Sanders. Over the past year, we've continued our mission to raise awareness and advocate and provide support to those affected by lipodystrophy. We've done this in several ways as a team, attending the Lipodystrophy Leaders Forum, which is where we connected globally with other charities worldwide to discuss collaborations and ways we can raise awareness. Our honorary trustee, who I think many of you have met, Rosie, along with her lovely mum Anna, has been making some wonderful handmade items. Rosie's been selling these locally, and she's been using it as a way to raise funds for lipodystrophy and also spark some really nice conversations about lipodystrophy and spread the word, which is amazing. So well done, Rosie. Their items are actually on sale on the merchandise stall, so if you could have a look, we would really appreciate the support. So in April 2025, we began the Patient Journey Project, which was in collaboration with Chiesi. Some of you may remember I did post the survey on the Facebook group quite often, so sorry about that, but I have to. The goal of the project was to collect the views and the experiences of current patients with regards to their journey to a lipodystrophy diagnosis in order to identify possible improvements that can be made to the process. We were really grateful to everyone that took part in this project and pleased to announce in December 2025 the paper, A Qualitative Assessment of a Patient Journey to Lipodystrophy Diagnosis, was published in Science Direct, which I think I missed. There we go. And then more recently, our wonderful Rosie. Well done, Rosie. So more recently, we've been working with Chiesi on a location project, and this is an initiative which aims to map where care is provided, identify the types of lipodystrophy, and the access to the specialist services throughout the UK. So this survey is still open. We really encourage anyone who hasn't completed it yet to just take a few minutes to participate. You can either scan the QR code that's on the screen, or I am going to share the link again on the Facebook group next week. If you've already participated, please don't do it again, because obviously we don't want lots of people in the same place if it's the same person. And so that's about it from me. We've got a packed agenda today, as you can see. I'm really grateful to everyone that's going to speak and share their stories. And so I'm going to hand over to our chair, Rebecca Sanders, who will give you our first presentation. Thank you again for attending, and I really hope that you enjoy the day.
Not as tall as Siobhan. First of all, apologies for my voice. Hopefully it'll hold out for the presentation. Thank you for joining us again. We're really excited to have you all here. Last year, many of you also attended, and I hope you agree it was a very successful event. And building on that, we have a similar format for today, as already communicated in the agenda. We are having a few different things as well, slightly different format to our patient stories, which seem to be the most popular part of the day. But hopefully you'll get a lot out of it, meeting other people that understand what you're going through and sharing experiences. So my talk, just to start us off, is an introduction to lipodystrophy, understanding the basics to kind of make sure that everyone kind of has a similar grounding in the condition to understand what it is we're going through, most of which you guys out there, you're the experts, we're the ones that live in with it, we know what we have to deal with on a day-to-day basis, but it kind of puts it into context of the medical side of it. So what is lipodystrophy? We know that lipodystrophy is a group of conditions characterized by the loss of fat tissue, also known as adipose tissue. That is subcutaneous, that means under the skin. It is a complex and essential, highly active metabolic and endocrine organ, and it stores excess energy or calories that we consume in our diet as fat. And it also serves to secrete lots of different hormones, such as adipokines, involved in energy homeostasis and the immune system. For normal weight loss or gain, this is a result of changes in the amount of fat that is stored in those fat cells. In lipodystrophy, our capacity to store fat as excess calories is reduced, either because the cells are abnormal or they're absent. And this means that the fat we consume in our diet must be stored in other places, and usually other places that are not suitable, such as around our organs, our liver, our muscles, our heart, etc. So, fat cells. There are different types of fat cells, predominantly white fat cells or adipocytes, as well as beige and brown. White fat stores energy and is used to insulate the body, so to help us regulate our body temperature, and is involved in hormone secretion, and it's usually found underneath the skin, subcutaneously, or visceral, that's around organs. Brown and beige fat burn energy to generate heat, this is to help maintain body temperature, which is known as thermogenesis, and are located in different areas of the body. In lipodystrophy, the primary deficit is in the loss or near total absence of white fat cells. However, the research is suggesting that both brown and beige fat cell loss are impacted, or their function is impacted also in lipodystrophy. And this means that the body loses its ability to safely store our excess energy as triglycerides or fats. So what are the consequences of this? So if we're losing white fat cells in lipodystrophy, that means an absence of the cells or an inability to store lipids. The result is the lipids spill over and have to be stored somewhere else, and they end up overflowing and getting stored on our organs. So this is known as ectopic fat. This is not where it's supposed to be, and that's what causes a lot of the metabolic problems that we have. If we have a loss or reduction in activity of brown fat cells, this impacts our metabolic rate and impairs our body's ability to handle glucose. And similarly with beige fat cells, it's kind of a loss of that metabolic sink that normally helps us regulate blood sugar and fats. So, symptoms and complications may include, so some people will have all of these, some will have none, and some will have some of them. So just because you have lipodystrophy doesn't mean you're going to get any or all of these symptoms, but some of the things may include severe insulin resistance, uncontrolled lipotrophic diabetes, leptin deficiency, extreme hunger, hyperphagia, high triglycerides, acute pancreatitis, fatty liver disease, cardiovascular disease, high blood pressure, kidney disease, muscle pain, neuropathy, and fatigue. Now, that looks like a really scary list. Please don't take away from that you need to be scared. They are possibilities, but by no means an absolute. And actually, by understanding the condition and doing what you can to help yourself and working with your clinicians to manage your condition, then a lot of these side effects or complications of lipodystrophy can be avoided or mitigated. So this is something I always put up every year. This is a word cloud that was generated from asking people in our community what are the words that they associate most with lipodystrophy. And as you can see, challenging, frustrating, understanding are things that are coming up most of the time within the population. But of course, there's all sorts of other things that people struggle with. So uncontrolled support, confusion, liver, diabetes, leptin, loneliness, pain. This is a really difficult condition to manage, and partly it's difficult to manage because not a lot of people know about it, not a lot of people understand it, and that includes the medical community. We're fortunate today to have members of the medical community that are experts in the condition, and that obviously is very beneficial for us because that helps us to manage our condition. But a lot of medics have never heard of lipodystrophy. Even diabetes doctors, not everybody has heard of lipodystrophy. And part of what we do as a charity, in conjunction with our clinical colleagues, is to try and raise awareness to improve that situation so that when somebody goes to a new clinician who hasn't treated somebody with lipodystrophy, maybe they've heard of it, or maybe they know where to get resources, or maybe they've treated other people too, so that helps everybody. So, as you may know, there are several different types of lipodystrophy. There's partial lipodystrophy, and this is the most predominant form of lipodystrophy. This means there is a partial loss of subcutaneous fat in certain areas of the body that are affected. Generally, it tends to be fat loss in the extremities, so in your arms and your legs, with excess fat around the face, neck area, and varied fat in the torso, depending on which subtype of lipodystrophy you have. Bear in mind, these are generalizations. Obviously, everybody's individual case is different. The remaining tissue that is fat tissue that is still present may be redistributed. So you may think, well, I've got a lot of fat on my face. Why couldn't I have some of that on my backside so it's not so uncomfortable to sit down, right? Or on my legs? Unfortunately, we can't control that. That's just what happens. That's where it goes. And it can leave us feeling quite frustrated because it seems to be a total disconnect on where we need the fat. But that's what happens. In generalized lipodystrophy, this is a total absence of subcutaneous fat from the entire body. So that means there is no fat under the skin at all. So when you think of fat tissue as a metabolic organ, as an endocrine organ that has a big responsibility in maintaining and managing our metabolism correctly, as well as our hormones, the lack of it, and certainly the total lack of it, has a massive impact on our health. These subtypes of lipodystrophy can be further split into inherited, familial or congenital forms. They all essentially mean the same thing, which is that it's coded for in our DNA. But there's also acquired lipodystrophy, which there is no inherited component that we know of, and is usually associated with environmental triggers. The cause is not always known or understood. Sometimes it can be attributed to some sort of autoimmune condition, but it's much less well understood. And both so the acquired form is generally less prevalent, but again, it can vary massively. So for example, there are what you would call normal diabetics, or non-lipodystrophy diabetics, who get localized lipodystrophy at the site where they inject their insulin. So that is literally just a very small patch where they inject. That's not the same as the type of lipodystrophy that we have. There are people with acquired lipodystrophy that have generalized lipodystrophy, so they have no fat at all. So it varies significantly depending on the subtype that you have. And within that, we all have different background genetics. So even though you might have the same subtype of lipodystrophy as the person sitting next to you, your experience of it may be very different to that person. So there are no absolutes, we just generalize, but a lot of the similar problems we share and we can support each other with. So lipodystrophy is classed as an ultra-rare disease affecting around 2.5 people per million globally. Now, this number is not really very accurate, partly because lipodystrophy has gone misdiagnosed, undiagnosed for a long time in a lot of places. I think this probably stands as more or less true for generalized lipodystrophy, so about 2 in a million of the population. For partial lipodystrophy, there is a big number of undiagnosed people. I think partial lipodystrophy is massively misdiagnosed or undiagnosed, and actually the proportion in the population is a lot higher than we realise. However, it's going to take time and increasing awareness in order to understand those numbers better. Okay, so leptin. Again, a lot of you who have been part of the community for a while have probably heard a lot about leptin. There are various treatments involved around leptin. I'm not going to talk about the treatments today, but what I am going to talk about is what leptin is, what it normally does in the body as a hormone, and how it's impacted by lipodystrophy. So, leptin is a hormone that is made mainly by fat cells. So if we're lacking fat cells, it makes sense that that's going to disrupt the amount of leptin that we have in our body. It travels in the bloodstream and tells the brain how much energy is stored in the body. So it's useful to think of it a bit like the body's long-term fuel gauge. So we saw our fat cells earlier. Leptin is mostly produced by white fat cells, and white fat cells are the predominant fat cells that we're missing in lipodystrophy. So this is why when we lose those fat cells, there is the potential to have low or almost non-existent leptin levels. What does this do? Well, leptin itself is important for regulating our appetite. A higher leptin level usually reduces hunger and increases fullness. In terms of energy use, it helps the body to decide how much energy to burn on a day-to-day basis. But it also affects other organ systems. It's involved in puberty and fertility, immunity, and aspects of metabolism. So, as we said, it acts as a signal to the brain. We release leptin from fat cells, it travels to the brain, and it's integrated into various different signals to affect hunger, energy use, and different hormones. The key point here is that leptin is a long-term signal about energy stores. It's not a meal-by-meal signal. So what happens when leptin is low? Well, as many of you will be familiar with, we go into starvation mode. So low leptin can happen in the general population if they are fasting or have significant weight loss, have very low body fat, so elite athletes generally have very low body fat, but also in lipodystrophy where the number of fat cells or the function of fat cells is reduced. The brain interprets this low leptin as we might be running out of fuel, so it's a bit of a panic stations, and this is an evolutionary response that has developed to protect us in times of starvation when there's famine. Unfortunately, we don't live in times like that now, and we have access to a lot of food. So when our body is telling us, oh gosh, we've got low leptin, that must mean we don't have food sources available, I'm going to turn on the signal to tell you you're hungry, so you go and hunt for more food. So your appetite rises. Your food thoughts can become stronger, so you get obsessive about food. You're thinking about food all the time. Energy saving, so the energy your body uses can drop, resulting in things such as a lower basal or resting energy burn. But it also shifts your hormones, so it changes thyroid, reproductive hormones, and this occurs due to energy shortage. So if you think about fertility, in an evolutionary perspective, it doesn't make sense for an animal to be able to get pregnant and use the massive amount of energy it needs to create a new life if energy resources are scarce. So the first and foremost thing is survival. And so your body is conditioned to turn off non-essential activities in the body in order to survive. So it's an evolutionary mechanism to protect us, but in lipodystrophy, it's being misused. So low leptin and metabolic strain, what does that mean? When fat tissue is absent or not functioning properly, as we said, leptin can be very low. That doesn't mean everybody with lipodystrophy will have low leptin. It's different depending on subtype and your individual kind of background genetics. But a lot of people with lipodystrophy will have low levels of leptin. The brain perceives this signal as a low fuel signal. So extra energy has fewer safe storage places. So even though we're telling the brain we have low energy stores and we need to eat, we have access to food, so we eat, but all that extra energy has to go somewhere. And because we don't have sufficient fat stores or functioning fat cells, the fat can build up around your organs. This is known as ectopic fat, as I mentioned. So this is not fat inside fat cells. This is fat outside of fat cells, finding somewhere to live. It'll just stick to where it can because there aren't any fat cells for it to go into. And this is what's dangerous because that's not the normal state of things. We shouldn't have fat stored around our organs. And when it is stored around our organs, it causes impairment to their function. So what people may notice is strong hunger. I think we've all been there. And a difficulty feeling full. So no matter how much you eat, never feeling satisfied. Feeling wired or hot after a meal. So this is not for everybody, but some people will have a real thermogenic response to eating food. So that's where the energy used to digest that food is creating heat. And obviously, the more food you eat, the more heat potentially you generate. And so that can give you hot flushes. And sometimes they're associated with happening after a meal. But also fatigue. The metabolism is under strain. And again, a lot of people in the community really struggle with fatigue, not well recognised. And until recently, even the medics didn't really appreciate the impact of fatigue in lipodystrophy. But actually, listen anecdotally to patients, fatigue is a massive, massive problem. But again, caveat, every experience is different, every subtype is different. Not everybody will experience the same thing. What can the clinicians measure? So the problems that we have result in things such as a fatty liver. So that's steatosis, so non-alcoholic fatty liver disease. High triglycerides, which can present a very drastic risk of pancreatitis, and severe insulin resistance leading to type 2 diabetes. It is called type 2 diabetes because that's the way the world understands it, because type 2 diabetes is resistance to insulin, and effectively that is what our diabetes is. It's a massive, severe resistance to insulin, but it's not quite the same as type 2 diabetes, and it's actually lipoatrophic diabetes. But if you say that, almost nobody will know what you're talking about. So it's just easier to say type 2 diabetes. These problems are driven by a combination of the low leptin, but also the ectopic fat that's stored but not where it's supposed to be. So the overheating and the hot flushes, what might be going on? So again, not everybody will experience this, but this is certainly something I've really struggled with since my diagnosis. to the point where when I was at university, I would constantly have my window open, and recently a friend told me that at university they were always cold in my room, but they never wanted to say anything because I was always roasting. And it's kind of having constant hot flushes, and it wasn't necessarily related to when I ate, it was just constant. And I know a lot of people really struggle with that, and it makes life really uncomfortable. So people can describe this differently. They usually mention an unusual kind of warm feeling, flushing or sweating. Sometimes that's associated with after eating, but not always. And there are lots of potential contributors to this. Again, evidence is limited and it's different per subtype, but anecdotally as well, it can be associated with having a larger meal. So this would potentially be that there's a higher thermic effect of the food, so the heat produced when you're eating. Lean muscle mass, so a lot of people have extra muscle, and resting energy use is higher in some subtypes as a result. Extremely high insulin levels, so as we mentioned, severe insulin resistance is very common in lipodystrophy, and the body's way to react, how it reacts to that, how it tries to cope. Excuse me a second. No, I thought I was going to sneeze. The way the body copes with that is by increasing its production of insulin. When I got my diagnosis, my insulin was 50 times higher than it should be, but my blood glucose was normal because my body was producing that extra insulin in order to maintain a normal blood glucose. Unfortunately, the pancreas, which is the organ that produces insulin, can't cope with that sustained pressure, the strain of producing all that extra insulin, and eventually it gives up, or at least it can't maintain the level of insulin it needs to produce in order to keep your blood glucose at a normal level. And that's usually when people have to start injecting insulin. Less subcutaneous fat may change the heat insulation and the heat loss through the skin. So generally I run hot, but when I get cold, I stay cold, and I find it very difficult to warm up because I've got no fat insulation. And I can see a lot of people nodding, you kind of experience the same thing. So it's one extreme to the other. And then there's other causes that overlap, so thyroid disease, menopause, infection, medication. So there's a lot to deal with. A practical tip here, if you find that you do get regular kind of hot flushes or uncomfortably hot feelings, keep a diary, a trigger diary. And it may not work, it may not reveal anything, but it might tell you triggers that you can then avoid. So for example, is it meal size or certain types of things that you're eating? Is it anything to do with the temperature generally? The amount of activity you're doing? Do you go for a walk after eating? Does that help, or does that make it worse? The time of day that you're eating, and keep a diary and then discuss these notes with a specialist, and maybe you can identify certain triggers that you can then help avoid and make it a bit more comfortable. So just briefly in summary, leptin is a hormone, signal from fat tissue to the brain about long-term energy storage. Low leptin acts as a starvation signal. Hunger rises a metabolism hormone shift. And in lipodystrophy, low leptin is part of why hunger and metabolic problems can be severe. And any questions? Yeah.
About lipodystrophy, the type 3 diabetes, that's what I don't know anything about that. I didn't know there was a different type of diabetes?
Yeah, so it's lipoatrophic diabetes, which essentially means diabetes caused by lipodystrophy or a lack of fat. It's very similar to type 2 diabetes in that it's essentially caused by massive resistance to insulin. But in terms of management, it's managed very much the same way. The difficulty with it is it's quite treatment resistant. What that means in reality is that we tend to need, for example, a lot higher levels of insulin if we're injecting in order to manage our blood glucose. So a kind of normal type 2 diabetic that doesn't have lipodystrophy may inject maybe 30 units a day. I inject 300 units a day, and that doesn't always manage to control my sugars. Some people are on thousands of units. So it varies from person to person and on the subtype. What it essentially means is it's just a bit more difficult to manage, and why it's important for your clinician to understand that you've got lipodystrophy and how it's different from type 2 diabetes, because often, and I'm sure patients will share, they get accused of being non-compliant diabetics. And that's not what's happening. It's just that their diabetes is very difficult to control. And that's why we're trying to raise awareness and understanding of lipodystrophy and how it impacts, I know you're hot, oh bless, how it impacts our metabolism in order that it's not only managed properly, but that clinicians are understanding and sympathetic to the fact that it's not that we're not compliant, it's that it's very difficult to control.
Yeah, I've been like nearly sick. I only got diagnosed last year.
Yeah.
So I've had uncontrolled diabetes since I've been in my 20s.
Yeah.
And they've all just blamed me for it. And everyone said, you're non-compliant, you're this, you're that. I ended up, it's been an awful journey to here now.
Yeah. I'm really sorry to hear that. That's awful, and you shouldn't have had to go through that. Unfortunately, it is a very common problem. There are people all in the room nodding along with you that are experiencing or have experienced exactly the same thing. It's unforgivable. It shouldn't be the way that it is. Unfortunately, that's what we're dealing with at the moment, but that's why we're trying to raise awareness to make sure that clinicians are aware of lipodystrophy and understand the complexities in treating it. Luckily, you have now got a diagnosis, so hopefully that will help in your management.
It's not actually. I'm struggling to get help, and nobody knows about it. I'm apparently the only one in the practice that has lipodystrophy, and there's no help for me because people don't know what it is. If clinicians don't know what it is, they don't know how to treat me. So it's very difficult. So what we will do, and we can talk after in the break, is to help you get a referral to Addenbrooke's. I have.
You have?
Yeah, I was there that's when I got diagnosed.
Oh, good. Yeah. So what we need is a plan to help your local healthcare providers work with Addenbrooke's to make sure you're getting the right treatment. Because obviously, if I'm not sure where you're located in the UK, but the Addenbrooke's is not necessarily on your doorstep. So you need local healthcare providers to be aware of lipodystrophy and help with your management. And they can do that by working with the team at Addenbrooke's. So
see, I've got all the comorbidities. I've got everything except pancreatitis.
Yeah.
So I'm like, I don't have one person kind of overseeing it. So I have to beg the GP for referrals to a cardiologist. And I've had a triple bypass. I've had everything.
Yeah.
And liver disease, all of it. But I have to say, look, I really need to see what, and they won't do it. They won't actually do it. They're like, because if the readings don't match, they're not gonna, they don't understand how the accelerated atherosclerosis and things like that are going on. So
and that's part of the difficulty of our kind of UK healthcare service, in the sense that we don't generally get treated holistically as a patient. We get put into boxes, silos, related to the different conditions that we're suffering, and there's often not a joined up approach, particularly in a situation like lipodystrophy, where potentially almost all of the conditions that you're struggling with are related to lipodystrophy and therefore each other, and there's not always that joined up thinking. And again, that's where we're trying to leverage the fact that we have a national centre of excellence for lipodystrophy that can not only support you individually but help support the clinicians that are local to you to think about lipodystrophy in the way that they're treating you. So I'm sure that things we could do to kind of improve that. It won't happen overnight, it'll take time, but getting the diagnosis is the first step. That doesn't mean the journey stops. It's still a hard journey, and it's still a long journey.
I think I talk and talk and talk. I've just sort of been on the borderline ADHD and that the spectrum. And I'm like 60 this year, so it's like I talk and talk. I say I've got this wrong with you, that wrong. It's like they think, oh my God, I have an hour-long consultations with my GPs. But things don't get resolved. They just talk. Well, they talk to me, which is nice. I appreciate that. But the sort of going to get each organ sorted is very difficult.
It's difficult. Hopefully we can help improve that. So as I say, you've got your diagnosis, so let's work with the Addenbrooke's team and see what we can do for you. Thank you.
Thank you.
I think there was a question at the back.
Sorry. Did that really awkwardly, didn't I? Sorry.
Thank you. Thank you. My daughter, I'm here with my daughter and my grandson, both got the lipodystrophy. But you've talked about leptins, which has helped me understand that. My daughter had metroleptin, which is a treatment, isn't it?
Yes.
Which was life-changing for her, but unfortunately it only lasted about 6 months. She developed a severe allergy to that. So I was just wondering if there's any other treatment in the pipeline.
Yeah, so this is a question we get asked a lot, and I know that the Addenbrooke's team are going to talk a little bit about some of the medications that are available to help lipodystrophy. As you mentioned, metroleptin is one of the only treatments available that is specifically there to help people with lipodystrophy. So as you might be aware, metroleptin is a recombinant protein, which basically means it's been produced in the lab as a replacement for the leptin that we're missing in the body. So a bit like when we inject insulin, that's been generated in a lab. It's human insulin, but it's been generated in a lab, and we use that to replace the insulin that's missing in our bodies. So it's a hormone replacement therapy. That is available for certain patients with lipodystrophy. It obviously depends clinically on your leptin levels and other factors. And the Addenbrooke's team are the only centre in the UK able to prescribe metroleptin, and they will be able to talk to you about it. Unfortunately, in some rare cases, we have an immune response, and people are no longer able to take the treatment. So I'm very sorry that you saw benefits and then you had to come off it. That must be very frustrating, particularly when you finally found something that actually helps. The difficulty with the rare disease is that in terms of the pharmaceutical industry, there's not a lot of money in trying to treat rare disease because there's so few patients that can benefit from the treatment. And so a lot of pharmaceutical companies are not doing research into rare disease or things that will help rare disease patients. There are companies that have rare disease departments and do help rare diseases. But again, as you may be aware, there are over 7,000 rare diseases. So while each individual disease is rare and there are few patients, there are a lot of conditions, and therefore the few pharmaceutical companies that may be focusing on rare diseases may not have ever heard of lipodystrophy and are focusing on something different. However, there are companies and research academics, some of which you hear from later today, that are doing research into lipodystrophy, and there are potential, maybe further down the line, but potentially will result in additional treatments. There's also efforts to look at repurposing current drugs. So there are lots of drugs that are developed for one thing that by chance are found to help a different condition. And there are efforts to look at repurposing existing drugs for rare diseases. I can't say whether or not anything's going to come from that, but hopefully it will. There is some work, again, as I mentioned, that's going to be talked about later today, looking at gene therapies as a treatment for lipodystrophy. Again, it'll be certain subtypes of lipodystrophy, which may eventually lead to all types of lipodystrophy, depending on whether they work, but it's going to take time. There are other drugs available that are not necessarily developed specifically with lipodystrophy in mind, but that can benefit lipodystrophy patients or some lipodystrophy patients, in particular GLP-1 agonists, which I think is going to be spoken about by the Addenbrooke's team later. So there are options. The best thing to do is to speak to the Addenbrooke's team because they'll know exactly what is available to prescribe. What we do as a charity is first of all, gather that information to share on our website. So there is information on our website, but obviously we're not medics. We can't prescribe anything, but we can inform you of the things that you might be able to ask for. And we also advocate for research and funding into finding treatments specifically for lipodystrophy. So if there is anything that we find in the future that may be a benefit, we will not only advocate for it, but we will also publicise that. But if anybody ever comes across anything that they find is helpful, let us know, because again, we're such a small community, the more information we share with each other, the more we learn quickly. So I'm sorry, I haven't got an answer for you, but there will be some other treatments in the future that may be of benefit, and there may be things now that can be done to help. Any other questions? One more here. It's the last question, and then we move on to the next.
Thank you. Well, first, just a sliver of good news, which is that my local consultant moved to a full-time teaching post, and before he left, he asked me to write a short piece to use with his students on a patient's perspective of having a rare disease. So, and I was able to say some of the stuff like, please don't think we're all non-compliant. It's very frustrating for me too. Yeah. So anyway.
That's fantastic. Well done.
But the question I wanted to ask was, on the list of things causing overheating, you didn't have pain. I find pain triggers it. Is it just me, or is that a general thing?
No, that can potentially be an issue for other people too. So it's just a rough summary. As I said, there's not a lot of research that's been done specifically in lipodystrophy to link pain and other aspects of the condition, but that is not to say that pain is not linked to feeling overheated. And actually, that's why we want to talk to you guys, get patient experience, because, you know, as part of this forum today, you might meet other people that experience exactly the same thing. And by gathering that information, we can talk to the clinicians and say, look, we're hearing this time and time again from our patients. So this is something that needs to be considered and looked at. So share. Okay, we're going to move on to our next speaker because we've got a packed agenda, so I don't want to delay anything. Next, I think we have... I think we've got Anna next. So Anna Steers is the consultant that runs the Lipodystrophy clinic at the National Specialist Centre at Addenbrooke's. And I'll hand over to you.
Morning, everyone. Thanks very much for coming. I feel a little bit like an intruder sometimes in these patient days, but I'm here to help. And so if you have any questions for me at the end, or the rest of the team, then do feel free to come and approach us later during the day if you want to not talk in front of the whole group. My name is Anna Steers. I'm a consultant in diabetes and endocrinology at Addenbrooke's Hospital, and I've been the clinical lead for the lipodystrophy service for I think about 13 years now, so time flies. And this is all our contact details. So what I'm going to talk about, can you hear me now? Yeah, is what is the service, what's new, a bit about the GLP-1 receptor agonists, and then I thought we would do a meet the team, because every year I can stand here and then the team sit there and then no one seems to know who everyone else is. So I thought if I could introduce the team to you, that might be helpful for everybody. And so we'll do that afterwards, and then we'll do some questions and answers. So the service is a highly specialised NHS service for adults and children. So it's quite unusual in that respect, because in the NHS, everything's I can't say the word, in little silos. And so the adults and children don't generally share the same service. And it was commissioned in 2011 by the National Specialised Commissioning Team, and they've been taken over by NHS England. And you may have heard in the news that NHS England is being disbanded. We're waiting to hear what's going to come next. I've spoken to the NHS England team, and they think it'll be the same team in a different building. But we haven't heard any details of that yet. So we're hoping that they'll stay. The team will stay intact. As I said, the service is based at Adam Brooks Hospital in Cambridge, which isn't necessarily easy to get to for people. And the funding is for people living in England. But if the patients are from Wales, Scotland or Northern Ireland, their local health boards can apply for funding. And we haven't had anyone turned down. And Professor Semple, who's in the middle somewhere over there, also sees patients with lipodystrophy in Scotland, in Edinburgh. So that might be easier for people in Edinburgh. So we have weekly clinics, and once a month we do 2 clinics a week now, because we've grown a bit. And we see around 70 to 90 new patients a year, 250 to 300 follow-up patients. So it's quite small in terms of NHS services, but it's grown a lot over the years. So, and we do the genetic testing and the biochemical testing, and then we offer specialised therapies, including dietary interventions, metroleptin, as we've heard about, the GLP-1 agonists. Increlex is a treatment for patients with a different condition. And we can offer high-strength insulin, which is 5 times stronger than normal insulin, and in some cases, insulin pump therapy. We also have a strong research team, and the service was really set up in the beginning by Professor O'Reilly, David Savage and Robert Semple, who are doing research in patients with insulin resistance. And so we have a monthly meeting where we all get together and discuss issues and patients. Everyone gets together, the dietitians, the nurses, and our admin support, Anne-Marie. And then we often also offer education. So we go around the country or online around the country these days, offering talks and education around lipodystrophy, mainly to healthcare professionals. And I thought this might be interesting to people. So this is our geographical spread of referrals. NHS England are very keen that there's equity of access to healthcare, which I think is a reasonable thing to want. So they're very keen for us to feed back to them where our referrals come from. And obviously, it's easier to get to Adam Brooks from the east of England and London. So we have a bit of a concentration of patients there. And we've identified places over the years where we're getting fewer referrals, like the Midlands. So we gave some talk in the Midlands, and we're getting a few more referrals. And I've invited myself to speak to the Manchester team, because we haven't had that many patients from Manchester. And also Nottingham, I think, is an area we haven't had as many referrals as we expect. So we're trying to make sure that there's equity in access. If you think that your area is not referring patients to our service, and there's a problem, we can go and give a talk. So this is my what's new slide. So we've had a few staff changes. Sam King is a research nurse. He's not here today, but you might come across him in the clinic. Aggie is a research fellow, and she's going to be speaking in a minute. And Ellie Wilbur, you might remember, Ellie's a paediatric dietitian, and she was in the service some years ago, went away and has come back. And so the good news is that Adam Brooks Hospital has now approved an additional consultant just for half a day a week. And the interview is in April. So this will be an NHS colleague to support me in the service, along with David Savage, who does some clinics as well, and the rest of the team, which is really, really good news, I think. So we're pleased about that. The other main news really is the GLP-1 receptor analogues. And I don't know if I can't believe anyone in this room has never heard of Ozempic or Mounjaro. So it's in the news all of the time. And these drugs were developed for the treatment of type 2 diabetes, and then more recently have been given a license for the treatment of obesity, so patients who have obesity who don't have diabetes. And also there's been a development from a once-a-day injection to a once-a-week injection, so they're actually really easy to give. And it's very unusual in that usually provision of medication in the UK is very strict, and so only doctors can prescribe it, and patients have to go to their doctor and ask it, and it has to be licensed, etc. But there's just been this massive expansion of availability of these drugs online, and you don't always know who you're dealing with at the other end of the computer, really. So I think some of these are legitimate companies and do have good processes, and some don't. Mostly the drug that you get in the post is the right thing, but sometimes it might not be, and you can't be sure. So it's a bit concerning that, patients might not be followed up very closely, etc. So the problem is that the NICE, who are the government agency that decide what drugs are going to be funded for who, have made some guidance on the funding of GLP-1 receptor agonists, and it generally says that these people have to be obese or overweight. So people with lipodystrophy on the whole, not everyone, but a lot of patients with lipodystrophy have a normal body mass index, so they're not overweight or obese. They may or may not have diabetes, and so we're struggling because we don't have our own budget to prescribe these drugs. We're struggling to ask GPs to prescribe them on our behalf, and really it's up to the GP. If they don't want to, because they're not comfortable, then they don't have to. So I've put in a policy proposal to NHS England asking if we can just prescribe them ourselves and cut out the middle doctor, and I put that in June last year, and I haven't heard back yet. And I think part of the reason for that might be that this restructuring of NHS England has slowed down a lot of the committee work, and there's other things that are in the priority list. So I did email them and say, look, we're having a patient meeting, in a couple of weeks' time. It'd be nice to have some news to share, but I haven't heard anything. So I'll let you know as soon as we hear anything back. But saying that, there's been quite a few patients now. I've asked GPs to prescribe with our supervision and help, and we're following the patients up, and they have prescribed them. So if you're having problems accessing GLP-1 drugs and you think you're eligible, let me know and we can see what we can do. So I haven't got anything about metroleptin here. The big update about metroleptin we've just heard is that the organisation that delivers the drug, Polar Speed, is no longer going to be doing that, and it's a different company is taking it over. But there shouldn't be any change. I think it's Sciences, if any of you know about these companies. I don't think there's going to be any change from the patient end. I'm hoping there's not going to be a lot of change from our end. But again, let us know if there's any problems, any teething problems. So now I'm going to introduce the team. So this is a photo of our team, past and present. So the photos are always getting out of date, so we're due a new photograph, really. And so the first person I want to invite up to say hello to you is Anne-Marie. I thought this would be like the Oscars, and we'd all get here and smile at you, but I think... So Anne-Marie is our administrator. You may have spoken to Anne-Marie on the phone. I don't know if you want to say anything, Anne-Marie. Do you probably need to...
I will be your first port of call into Adam Brooks. Either I will pick up your emails or your phone calls and then direct you to the best place you need to be. I also pick up all the referrals that come in and then send them to Dr. Steers, who will triage. I will then ring and book the appointment and the accommodation if you're travelling the distance. So if anybody has a follow-up appointment, always ring me and ask if you need accommodation to be booked.
Rebooking, if you can't attend an appointment date, please let us know, and Anne-Marie will do the best to ring.
I will do my best, but obviously because we are the only centre, sometimes if you cancel, you might have a 6-month wait to be rebooked, because we are completely, as we saw on the list, completely full. people are desperate to get appointments.
Anyone have any questions for Anne-Marie? No, you're off the hook. And I'm going to let the rest of the team introduce themselves. So, what's your next? I'll take some questions at the end if anyone has.
So, hi everyone, I'm Charlotte. We've put some photographs up on here just so. Oops. What do I do? What happened? I didn't push anything. That's it. So sometimes in these big rooms, we're out of context. You recognise the face, but you don't always know who that person is. So we just thought we'd come and put our photos up, and there's contact details here if you don't already have them. So I'm Charlotte, and this is Imalka. So I've been with the service for, I think, since the beginning with Anna, and Imalka has been with us for the last couple of years. Yeah. So there's 2 of us now, which is quite nice. We work different times, variable times. I usually have the days that I'm working on my email responses, but there's usually one of us around. So Imalka's just going to talk about our role.
As a diabetes specialist nurse, we are helping with education and information with if there's any insulin changes or any other like Libra or review, glucose review, things like that, and we help you. You can give us a call, and we have information we have provided earlier, our email address and stuff. And also we help with technology like insulin pumps and any glucose funding applications, things like that. And we are supporting with metreptin, contact people as a contact people if you need any advice with metreptin, or if you want to start, if you're going to start, we will provide the education how to do and everything like that. And we act as a point of contact of patients via email, my chart, and telephone calls, things like that. Yeah.
And then I've got another little what's new slide. So Anna's already mentioned about the delivery team that are changing. So I think it's the end of May that this will come into place. It shouldn't affect any of you guys, and hopefully it won't affect us either. So it should be quite a smooth transition, but it's just to let you know that it won't be Polar Speed anymore. It'll be Sciences, or there's another one, I can't remember the name of it. But we'll keep you updated on that. I just wanted to mention a little thing about sensors. I've put Libra, but didn't put Dexcom. So it can be a bit of a postcode lottery with the funding of sensors, which is a real shame. It should be the same for everybody. I know in Cambridge it can be really difficult to get sensors for people who don't have type 1 diabetes. But we're seeing more and more people coming to our service from around the UK who've managed to get sensor funding, which is great. So it's definitely worth just discussing that with your local services or your GP to see what they can do, what they can support with, and we'll support as much as we can. But we are our hands are a bit tied, but it's worth discussing that locally. And the other thing I wanted to mention is that if you ever have any faulty sensors, please do report it to the manufacturers, because the GPs are funded to prescribe depending on which one, either 2 or 3 sensors a month. So can't give you any extra. So if it's a faulty sensor, then the manufacturers should be replacing that. The NHS shouldn't be spending money on faulty sensors. And then just a little thing about hybrid closed-loop systems. So some of you may be aware of the developments in pump technology, where sensors are now linking to pumps and are able to talk to each other, and the pump will then respond by increasing or decreasing insulin according to the glucose levels sent to it via the sensor. which is amazing, brilliant developments that are coming in. Again, funding is restricted, so it's mainly the funding is for type 1 diabetes, but we are seeing some people coming through to the service who are using these devices, and they're working really, really well. We can apply for exceptional funding for people with lipodystrophy. It would be done by the local diabetes service, but we are there to support with that. Or if you're from our area, then it's something that we can do as well. So again, if that's something that you're wanting to talk to us about, then we'll be here. You can come and chat to us. If it seems to be something that we could do for you, then that's certainly something we can help with. I think that's all from us. I've put a little poster up outside, just if anybody's got any tips or anything that you can share with us, just put some notes on the post-it notes. We're trying to gather as much information as we can so that we can share that with other people too. All right, see you later. I'll hand you over to Catherine and Lisa.
Hello, so lovely to see all of you today. So for those of you who don't know me, hopefully most of you will either know myself or Catherine. So I'm Lisa, this is Catherine, and we're the two dietitians working in the service. So we just wanted to spend a couple of minutes just talking a little bit about our role and some of the things we've been up to for the last year since we maybe last updated you. So we're funded 1 day a week each for the service. So when you come along to the clinics, which are always held on a Tuesday morning or a Wednesday morning, there should hopefully always be one or both of us available to see you all in there. So we do try and catch up with you at that point. But we can also arrange sort of other follow-up with you. So even though we are only 1 day a week, we can be available on any days of the week that you might sort of need us. So if you think, oh, actually, I want to book a phone call in, and Thursday's the only day that works for you, then please do let us know. We can sort of sort that out. And we're happy to sort of communicate with you, email, phone calls. We do have a Adam Brooks My Chart now that you can send us messages on or give us a call. Always just leave a message if you do call, though. Don't just keep calling because it's not going to get picked up, but just leave us a message and we'll get back to you. And also, just a bit like with Charlotte, we've got a little room outside, and we've got a little information stall, lots of leaflets and just bits and pieces. So come and have a chat with us, come and have a look at what we've got. Just wanted to quickly sort of do a reminder. So obviously a lot of you are not local to Cambridge, and you're sort of scattered all over the place. So part of our role, a bit like the team in general, is to try and raise awareness and help support other clinicians who are looking after people with lipodystrophy as well. So hopefully you may have a local dietitian that you get on well with, but if you feel like they're maybe struggling with some of the understanding about what lipodystrophy is and why diet for lipodystrophy is so important and why that might be different for other people, then do let us know. We're happy to talk to them and send them information and have those conversations. There are a lot of local weight management options, so what will be available will be different in different areas, again, across the country. If you're not sure what is in your local area, then we're happy to try and do that investigation for you. You know, there's lots of things, there's much more now than there ever has been. So there's a lot of online services if you can't make it to group sessions. There are apps. There'll be a lot of local sort of services as well, sort of, groups and things like that. And again, we're happy to try and make sure that they're as appropriate for you as possible. It's important to remember, if you are thinking, or if you're trying and you're thinking, well, actually, some of this GLP-1 or metabolic surgery might be useful for me, or something I'd like to know a little bit more about, it's often important to be plugged into one of your local weight management services for that. So part of the funding criteria for things like that involve you having sort of worked your way up through the sort of tiers of weight management services. So again, it's sort of just worth knowing that when you are battling for these things. And if, often because things like Anna mentioned, BMIs supplies are understandably a lot lower, then we can help with sort of funding applications for those things. So we can help your local team put in those funding applications. If they need the right arguments to pop in there, we can sort of support with that.
Hi, I'm Catherine, so I've probably met a few of you, as Lisa said, work with her in clinic. So with regards to the GLP-1 medications, we've put together some dietary information, so if anybody starts on the medications, this will kind of complement it and hopefully give you some guidance on how to manage symptoms through diet. And not everybody gets all the symptoms, but it's just some information there. And they really, vary person to person. I think, like Becky was saying, with the hot flushes and things, it's really good to keep sort of food diaries, symptom diaries. You can see which things are triggering you. One of the main things is, because people can lose weight quite quickly, is maintaining activity and enough protein in your diet to keep muscle mass, so you're not losing muscle, too much muscle. So we've got information there that will hopefully complement if you do start on any of those medications. We did mention last year about a chapter we'd written, and we were hoping it will be published and out there, but it's actually coming in May. So we've kind of tacked on lipodystrophy onto a diabetes chapter. So this is a book that all newly qualified dietitians or people who go to university to study to be a dietitian expected to buy. It's a little bit like a little Bible for newly qualified dietitians. So hopefully that spreads awareness a little bit if they're reading through that chapter there, and we can also refer people to read that. Recipe book. I know last year everyone said about recipe books be really helpful. We have lots of different recipes, and we often direct people to different websites like Heart UK and things. We have been working with one of the companies to try and formalise it and put it all together in one place. It's not quite there yet, but hopefully soon. We've pulled quite a lot of the recipes from Heart UK with their permission. And then what we've tried to do is, rather than colour code it as sort of high or low, we've just tried to make them all suitable. Everybody's a bit different how much fat they can tolerate, so we've just written how much fat and carbs are in the recipes, and then it would be very much dependent on how much you're able to have. So hopefully you can then make choices depending on what is there. So I think we have 90 or so, don't we? We're hoping that will be made into like a format that you can take away, or a QR code that you can scan and then use on like an iPad or a phone. Pediatrics can talk now.
So yeah, do come and chat with us later.
So good morning, everyone. So just now a brief introduction of the pediatric team for the lipodystrophy in Cambridge. So it's myself. My name is Loredana Marcovecchio. I'm a pediatric consultant. I've been working in the service since January 2024. So I think by now I've met most of our families. And I work alongside lovely Sam, who is our specialist nurse. Sam, do you want to say anything? Okay. And then we've got, so in terms of our team, we've got Ellie, who is our dietitian. She joined the team just recently, although she worked in the team in the past. And then we've got Angela, who is our play specialist. And Hannah, who is our medical secretary, who is helping with the booking and sending appointments and so on. So the pediatric team is slightly different. I think it's essential to have a play specialist in the team. And what do? We work very similarly to the way that Anna is described. So generally we have some joint consultations. We have clinics twice a month. And we tend to sit together with Sam and our dietitian to work together with the families. And then we have got, as I said, Angela, who is helping mainly, young children when it's time for blood to be taken, which is never easy for anyone, particularly for children. So we are really grateful to Angela to help us support with that. And then during the appointments, we tend to do investigations. And then what we also provide is education and training, particularly when it's time to start treatments such as leptin, where Sam is involved with that. And then something else which is different, specific for children is sometimes they need some school plans, because they spend most of their time at school. So it's important that schools are aware of the condition. Also, it's important that, in terms of the food they get at school is appropriate. That is quite an issue. And then what we tend to do, given that, again, also our children, live all across the country, we tend to have in between appointments, phone call or video calls with the families, but also with the local team. And I think what I've found that is improving is really the relationship with the local team, because that is important, can avoid, traveling. So we always like to see all the children for the first time, and then in between we tend to have some joint video calls with the local teams, which work quite well. And just to show you, in terms of our pediatric service is relatively small. So we've got around 60 children and adolescents from the age of 18 months up to 16 years. And generally then after the age of 16, we transition children. We move across to Anna and her team. What you can see from this graph is how the number of referrals that we receive has increased over time. You can see that in 2025 we reached 20 new referrals. I think this is positive because it suggests that I think there is increased awareness of the condition. So I can see that my colleague, pediatrician across the country now get in touch with us more often with queries, which I think is really, really positive. I think this is the results of what, the Lipodystrophy UK does, but also of meetings. Now, in all the main pediatric conferences, there have been some sessions dedicated to lipodystrophy, which is really, again, very positive. And then also I want to share, it's always nice to share some stories. So we've got Rosie, we've got Zoe here today. So you've already heard about Rosie, but I always say we have other heroes. We've got Carmela, who is a young 11-year-old girl who got an MBE because she has got also another condition. And she has been raising funding for a charity. And then we've got also Ayla, who also, share their story on TV, which again, I think is nice to share stories. One thing that I forgot to say that in our team, we've got also a psychologist, and we are trying to work hard to have more input from the psychologist, which is very important, again, particularly in teenagers where body image is already an issue in general, so in this condition can be even more. And just I'll leave a few minutes for Sam and Angela, if you want to say anything.
Thank you for being really patient, Zoe and Rosie. We've got more interesting things to do over the other side. So if we've got anybody under 18 who would like to come and just have a chat, have a chill, we've got some bits and pieces over in the room that we had last time for you guys to do. You're welcome to come and go, but if you'd like to come now, we'll find some bits and pieces for you. I think that's it.
Questions for probably the adults team, if that's okay. But basically, obviously infertility is a big issue. I only found out about my lipodystrophy because of going through IVF and my triglycerides going absolutely wild, even though I had diagnoses of all the other issues like NAFLD, diabetes, and a massive spleen. I don't know if anyone else has that. And I was just wondering, is there any kind of resources available for IVF teams? Because I'm going through the genetic screening service at Guy's and St Thomas's, but I'm with a new consultant who doesn't know me as well. And when I've tried to say, don't give me estrogen, that'll make me really poorly, they kind of haven't really understood why. And I just wanted to know if that could be part of the service going forward, if it's not already.
I think that's a really, really useful point. I think the IVF services are a bit distinct from the NHS services in general, actually. So I think there is a bit of a divide in people with diabetes coming to the general diabetes clinic, as well, in the thyroid service. So I think the thing to do currently is to ask those professionals to contact me or my colleagues, and we can deal with it on an individual patient basis. So we can have a discussion about each patient. There is a project in place to write a paper about lipodystrophy that presents into different specialties, and I think obstetrics and gynecology are one of those specialties, but I'll make sure that it is, and it's going to be a case-based, I think Professor Semple's taking part in the project as well, so that we can reach out to different specialties, because that is an area where I think we have educated the diabetes and endocrinology specialists quite well, but I think dermatology, obs and gynae, etc., you know, it's a rare condition, and we have work to do. So thank you for raising that.
And I forgot to ask, is there any issues with taking any of the drugs that have been mentioned whilst you're trying to get pregnant?
I think that would be something to deal with on an individual level. Metroleptin is not licensed in pregnancy, so we wouldn't recommend taking metroleptin in pregnancy. Saying that, some patients have been on it for many, many years and have decided to stay on it and have done okay. But the other drugs, I think it's a discussion between us and yourself or the patient. Okay. But, you know, just contact. I'm happy to take any questions by email or my chart. I can help. Yeah. Any other questions?
Kind of on a similar note, actually,
Yeah.
and to do with sort of fertility treatment, that obviously if you know your genetics, you can then get screened for it. But if you don't, you can't, because if you're still waiting to find that answer,
yes,
you can't be screened for it in that way. But
yes,
you know, as part of that service, when I've gone through it, they have said to me, "Oh, because I've always been told I had PCOS from a young age, but when I went through the fertility service, they were like, you've got similar to PCOS, but we don't think it is, and we have no idea what it is." And I think that's the first time that anyone's ever said that to me, because PCOS and diabetes go so hand in hand. So I do really completely support what you're saying, is the fact that there isn't that understanding, particularly of hormones generally in this condition, and just how it can impact you, and even just different types of estrogen can be different.
Yes.
So I think some real understanding about, you know, and how you're, even in diabetes, how as you get older as well, when your kind of hormones change, that completely changes what your insulin needs are. I think sort of looking at that would also be extremely helpful for people going through this.
Yeah, thank you. I forgot to say that, you know, high dose estrogen can cause the triglycerides, the fats in the blood, to go up higher in someone with lipodystrophy. And so the monitoring throughout pregnancy or through IVF process might be slightly different than it is routinely. So, but I do think it's such a rare condition that we can't expect every single obs and gynae specialist to know a lot about it. And so I think if you ask them to contact the team here, we can help, I think, on an individual basis probably. But yeah, raising awareness is yeah, you're right. Any other question? Yes.
Hi, I'm interested in retatrutide. It's a new drug that's, I don't know when it's going to be available in the UK, but it looks really promising for what I've seen. It's on the GLP ones. Have you heard of that?
I think
yet?
is that the triple?
Yeah.
So it contains 3 different hormones.
Yes.
I don't know where that is through the NICE process. I've heard it'll come through.
It wasn't available. I keep asking about it because I've sort of followed America and their treatment, and then that seems very good, and I just wondered if there was any new news about it.
So not yet, but
No.
you know, these things appear on the market, and they might be available privately before they are through the NHS.
Yeah.
So as far as I know, I certainly haven't prescribed it or recommended it for any patients yet, but it's on the horizon. Any other questions? Any questions for any of the team at all? No? Okay, I think I'll hand over to, who's next, Omar?
How do we get this? Hello, everyone. It's nice to be here again. This is my second year here. I was here last year, and I guess before I start, I just have to say I was really inspired by some of the talks and some of you guys. And so, you know, I think you should all give yourselves a round of applause. So I'm just going to talk about what happens when obesity treatments meet. It should be partial lipodystrophy, to be honest, because that's sort of primarily what I've been focused on. So just a bit about me. So I was actually a gastroenterologist and hepatologist by background. And then in 2023, I joined Professor Savage as his research fellow, where I've been involved in the low-energy diet study. I'll talk a little bit about that. So I've been working with Professor Savage and Dr. Steers with the National Severe Insulin Resistance Service. So I'm just going to talk a bit about some of the alternative treatments to partial lipodystrophy. So I guess to start, the low-energy diet study. So this really was built on a large randomized control trial that was done up north. So it involved around 49 GP practices. And they got sort of a whole bunch of patients with type 2 diabetes. And what they did was they put them on a low-energy or a liquid diet. And this was for around 3 months. And actually what they found by the end of the study, which was 1 year, was that in almost half of the people that took part, they were able to reverse their type 2 diabetes or to put their diabetes in remission. And so what we aimed to do was to do the same thing, but in people with partial lipodystrophy. So the main aims were, number one, to prove that it works, and number two, try to understand a little bit about how it works, and then, most importantly, try to improve metabolic health in people with partial lipodystrophy. And so we started to recruit people with partial lipodystrophy and diabetes. They had to have a HbA1c between 53 and 108, and they had to have a stable weight for 3 months. We were looking for very keen, enthusiastic individuals that were highly motivated, because it's really difficult. So if you imagine for 12 weeks, you're having a liquid-only diet. I did try it for a couple of weeks. I'm a big proponent of trying things that you prescribe to your patients, and it was certainly a challenge. Nevertheless, we were able to recruit a total of 10 people, of which 4 unfortunately dropped out, but 6 did complete the study. And so the study itself, it had 4 sort of big study visits where they'd stay at our research facility overnight, and then 3 smaller visits. And so the first 12 weeks, the participants were taking 800 calories a day, so just pure liquid diet, which was 4 sachets. And then after the 12th week, we slowly started to reintroduce food. And then by the end of the study, they go through sort of a weight maintenance phase where they're just having sort of regular meals and trying to maintain all of the weight that they lost. In terms of the main study visits, the participants would come to the research facility, would check their weight, BMI, waist circumference, hip circumference, etc. In the first 2 visits, so baseline and week 12, we did a fat biopsy. Also, to look at where the fat was distributed, we did a body composition scan, so a DEXA scan, and that tells you where all of the fat is, under the skin and around sort of the organs. And then we also did an MRI scan, and the MRI was to look at fat in the liver and fat in the pancreas, because I'm sure, you know, many people with lipodystrophy have fatty liver disease. And we provided all of the meal replacements, so there was lots of different options. There was things like vanilla shakes, banana shakes, chocolate shakes, and then some people loved the porridge. And then for dinner, there was different types of soup. So you could have 4 of these a day. And if you look here, this is week 12. And if you look at all 6 participants, really, in terms of weight change, was really drastic. So around the participants were losing around 20% of their body weight by week 12. I think it's really important to point out 2 participants. So this participant, these 2 in green, and if you look at these 2 in purple. So the 2 in green, you can see after week 12, their weight loss continued, whereas the other 2 in purple, they started to regain all of the weight. And the difference between these 4 participants was that the bottom 2 were given tirzepatide at week 12, and the top 2 weren't. And so when we introduced tirzepatide, you could see that they were able to continue their weight loss. And this, of course, transpired into a significant change in HbA1c. So in almost all the participants, by week 12, we were able to reverse their diabetes. So they went from being diabetic to a normal HbA1c. And this was statistically significant. This is just a picture, just to show you sort of an idea of sort of body composition. You could see the yellow is all of the fat, and the red is the high amount of fat. And this is baseline, so before the study, and this is at 12 weeks, so at 3 months. And you can just if you just look at it, you can see a really remarkable difference. And then what about liver fat? So here we have 3 participants. So you have the blue, the light blue, and the green. All 3 are individuals. And then the orange is the liver fat. And the line at the bottom there is marked at 5%. So fatty liver disease is characterized as more than 5% of your liver having fat in it. And so you can see in all the participants, by sort of by week 12 and the end of the study, you could see that the liver fat reduced substantially. And actually in the 3rd participant, there was no liver fat. And in the 1st participant, there was very little. So there was clearly a lot of loss of fat in the liver as well. And so I guess a little bit about tirzepatide or Mounjaro, because I know that's already been talked about, and it's sort of all over the news, and everybody talks about this drug. It's a great drug. And so I guess in terms of lipodystrophy, the first sort of paper that came out was this one in the New England Journal, which just described 2 individuals with generalized lipodystrophy. There was a 64-year-old woman and a 23-year-old man who were both given tirzepatide. And actually one of them was on metroleptin. And after treatment with tirzepatide, there was really a drastic improvement in their diabetes control. And actually one of the individuals was able to stop metroleptin completely. Following this, a group in the United States published their paper, and this involved 17 individuals. 14 had partial lipodystrophy, and 3 had generalized lipodystrophy. And again, in their study, they found really statistically significant reductions in HbA1c, triglycerides, as well as BMI. And then more recently this week, we've just published our paper, which is the largest to date. So we looked at 40 people with partial lipodystrophy from our service who were prescribed tirzepatide, mostly through their GPs. And we looked at a sort of median follow-up of 9 months. And again, in those that were treated with tirzepatide, there was really a substantial, statistically significant reduction in weight, BMI, as well as HbA1c, as well as serum triglycerides. And interestingly, although the HbA1c improved so much, there was actually a statistically significant reduction in insulin. So these participants were actually needing, these patients were using less insulin than they were before the tirzepatide. It is important to note, I'm not sure if you can see this here, but actually in the cohort that were given tirzepatide, the median weight was 91 kilograms, or BMI of 31.5. So these weren't sort of the lean lipodystrophy patients. So it's still unclear in patients who aren't in the overweight or obesity range whether tirzepatide would be beneficial. I think it's important to mention, although there's a lot of positive things with tirzepatide, it's certainly not a drug that you should, I wouldn't encourage anybody to go and get on it privately. There are complications. We did have one person who had pancreatitis and they needed to stay in hospital for 10 days following tirzepatide. So it is important, if you do want to get on tirzepatide, that you speak with your consultant. Additionally, we know that with sort of rapid weight loss in people with diabetes and rapid improvement in their glycemic control, that can sometimes worsen any retinopathy. In our group, there were 3 individuals who had worsening of their retinopathy. There were 3 that did get better, so it's still unclear what sort of the effects are in terms of retinopathy for anybody who has that. I guess lastly, I just wanted to talk a little bit about bariatric surgery. So there really isn't much literature in terms of sort of the effects of bariatric surgery in people with partial lipodystrophy. So there's one case series which involves 3 people who underwent bariatric surgery. And other than that, there's just a couple of case reports. So there really isn't any data in terms of how beneficial it is in people with partial lipodystrophy. So more recently, we've sort of worked with some collaborators across Europe, in Spain and in France, and we've been able to collate around 23 people with partial lipodystrophy who have undergone bariatric surgery. This looks very wordy, it's not very clear, but essentially what we found was really drastic improvements in weight, HbA1c, serum triglycerides, and reduction in insulin. So it's it clearly is extremely beneficial in people with partial lipodystrophy. But again, similar to the tirzepatide, the people that we're looking at here are people with a median BMI of 37. So it's unclear for those with a lower BMI how beneficial bariatric surgery will be. And again, bariatric surgery, ultimately, it's an operation, so there are complications. And there's 2 key things when you look at complications. You look at early complications and late complications. And with early complications, these are complications that occur within the first 30 days. And so what we found from the 23 individuals was there were 4 cases of early complications. 1 was bleeding, 1 was an injury to an organ, and then there was 2 cases of infection. The data here is similar to what is with the sort of average population. So there isn't anything striking, but it is important to highlight that there are risks with surgery. And then we looked at sort of late complications. So there were all different kinds of things that people are experiencing. So things such as iron deficiency anemia, vitamin D deficiency, hair loss, as well as sort of psychological changes. So 6 people from the 23 had depression, but actually when we went back and looked at the data, 5 of them had depression before the surgery. But again, it's just important to highlight that, bariatric surgery is an option for some, but again, it does carry risk of complications. And I think that's everything. Thank you very much.
Thank you very much. It's always good to hear about the research and a kind of update from where you spoke about last time. I was just curious, the person in the diet replacement or meal replacement study that had the GLP-1 agonist that had pancreatitis, had they suffered pancreatitis previously?
Possibly. It's unclear. So that individual did describe a few episodes in the past where they had sort of sudden abdominal pain, but there was no formal diagnosis of pancreatitis in the past.
So it's not necessarily attributable to the treatment?
It's not necessarily attributable, yeah.
Hiya, just a question about the GLP-1. So when you obviously research and you see that, I'm going to call them normal people, will go up in milligrams with the GLP-1, did you find with that group that there was a baseline of what worked as a percentage of milligram?
It's really interesting. So one of the participants on the low-energy diet study who continued to lose weight went from 2.5 milligrams, so you go up by 2.5 milligrams, so that's the starting dose, and the maximum dose is 15 milligrams. That individual has been on 5 milligrams for months, and they've not needed to increase the dose. So there are 2 sort of ways to approach it. One way is just to keep increasing by 2.5 every 4 weeks until you reach the maximum dose, and all the studies show that the maximum dose is where you achieve the most weight loss. The other approach, I guess, is a patient-directed approach, which is sort of what I sort of followed, which is the patient takes the lower dose, and if it's working, stay on the lower dose. If it's not working and you need to lose a bit more weight, then we go up in dose. And of course, you know, the higher the dose, the more the side effects. So things such, and predominantly they are gastrointestinal, things like constipation, acid reflux, abdominal pain, etc.
Just wondered, because obviously our body fights everything.
Yeah.
So does it fight this? And is there a, you know, unfortunately we have to go to the maximum dosage to get...
No, you don't necessarily need to. So you may find that actually you're losing a lot of weight on 2.5, but there will come a point where it will sort of plateau, and then you can go up to 5 milligrams. So you can do it that way, or you can just go up every 4 weeks.
Thank you.
So I've been on the Mounjaro for like, I don't know, 2.5 years or something. I'm on 15 milligrams. I haven't had any weight loss. I've been 62 kilograms for about 4 years. And I've never been eligible for any of the low diets and that, because my BMI has never been large enough. I've only got diagnosed in August last year, sorry. So they've looked at me as a diabetic. So I've been diabetic since I was 20 and insulin resistance in puberty. But I've never been eligible to try that. And I really wanted to do the low calorie diets, and I'd asked the doctors about it. And is there a possibility I could start a trial to see about joining like that? Is that a,
yeah, so
is that quite a...
So I guess a couple of things. So we're no longer recruiting for the low energy diet study. It's sort of pretty much finished. But I'm sure if you sort of speak to Lisa and Catherine, perhaps they can direct you in terms of what other options there are. In terms of the tirzepatide, you said that your weight's been stable for sort of 3 years. You've not lost weight, but no. You've been 62.
Yeah, but I'm not as hungry. That's why I'm on it.
Yeah.
Because I'm not as hungry.
Yeah. So I guess my point is, it might not be that you're losing weight, but you're not gaining weight. So it's stopping you from gaining weight, which is still sort of some benefit.
Which is a result. My HbA1c was 129 2 years ago, and they said I've got end organ damage. And since being on the Mounjaro, it had that. I don't know what's going on, but I feel, okay as I can. But also the retinopathy, they wouldn't give me Ozempic. This is 10 years ago. I asked for it, and they were like, "No, you've got retinopathy. It's too risky with the Ozempic." And then I no longer have retinopathy, and so that's 2 or 3 years on Mounjaro at 15 milligrams, and I don't need to go every 3 months to get lasered anymore. It's like just a yearly check.
So it sounds like it has been beneficial for you.
Yeah, but then we're all individual, and it all is different, isn't it?
Yeah. Any other questions? Okay, thank you very much.
Oh, yes, please. Thank you. Hello, so my name is Agi Jakubowska, and over the next 10 to 15 minutes, I'm going to tell you a bit about a new area of research in lipodystrophy. So who am I? I am a medical doctor, a specialist registrar in metabolic medicine and clinical biochemistry. So last year, I joined Professor O'Reilly's group at the Institute of Metabolic Science as a clinical research fellow. And I am starting a PhD project looking at something called adipose tissue extracellular matrix. So this can be described as sort of scaffolding around the fat cells. And I specifically want to understand what happens when the scaffolding malfunctions, because someone might have certain genetic mutations, and how that can lead to then development of severe insulin resistance and lipodystrophy. So what actually is adipose tissue extracellular matrix? Well, it's this supporting scaffold that surrounds fat cells, and it helps hold them in place and allows them to expand and function properly. It is divided into two components. So we have something called basement membrane, and it's this sort of thin layer around each fat cell, and it helps it sort of stay intact and function. And then we've got something called interstitial matrix. So it's this sort of looser network of cells, and it's made of fibers, so collagens and elastins, and it gives sort of the fat tissue the strength and flexibility. And I hope you can appreciate from this diagram that it's quite a complex system. So there are loads of different components that make up this extracellular matrix. And what we are finding is that increasing evidence suggests that if some of those components are missing or not working, then the support system breaks down. And we believe that when that happens, fat cells can't function normally, and that can lead to problems with fat storage, insulin resistance, and in some cases, lipodystrophy. So recently, our team, along with collaborators from Germany and Brazil, have discovered a new novel type of lipodystrophy due to LAMA4 mutation. So LAMA4 is a protein found in the basement membrane of this adipose tissue extracellular matrix. And what we have found is that if you have mutations that don't make LAMA4 function properly, you develop partial lipodystrophy with severe metabolic dysfunction. So we have now found 4 individuals across the world from 3 different families who have this partial lipodystrophy and severe metabolic dysfunction, so high triglycerides, pancreatitis, diabetes associated with this condition. And we are currently waiting on a peer review to have this new discovery published. And of course, following on from that, we wondered, is this just LAMA4 that this is restricted to, or is there a wider effect of the extracellular matrix in lipodystrophy? So to explore that further, one of my colleagues from the lab, Sam Lockhart, analyzed rare genetic changes in extracellular matrix genes, and he actually found 5 genes that seem to be linked to development of more sort of central, so more fat around the tummy, sort of distribution of fat. So on this slide, each dot is a gene that helps sort of build this support structure around cells in general. And on the left-hand side, there are 5 genes that are only active in fat tissue. And on the right, there are genes that are not. So I hope what you can see is that the genes that are active in fat tissue show a clear effect. So when they are damaged, the fat is more likely to be stored around the tummy. And a couple of those genes that we identified were collagens, so COL3A1 and COL5A3, which I will talk about a little bit more in the next slides. But the key message here is that changes to the extracellular matrix, so this scaffolding around fat cells, can directly affect where the fat is stored around the body. And another thing that Sam looked at was sort of more genetic studies involving thousands of people. And he found the same pattern with more common genetic changes. So many of the genes that are linked to where people store fat are also involved in this sort of scaffolding around sort of the body's structural support system, so the extracellular matrix. And in fact, these structural genes were about 10 times more likely than other genes to be linked to fat distribution. So this suggests actually that the fat tissue, the way the fat tissue is physically supported, plays a very important role in how fat is stored and our overall metabolic health. So just going back to COV5A3, this was one of the 5 genes that we have identified. So our colleagues from Queen Mary University in London sort of analyzed genetic data from 45,000 people from Genes and Health Study, which is
Welcome back. Can you hear me? There we go. Hi. I hope you're all feeling refreshed. I'm going to introduce you now to Dr. Emma Waite. She's a research fellow at the Centre for Appearance Research.
Wonderful. Thanks very much. Hi, everyone. Thanks very much for having me. I'm Emma Waite, and I work at the Centre for Appearance Research, which is based at the University of the West of England in Bristol. And today I'm going to talk to you a little bit about the Visible Difference Support Hub, which we've created. It's essentially a website, and it's all about providing free evidence-based resources for people who are impacted by visible difference. Lovely. So, I'm a research fellow and a health psychologist, and for people who maybe haven't heard of the centre before, we are the world's largest research centre that focuses specifically on appearance psychology, so kind of anything about the way that we think and feel about how we look. So at the centre we kind of have 2 teams, I suppose. One is primarily focused on body image research, and that can be in people with or without visible differences. And then the other team is focused on visible difference research, and that's the team that I'm in. So when we use the term visible difference, we mean any condition, injury, or treatment effect that can alter a person's physical appearance. So something like lipodystrophy. And I guess the kind of main 2 areas that our visible difference team focuses on are firstly trying to kind of understand more about people's lived experiences of living with these conditions and injuries, trying to understand more about their support needs and providing support for those individuals. And then the second area is really kind of societal level change. So trying to improve people's attitudes towards people who look different, trying to reduce stigma, and trying to improve kind of inclusivity and acceptance of a diverse range of appearances. So as I mentioned, I'm going to talk about something called the Visible Difference Support Hub. So we, over the course of kind of several decades, have been developing resources and also evaluating those resources, so trying to make sure that they're safe and effective. And what we've done now is we've taken all of our resources and we've put them in this central location so they're really easy to access. And this location is called the Visible Difference Support Hub. So it's actually a website. You can see it at the bottom there, just visibledifferencesupporthub.com. And if you go on there, it's relatively easy to access. We've kind of created it with lots of input from people with lived experiences, and we've worked with the Appearance Collective charities, so Lipodystrophy UK is one of those. And everything's kind of hosted in this one central location. So as I mentioned, they kind of focus on one of those 2 avenues of either providing support to individuals or challenging stigma. And just to kind of emphasise as well, they're all evidence-based, so they're based on research, and they are also evaluated to make sure that, yeah, they're safe and they're effective. We do on there have what we call generic resources, so they can apply to people with any different type of visible difference, because even though we know that conditions are very different from kind of the physical health point of view and the physical implications, we do tend to find quite a lot of similarities in the psychological and the social experiences of people with different conditions. We do also have a few condition-specific resources on there as well. And yeah, as I mentioned, it's the website itself and all the resources on there have been developed with stakeholder input. So I'm going to kind of talk a little bit about the actual development of the website, and then I'm going to give you a few examples of the resources that are on there. But please do feel free to go onto the website, have a look around. It's all quite easy to navigate, and yeah, we've had a lot of input with kind of making it really accessible and everything. So just to highlight as well, the resources that are on there have all, it's all stuff that we've been involved in at the centre. So if there are other research centres or other people that have developed things, they won't be on the support hub, just to flag that. And it is also a live website. So the stuff that's on there is stuff that is kind of relevant now. If anything gets discontinued for any reason, it's taken off. But that also means that as we keep developing and evaluating things, they'll also be added. It's completely free to use. There's no login or anything. You can literally just type in the website and then you can download or look at them online, whichever kind of works for you. And the only one that's not free is a board game, which has to be bought from the people that have designed it and made it. And there's a range of different things on there. So there are resources that are aimed at adults who have appearance-affecting conditions and injuries. There are some that are relevant for parents and carers of children who might have a visible difference. There's some for young people, and there are also some for professionals as well. So that's things like teachers or health professionals. And this is just a little insight into kind of the creation of the actual website itself. So we work kind of all the time very closely with the Appearance Collective charities, but for this particular project we had input from 12 different charities, and they gave us lots of advice about kind of the tone and the language on the website, what kind of imagery we should use, and the name, fonts, so kind of lots of different elements of that and the accessibility overall. And these are some of the images that are actually on the website as well. So these are some of the kind of cross-condition resources, and as I said, I'll go into detail about 5 of these in a sec. And then we do have some condition-specific ones, but we don't at the moment have any lipodystrophy-specific ones. So this is what it looks like on the home page, and again that link is up the top there. So you can see there's kind of a bit of an intro, and then there's each of these sort of drop-down menus which you can filter through the resources. So I think if I press this button the video will play. There we go. So yeah, you can see kind of browsing, and if you wanted to filter depending on who the resource is for, you can do that. And then each resource has its own page as well, which looks a bit like this. So this will give an overview of it. There'll be like a link to the resource itself. We also have a podcast at our research centre, and often there's a podcast episode that's associated with the resource. So kind of trying to present that information in a few different mediums. And then if there's kind of any journal articles or anything published, that's also linked there, but we've kind of put everything in quite accessible language, and you can sort of find out what team members were involved in making it. You can read sort of testimonials and things like that. So yeah, and there's a little accessibility pop-up as well if you wanted to kind of change what it looks like when you're going through it. So I've picked out a couple just to very briefly highlight a few of them, a couple that I thought maybe would be the most relevant. So the first one is called More Than My Appearance, and this one is a writing program, and it involves 3 different writing tasks, and the idea is that you complete them over the course of a week. And on the support hub, there's like very extensive instructions and kind of how to do each of those tasks. And it's really focused on promoting what we call body functionality. So that's when we kind of learn to appreciate what our bodies can do for us and move away from kind of really centering what they look like. So yeah, there's lots of sort of guidance on those different exercises, and each one takes somewhere between 15 to 20 minutes. And they can be done straight online onto the PDF version of the resource, or if you did want, you could download it and print it off. Then we have an app that we've created called Act It Out. So there's a link to kind of be able to download that from Google Play or the App Store. And that one is for anyone who's over 16 who has either psychological and or social challenges from looking different. And it's based on something called acceptance and commitment therapy. So that's very evidence-based now, and one of the key kind of goals, I suppose, of acceptance and commitment therapy is helping people to do more of the things that are important to them, so they can kind of have more of a fulfilled life and reduce the barriers that come with some challenging thoughts and feelings about appearance. So if you really wanted to go swimming while you're on holiday, for example, but you're worried about your appearance, that approach can help you navigate some of those challenges so you can do more of those things that matter to you. And that one has got 6 different sessions, and they're about 30 minutes each. And again, you can just do them straight onto the app. It's designed to all be done on your phone. And it's really about, developing some skills to manage those challenges and helping you to live well. And there's a few examples up there of specific things that it might help with. So it could help you become more aware of your habits. For example, if you are constantly looking in the mirror, constantly checking your appearance, it can help to become aware and reduce unhelpful behaviours as well, and be more present with your kind of environment. It can help you identify some of your values and your valued behaviours, and then recognise where maybe you might be avoiding some of those and how to combat that. And then also goal setting, which again would be designed to be done in line with your values. And then we have one called Loving Action, which again is based on that same therapeutic approach. And this one's a podcast series, and it's really focused on supporting people to navigate intimacy and romantic relationships. Because we know from the research that can be really challenging, and that has come up a lot over the kind of years that we've been doing this work as something that's really hard for some people. And that one is 7 episodes, and they cover, again, things like identifying your values, managing some of those thoughts and feelings that might come up that might get in the way of some of the things that you'd like to do in your life, how to communicate in relationships. So that might be things like disclosing about your condition, how to navigate some of those conversations, and also navigating intimacy as well, because we do know that a lot of people can feel anxious about sex and intimacy. And on the podcast, we've also incorporated the experiences of people with lived experience. So we have a couple of researchers, and then we have some characters, and they're voiced by people with different conditions, and they talk about lived experience of relationships and visible difference. And then there are also sort of scattered throughout the episodes links to things like YouTube videos. We've got some worksheets and things like that, so you can kind of practice the skills in your own time as well. Then we have a resource that's aimed at children. So this one is the board game that I mentioned, and it's for children aged 9 and above. So what they kind of do in the board game, they divide into a couple of teams, and their goal is to kind of get to the finish line of the board spaces. And along the way, they have different cards that they pick up, and the cards kind of help them have discussions and do activities that are all about exploring their thoughts and feelings about body image and about appearance, and also about appearance differences and diversity. And yeah, it's about 45 to 60 minutes, and what we found is that it can help to increase children's knowledge of appearance-related issues, so building kind of some of that awareness. And then I'm pretty sure this is the last one on my list. This is the Visible Difference Parenting Toolkit. So this one's specifically aimed at parents and carers of children who have visible differences. We know that there's kind of been a lot out there about supporting their child, but less about kind of going beyond that and actually thinking about what that experience is like for the parents and carers and how that can feel. So we've tried to address that. So this one does cover supporting your child, but it also talks about looking after your own well-being as a parent and carer. And there's kind of two main sections. So the first one is about managing difficult thoughts and feelings. And then the second one is some of that really practical guidance and advice on specific scenarios that might come up if you're parenting someone with a visible difference. And again, these are things that have come up in our previous research when we've talked with parents and carers about the kind of challenges that they might experience. So managing reactions from other people, how to kind of support their child through experiences of teasing and bullying at school, how to have some of those conversations with their child about their visible difference, and then also managing healthcare appointments, which could be similar to some of the things that we've kind of talked about today already, or also things like supporting your child from kind of transitioning from child to kind of managing their own condition and starting to advocate for themselves in their appointments. So that is pretty much it. Just to reiterate the website up there. I've also got some cards with me if anyone wants kind of a card that has a QR code. I can give you that, but it's also there and it should come up if you either type that in or just Google it. We also, although we've kind of developed it with a lot of input, we are still always wanting feedback, knowing how we could improve it, very open to making changes still. So I've added the kind of QR code for the feedback survey as well, and if anyone did want to complete that, then you would also have the opportunity to opt in to win a £25 thank you voucher for doing that. And then my final plug is just to say that every couple of years we do this conference in Bristol, which is hosted by our research centre, and it's all about the psychology of appearance, and it's actually coming up in June. So just added that detail in case anyone was interested. Thank you.
No questions? Thank you. And so now, can I introduce you to Professor Rob Semple? He's from the University of Edinburgh.
Thanks, Siobhan. You can tell that you pressed me for a title when I was in the middle of a clinic and had to come up with something quite vague, which didn't really tell you what I was going to talk about. But it's lovely to be here. Always lovely to see colleagues, see people with lipodystrophy and their families who I've met. So I don't have a particular job today, so I thought what I would do is reflect a little bit about our community, the community of doctors and researchers and patients and families and everybody else involved in what actually matters in lipodystrophy. And I think to do so with the purpose of making sure that together we're really effective and muscular in making things better together, and that we understand each other's roles, and you know, we're like a family, if you like. And like all families, you know, I love my family dearly, but also amongst them there's some of the most irritating people in the world. And as a community, we're like that too. We all have different roles. So the hats that I wear in this community are slightly crazy-looking doctor. You know, and doctors you all know, you love and hate them. They're your allies. They're prone to obsessing spreadsheets of, biochemical results. They don't always address all the things which bother you every day. They use pompous Greek, Latin language. All that stuff. So I do that. I am a scientist as well. So I start with people I meet with rare conditions, try to find the cause, often genes, but not always, and then work with scientists in my lab to really try to understand how it all works, and out of that, how we can make things better in the end. So that's the world of the geek. And in my world, geek is a compliment, by the way. So, and we want to have the best geeks, if you like, in the lab, doing the really basic stuff. But, blimey, their language can be difficult to understand as well. And also, the people who train in that world of science, they're training in how to speak to other people in the world is, you know, is getting better, but it's not that great. And it's a two-way thing. So if you find yourself having talks either from doctors or researchers, and it's just gobbledygook, tell them that. It's, you know, it helps them, it makes them better as well. But I'd like to say my other role is also a human being. In other words, I don't have lipodystrophy, and I don't have family members with lipodystrophy, but I've got, sometimes I'm a patient, I'm a person, I do have family members with other stuff, I worry about them. And I think one of the most important things we have to keep doing as doctors is, even though we can't really feel the lived experience of lipodystrophy, we learn a lot about it from speaking to you, we have to do our best to imagine what it's actually like to help things along. So I did mention north of the border, and I think I went back from Cambridge to Scotland about 8 years ago now. I do like to boast sometimes that Scotland is sort of the home of lipodystrophy, because that's where really, in the 1940s, Robin Lawrence described acquired generalized lipodystrophy and really thought about it and wrote a very important paper then, although it was ignored for many years. And then it's in Scotland that FPLD2, as we might call it, or Dunnigan-Coberling lipodystrophy, that was found by Matt Dunnigan, who was just a diabetes doctor in Glasgow, and he was one of the right sorts of doctors who saw stuff in his diabetes clinic and saw funny patterns of things which happened together and said, well, that's not quite right. And in 1974, he described a couple of extended families in Scotland with lots of affected people, although it was 25 years later. So Scotland has a great history in lipodystrophy, but actually there has been nobody who particularly takes an interest in lipodystrophy in Scotland. So since going there, I have been around and spoken to my colleagues and given lots of talks and found a bunch of people with lipodystrophy. And all the stories I can tell you from there are all the stories that we've heard about this morning from this room. People who probably could and should have been diagnosed 10, 20, even sometimes 30 years before. A paratrooper who developed diabetes when he left the army at 30. Nobody really wondered why he had severely insulin-resistant diabetes and high triglycerides, so we diagnosed him at 40. He's doing well now, but he has permanent damage to his liver, which he didn't need to have. People in lipid clinics for decades being managed and investigated for very high triglyceride levels without people really thinking about why. People with severe polycystic ovary syndrome. You know, I don't need to tell you any of this because you know all these stories. And so I've found around 40 people with different types of lipodystrophy in Scotland, and I'm sure that's only scraping the surface. And although I keep giving talks, it just shows the work is never done. And simply doctors giving talks is not going to be enough in the end to spread the word. So this is kind of obvious stuff. So what do we actually want to do as a community? So we want to make sure that people who have lipodystrophy are recognized as having lipodystrophy early. I just added that little note about genetics, and it's not all about having a gene test. If you have a type of lipodystrophy which is caused by a particular gene, it's very good to know that. It's important because then there might be other things that you should be looking for, and it's important for a family. But it's not the be-all and end-all, and of course many people don't end up with an abnormal gene test in the end. But they've still got lipodystrophy, and the principles of how to manage that are the same. So sometimes I've seen people sort of delaying until a gene test arrives before starting treatment, and I think that's wrong. And actually, we want everybody to have well-informed, personalized advice. You know, that should be a complete no-brainer. And I think the particular issue there in lipodystrophy is the fact that it's a sort of lump on the edge of type 2 diabetes and obesity and that whole world. And sometimes that can be a good thing, because when we're trying to raise money to make things better and to do research, you can say, well, if you study this rare condition, we'll also learn stuff about this really, really big common condition. So it can be a very good way to get money. But on the other hand, because costs have to be so controlled in managing type 2 diabetes, the recommendations for prescribing are very strict that come out of the type 2 diabetes world. And very commonly they come with something like a body mass index limitation, which is rubbish if you have lipodystrophy. The point is not what your body mass index is, it's the evidence you have that the fat tissue isn't working. And so half the battle as a doctor is to constantly write to other specialists or to GPs and say, we must break the rules here. The rules don't apply because this is not type 2 diabetes. And that's a job which needs to keep going. And I think as well as doing our job to go and speak to people, I think that's where there's probably a lot more work to do together. I think, you know, carrying folders is a tremendously helpful thing to do. maybe with some standardized information about the condition. And the first thing I do, I should say, when I see people is point them to the LD UK website, which is fantastic, but carryable things as well. We could maybe help to design a kind of portfolio which people carry around. I was thinking even that something like, I think it's, actually I'm speaking to the wrong slide, but I'll make the point anyway. I think things like a charter might be interesting. You know, a charter is a kind of artificial thing, but we could come up together with, let's say, 10 things on a card that every patient with lipodystrophy should expect. All that type of stuff is useful. It's, you know, you can plonk it on your doctor's desk, on anyone else's desk, and try to make things better. So obviously, the NHS can do some stuff and just can't do everything. And I think all the other people you've heard about today, the charity itself, Centre for Appearance Research, everybody has a role in actually social, personal, and logistical support. Communication and awareness is fantastically important, and we have fantastically better opportunities now with AI and internet as well. You know, there's really big opportunities there to be grasped, and the right treatments at the right time. And the point I really wanted to make there, all that top stuff is the important stuff, the really important stuff, because that can make life better now or nowish. The bottom stuff is really, really important as well, and we need to be promoting that and making sure that people are being supported to do research, but that's long-term stuff. So it's important to have that hope, but we need to be quite clear the timescales of different things. And so I think that's really the point I'm making here, that if we want the biggest win quickly, it's getting all the stuff that we know about already to be done for anyone with lipodystrophy, and there's a lot of work to be done there. I give talks to various different rare disease patient groups, and I make this point again and again. And once again, this is just to make, you know, I think there's some fantastically exciting things there. I think for the genetic types of lipodystrophy, I think there is now a reasonable chance that some will be curable with gene therapies or therapies which take away the damaged gene. And there's such quick advances of that in the world of rare disease. I think that is in range. That needs research. It's never as quick as you hope, and you'll hear about a little bit of, I think, from Justin and George next. So we're talking, you know, 5-10 year sort of timescales, but I think it's tremendously exciting. So potential cures are down the road, and we should never lose sight of the potential excitement of that. But we also shouldn't lose sight of the really important things to do before we get there. So how do we actually do all that? I mean, I think it's easy and right for us to complain and moan to each other about bad experiences and everything else, but actually we just want to make things better. So how can we start from where we are and make things better? So we all have a job to educate everybody we meet. And doing that together actually is more powerful than just us speaking to fellow professionals. Making a real nuisance of ourselves, you know, speaking to MPs, politicians, people that control health policy, actually sticking an oar in and saying, this is not acceptable. And that's absolutely something which we have to do together, which we can't do just as doctors. And so we should be impatiently difficult with all the people that make the rules and hold the purse strings. And then moving more into the research side of things, you know, we, as a researcher, I and other people sit in labs and do clever stuff, and that's great. But actually, and you might think that's a comfortable, nice thing to do away from the realities of the world. But the truth is, it's pretty tough, and we can only do that if we keep getting money all the time. And getting money is tough in a competitive world. And so we need to be smart to change our message to get money at the right times. And the nice thing about the world, the good thing about the world is, gone are the days when we just do that on our own and say, look, we're clever chaps, give us something. You know, we have to make the case that we're doing that, and not just telling people with the condition about what we do, but actually getting their partnership and involvement in that. So just to say that once upon a time, rare disease was a really unhelpful sort of label. And people would say, well, you know, we've got common big diseases, let's deal with those. Rare by definition is not something to worry about. But that's changed a lot in the last 10 years in a good way. So all countries have rare disease frameworks. Companies do see opportunities to make money from rare disease, and so it's got very strong branding. This is from one of the European rare disease organizations. And the sort of case they make is, actually, although diseases are rare, it doesn't matter if your disease is rare if you have it, first of all. And then also there's lots and lots and lots of them. So actually, together, an awful lot of people have rare diseases. And that's all really good, and it's helpful, and it builds a sort of rare disease community. But the uncomfortable truth is they are all competing with each other to some extent. And so the diseases and the conditions where the community is better organized and you're working together with patient groups as in partnership, those are the ones that tend to be more successful in getting money than trying to do it in a piecemeal way. So it's a good thing, but it's also a kind of challenge as well. And also I just added that, even in lipodystrophy, we're here because of lipodystrophy. And in the room, there's people with a bunch of different types of lipodystrophy, and some of them have other features depending on what the type is. And so it's incredibly valuable to organize around lipodystrophy, but we should never forget that there's a lot of variation as well, different experiences and different other conditions as well. And just to mention, actually, this is an example of tailoring the message to what we're doing. So David Savage from Cambridge isn't here today, and that's because he has been pressing the button to submit this grant right today, which I'm involved in as well. And this is to the Wellcome Trust, who give a lot of money. But the types of research they like are kind of conceptual scientific research. So really, this is a grant. It may well not be funded, but it might be. You have to keep trying. And really, it's about lipodystrophy, but we have to describe it as being actually about what determines human body shape, and then using lots of people with lipodystrophy as our partners in that to study it. So that doesn't mean that that's the way we think about the world, or that's what matters. But it's smart because that's what we need to tell this particular funder to get money. There's lots of other funders who fund rare disease translational research, and then it would be very, very different as well. So we have to be salesmen, and we value your partnership very much in that setting. Now, this is a bit of a more horrible scientific graph, and I just use this to make one point. So this is information about 20,000 people from Britain, middle-aged women, and it's a measure of how much fat they have in the middle part of their body to the lower part of the body. And so it shows at one side, up here, where it says FPLD1, that's the extreme of just what happens in the general population, and that's people who carry nearly all their weight in the middle and nearly none of their weight at all on their legs. And we can show that that is associated with lots of metabolic problems. Quite honestly, that is lipodystrophy, and there's people in this room who have that type of lipodystrophy. And so you can see it's actually not nearly as rare as you might think. And that can be a good thing or a bad thing strategically. So if we want to say that studying this disease is actually tremendously important for a larger number of people, we can just slide that along and say that. But if it's strictly a rare disease funding grant, then we need to be studying a condition which affects fewer than 1 in 2,000 people. So sometimes we just have to be smart in the way we're defining things. But it does make the point that there are a whole bunch of people, actually there are thousands of people in the country who have lipodystrophy, and the vast majority of them we don't know about. So I think this is probably my last slide. I've no idea how long. Oh, okay, still. So what can LD UK or others do? So obviously, the top things are so obvious, I hardly need to say them. And we've seen today that you're already doing a brilliant job in those things, that a place to speak to each other, share experiences, support each other. Be part of that annoying, loud voice, getting information about lipodystrophy out there through all channels that we can, professional, public, internet, anything. And crucially, from my point of view, to be a great point of contact. As I said, giving out the website address, sometimes speaking to Becky to direct my patients there is a crucial thing. And I should say, we live a long way away. And a lot of my patients can't or just don't yet feel willing to come along to the meeting down here, but lots of them I know follow very closely the website and the social media. And again, this is where we come into actually just making sure that the stuff that should be happening already is happening. That's probably, to my mind, the single most important thing. And that's where I think templates for care dossiers, patient charters, there maybe is more stuff that we could all do by sitting down together. And I see this in other diseases. And I think we would love it if every doctor knows about lipodystrophy, but they won't. And they won't ever know about lipodystrophy because they have to look after hundreds or thousands of other diseases. So I don't blame many doctors for not knowing about it. I would blame any doctor a lot if they weren't curious about why they were seeing odd patterns and then didn't look to find out what that pattern meant And then we make it as easy as possible for them to find that pattern and find their way to the right places. So I think we're never going to have every doctor in the world knowing about lipodystrophy, although we should aspire to it. But we need to make sure that they can find it quickly when they think about it. And I mean, helping to fill the gaps in NHK, it'd be lovely if we had a service in Cambridge or elsewhere which also could properly address, dressing and body image and all those other things which are such important bits of daily life. But in this cash environment we work in, that's going to be tricky. So that's where stuff that happens outside hospitals is so important. And I think, it's much more satisfying working in research these days. In the old days, maybe even when I started in the 90s, research was clever stuff that was done by doctors and scientists. And then it was never even asked for, but from time to time it was quite nice to go and tell your patients about what you were doing. And that was the power shape. It was us telling you as patients what's going on. But certainly, I think the world has completely changed in a really positive direction. So it is now expected that we're not just efficiently telling you about stuff, but you are part of working with us to put the bids in. And it means in our grants we have to explain not just patient and public engagement, but involvement as well. And sometimes that means asking in our grants for a bit of money to help people be focus groups or give our inputs as well. And another thing is that, of course, we have pretty good skills, but we've got limited skills. And amongst any wider patient group, there are some people that just about get by, struggling with families and work and life and healthcare demands. But there's also a lot of people who have great skills in, graphic design or law or IT, and actually mobilizing all those skills when people have the capacity is a hugely, hugely powerful thing to do. And there are examples around the country where patient charities actually co-run and co-own NHS services. So the sky is almost the limit for how much charge you can take. But of course, it all depends on how much capacity people have in their busy lives. But you should never feel slow about being assertive, and it's co-ownership more than anything else. And just the very last point is, as I said, science is quite tough, even if you're quite senior like me. I'm still going to have a job if I don't get grants. But it's only because we have grants that we're able to have people in our labs doing science. And that's quite a tough career, because they don't know what's going to be happening after the end of a grant. So they go 2 years to the next. And so we want the best people to be working on lipodystrophy. And we need to be getting those grants to bring them along. And I think getting spaces where not just me, but much more junior people that work with me get a chance to maybe not even give talks, but maybe sit down and talk through stuff and learn how to use the language that is meaningful to you would be, and that's hugely valuable for scientists who do very clever things, but they also really like to know that what they're doing is meaningful for something in the real world. And the best way to do that is to meet people to whom it's meaningful. So I can imagine other ways in which we try to connect with our wider groups, as well as just the usual people you see down here quite regularly. So that was it really. That's just 20 minutes of rambling about things I thought about over the last few days. So very happy to chat at lunch or elsewhere, but I think we've got some proper nailed-on geeks coming next to tell you about their research. So I probably better hand over to Justin. Well, I don't.
Just before you go, if there's any questions?
I'm more than happy to be grabbed at lunch or later on as well. Yeah.
Thank you, Rob. So next up we have Justin Rochford and George McIlroy from the University of Aberdeen.
Right, I'm going to emergency notebooks in case we need it. So maybe while George gets things plugged in, I'll just introduce us. So I'm Justin Rochford. This is George McIlroy. We both have research groups at the Rowett Institute, which is part of the University of Aberdeen. So we've travelled a long way down. It's a real pleasure to be here. I think George presented here last year. I gave some presentation online, so maybe some of you may recognise us. It's a real pleasure to be here in person. I think that's been mentioned by several people today, Omar and others, that, I mean, it is really, we're researchers, so we don't see patients. It's really powerful when we get to meet patients and hear your stories, so it's wonderful to do that, and we're going to try, and if you're willing to do so, we're going to tap into some of your fantastic knowledge during this next probably 30 minutes. So I'll give a brief introduction. We're also going to try and hand back and forth, which we haven't done before. I'm aware that this might turn into sort of like a nightmare version of Pointless, as we're each stepping up to the microphone. So we'll have to try and remember to come over here. We just probably ought to disclose that we, has been mentioned a couple of times about the fact that we've done some work on gene therapy, and we co-own a patent covering that. And I also am a co-eye on a project funded by Regeneron, although it's nothing to do with lipodystrophy, but I think it's important to just disclose that that bit of work that I do something for is paid for by a company. So what we'd like to try and do today is, we talked about our research before, and we don't really want to do that again because we want to hear what you've got to tell us, if you're willing to do so. But we will just quickly give probably 3 or 4 slides to give a sense for those who haven't seen it before what it is we do. We're going to say something about funding applications and how they work as well. The reason for that will become clear, but Rob's actually covered some of that really nicely already, how tough it is to get funding and how we really need your help. But we hope... some interference on the screen. And so we'll talk a little about that, about the kind of future projects that it would be great to get some feedback on, or your ideas on what kinds of things that you'd be interested to see, and then something also more, as Rob's mentioned already, about engagement. We want to really put in applications where we can get funding to make sure that we can compensate, people giving their time to finding out more, giving comment on research applications, but to do that, we need some evidence that we know what it is you would like us to be doing. So that's what we're going to try and do. Right, and with that, I think I can hand over to George.
Yeah, good afternoon, everyone. So Justin and I are both researchers who work at the Rowett Institute, which is based at the University of Aberdeen. And it was really founded in 1913. And then more recently, in 2016, we moved to a purpose-built facility. And really the mission statement for the Rowett Institute is to promote sustainable nutrition and improve health and well-being through world-class research and education. And so just to give you an overview of some of our research strengths, so we're divided into a number of different topics and themes. And so Justin and I are involved in the nutrition, obesity, and disease theme, but we also have strength in the microbiome, for example, healthy life course, physical activity. And really central to this research is kind of 2 world-class cores that we have. So we have a human intervention studies unit where human intervention studies are performed in-house within our building. And we also have a world-class analytical core facility, which is doing things such as lipidomics and proteomics analysis. So I thought I'd just give a bit of an overview of what kind of day-to-day lab life looks for our groups at the Research Institute. So here we have Nadine Summer, who was a recently graduated PhD student from Justin's lab. So here what she is doing is analysing tissues such as body fat and liver from our preclinical mouse models and cutting sections and stains for those. Here we have Alima Ruman, who's working in our tissue culture facilities as one of her aspects of her postdoctoral research studies. And again, this is taking cellular models and manipulating genes that are responsible for causing lipodystrophy and examining what is happening under these very specific conditions. And then here we have Mansi Tiwari, who's a PhD candidate in my laboratory, and she is heavily focusing on computational research which is very heavy data-driven, performing analysis using bioinformatics techniques. And then Justin and I typically can be found outside enjoying the sunshine, debating which coffee we're going to have next as the students and postdocs are working hard. So next, I'm going to hand back over to Justin, who's going to give us a very brief overview of some of the research projects that we have ongoing at the moment.
Right. Excellent. Smoothly done. Right, great. So I think actually it's been articulated. Becky gave a great introduction actually about fat tissue and how fat tissue doesn't really work in lipodystrophy, and that's what it's about. So we're very interested in that. So I guess our research spans from the very mechanistic studies of trying to work out what's going on in cells and how things work to much more sort of, we don't go into studies in humans, we do use human tissue, but into mouse models of lipodystrophy. So just to sort of say a bit about that, so, if you take, this is a DEXA scan where you can see coloured in yellow, there's a fat tissue. If you took a piece of that fat tissue, and as you saw Nadine slicing tissue, you'd get a section like this of tissue, and those little circles are all the fat cells inside the fat tissue. And if you zoomed in on one of those fat cells, you'd find this cell with a big droplet of fat sitting in the middle of the cell, which is being stored there. And those are the cells that we're really interested in studying if we want to understand more about what's going wrong. And the two really key things, again, as Becky said already, that I would say those cells are doing is they're storing the fat in the body safely, and they're keeping them away from all these other tissues where they might cause disease. And they're also secreting lots of hormones. And obviously we've heard already particularly about leptin, because metroleptin can be a therapy. So we've done a lot of work looking at the gene that causes generalized lipodystrophy type 2. So I'm just using that as an example of some of the kinds of things we've done. And as many of you will know, if you have a change in the sequence of this gene BSCL2, it can cause this very severe lipodystrophy with almost no adipose tissue. And so we've done various studies taking cells like Alima was doing in that picture where she was in tissue culture and trying to change things within the cells to mimic what might happen in the fat cells of these people, and then try and work out what that gene's doing. We have what we refer to as preclinical models. So these are mice where we've made the same changes to genes in the mice, and then we know that they will show many of the features that one would see in people who have the same changes. And then we can look at what happens there and why that happens. But also particularly, what are the effects of that fat tissue not working properly on lots of other tissues? And then we can go right down into the details. This is actually trying to render a picture of what the product of that gene would look like, and highlighted on there are some of those specific changes in that gene, and trying to work out why it is those changes are important. So that's at the really kind of molecular end. So then if you zoom out, then we've got these models, these mouse models, which display the same features as you see in people living with lipodystrophy, and we want to test. Another thing we do is to try and test drugs and test potential treatments in those models. Essentially, because we can look in much more detail on exactly what's going on than we'll be able to do in a clinical study. Particularly with a rare disease, it means we can do really in-depth studies. Obviously, mice are not people, so we have to be very careful about what we say and how much we take from those studies, but I think we can learn some really important things. So as a couple of examples of those, we had a recent study where we used these GLP-1 receptor drugs, one of the drugs called liraglutide, and we showed that in our model, over a short term at least, we didn't see a big change in fatty liver, but we did see a big change in the control of blood sugar levels. So we got really clear results from those studies. We've also done some studies where we've tried to deliver leptin as a gene therapy. So instead of injecting leptin every day, the idea here is you'd have a virus that you'd inject. The virus will, we think, in this case, go into the liver, and it'll keep producing leptin all the time. So you don't have to keep taking injections. It probably lasts for several months, just producing leptin all the time. And we showed that that was actually very effective in our model as well. And we've got very dramatic improvements actually in liver fat, very dramatic improvements in insulin levels. We don't actually see huge changes in blood sugar in that model, but we did see some really big improvements. And just to say, that actually led to a grant Rob was talking about getting funding. We're very lucky we managed to get funding from Diabetes UK for a project that's just started where we're combining these therapies and we're doing some more in-depth studies. And we need to thank Becky and Siobhan and anybody else in the room who might have contributed to that. We contacted Lipodystrophy UK, and it's always really helpful to get feedback. Obviously, we need that feedback to know what it's doing. But I think I'm going to hand back to George, and I'll be returning to that point in a minute. So.
Yeah, so my laboratory has also been investigating gene therapies, which we hope could potentially be a potential cure in the future by regenerating and making new body fat and adipose tissue. And so this schematic here really is just showing a cell with a defective gene, which ultimately results in the lack of fat development. And gene therapy is trying to deliver functional copies of that gene to the cells where it's required. And therefore, hopefully, with these delivered copies, the cell will now function normally, and that will lead to the development of adipocytes and adipose tissue development. And so what we have conducted in our preclinical models is research to examine whether or not this is effective. And so what we have done is we've injected gene therapy, and what we found was that the mice that were completely deficient in body fat, we were able to restore adipose tissue development, and this was able to completely improve the metabolic complications observed in this model, which highly replicate what is observed in people with congenital generalized lipodystrophy type 2. So we're trying to develop this further, and again, we've already mentioned funding and how challenging that can be. One area that we have identified is that we're not really sure how we can translate this to humans effectively because the information isn't out there. And so we don't know which type of gene therapy will be effective in human precursor cells, which lead to the development of body fat. And so what we're really trying to do is some basic research to find out what could be effective in humans in the future. So there's some real hope and promise there, but as was mentioned earlier, research does take a long time to progress. Additionally to this, we're doing more molecular work with these models and the results that we've seen from our gene therapy preclinical models. And so what Mansi has been doing is she has collected livers from our mice that have received gene therapy. And if we take a closer look at the liver, this is a really complex organ which has multiple different cell types, all performing different functions. And so she's performing really complex next-generation sequencing techniques within these cells. And what she's able to do here is identify changes in the genes, but also the DNA architecture. And what this funny image with lots of dots is showing is individual cells where we have that information at single cell resolution. And so she's able to split up the different cell types which are present within the liver and ultimately try and decide where the improvements are occurring in response to gene therapy in the liver, which hopefully will lead to the identification of alternative treatments in the future. So that was an overview of some of the research that we're conducting, and we really want this to be an interactive session. So if you could get your smartphones or devices out and scan this QR code, what this is going to do is it's going to take you to a system that we've got at the university called Vvox. And so this is a completely anonymous survey analysis, and we should, if this is going to work, fingers crossed, and I will do the same, is if you scan the QR code, this should take you directly to a page which has the University of Aberdeen logo on it and Lipodystrophy UK Patient Day. Is everybody beginning to see that? Excellent. So I'll give you a bit of time just to get the scan. And so essentially, as I say, this is anonymous. but we're going to get live results as to what you've got to say. So we've got a number of different questions that we want to ask. Okay. We're also willing to, if people don't have devices that are able to do, this is an interactive section.
So that we can stick hands in the air if it becomes necessary.
Or it doesn't work. So if everybody has a copy of the QR code, excellent. What should happen, so it's come up on my phone, you should get this question and the ability to select an answer for this one. So as you can see, we've got a couple of answers for, did you follow our research overview? So Rob nicely put that we talk a lot of jargon and potentially gobbledygook on a regular basis, which is not easily understood. So we are really interested. So this is fantastic. We've got 42 people. This is amazing. So 20 of you have already responded, which is great. So I'm just going to keep this poll open for a bit longer. So we really, please be honest. It's completely anonymous. We can take the heartache.
Would have had worse.
Well, definitely. So we're up to 35. So this is going really well. And there'll be a couple of reviews scanned in because I won't. I can give an answer. 40. This is excellent.
Wow.
39. Oh, we've got more. So I've signed in, so it won't get up to 45. Yeah, sure. You can just nip back. Yeah. And just to say, this should stay open in your browser for the rest of the questions. So we're going to jump back to some funding, and then we'll ask some more questions later on.
Can we just go to the app? Can we just go to the app, take the app into it? I can't do this
No, so this is actually just like a live thing. So yeah. But if you can't get logged in, we'd love to hear from you.
Absolutely.
Anyway, so you can always just tell us what you've done. That would be great. Yeah. Heckling is fine.
Yeah.
Yeah, so that was the idea, is we don't have to download it.
That's all right. Okay. But this is fantastic. We've great response. So, I scanned in, and I'm not going to put an answer down. Well, I could say yes. It's going to go on Netflix. Right. So let's go for our first results. Okay, so this is music to our ears. So we've still clearly got work to do. If you got some bits, we are not doing a good enough job. So this information and hopefully the other questions are going to be really essential for us, and also just, again, enforcing engagement with the community. So we've got a few more of these that will come up later, but you should be still signed in and ready to go. You won't need the QR code again.
Cool, okay. So, and actually Rob's kind of done the job for me for the next slide at least, but we just wanted to tell you a bit about sort of the challenges of getting funding, the fact that we need funding to do any research, and also therefore why we really value your input and help, and that hopefully that means that together we can get more done and make a bigger difference. So I don't really need this slide. It was really just to say there are lots of different types of funders, and they're after different things, which I think Rob articulated really nicely for you. So I just highlighted two things we currently are applying for money, or two schemes we're applying for money. I think they illustrate two different things. One is a BBSRC grant. This is a government funding body, UKRI, and you know well in advance these things are coming, subject to some minor changes recently, but you know in advance these things are coming. But actually, they don't really want any. But they're not greatly troubled by whether we've engaged with the community, because these are very fundamental research grants. So actually, what they want to see is there's going to be impact of those grants, but they don't. In my experience, there's not really sections to fill in for that, but we know about it in advance. In contrast, George has led an application very recently, which is very disease-focused. And there are two things. One is that it is very disease-focused, so it's really helpful to know what your community would like you to be doing. But the second thing is sometimes these come at really short notice. And one of the things we want to try and get through to try and discuss with you today and see how we could do better is we're very mindful. We quite often end up emailing Becky or Siobhan and saying, can you have a look at this for us, whatever. And it's last minute, it's completely unreasonable for us to be trying to get information on things at short notice. So can we do things a bit better so we've got that information before we even start, and also be engaged more consistently so that we can get you involved in the research along the way. So we're going to come to a little bit about that. So it was really just to illustrate those points. And I mean, this is really just reiterating some of what Rob said, but I'm actually on panels for Diabetes UK, and they're really probably of the funders that we go to, probably the most invested in this. They wanted to show evidence that we've involved people living with diabetes, but living with lipodystrophy in developing the research question, reviewing what we've put together, designing the study, but also how are we going to involve people living with the condition in the management of the research, and certainly in the dissemination of the research. And so it is really important for us to be able to engage better, to do those things better. I think I'm handing back to you.
Yeah.
Yes.
Yeah. So, as Justin's mentioned, we're continually developing projects, and again, we really wanted to use this opportunity today to better involve the lipodystrophy community in the work that we're doing and going forward, to make sure that we're doing the work that is important to you and answers the questions that you have. So we've got some more questions coming up. So our next question would be, would you be willing to give input to our grants? So this could be as easy as assessing our lay summary impacts, or communicating with us with the types of research that you want us to perform. So what we're trying to gauge is whether you'd be willing to give that input, and we then potentially, we're not asking a few people from the community, it's a much broader group of individuals that are providing input and helping us. So again, we've got 41, which is fantastic, numbers flying up.
So I should say, before any more people hit the button, this is us gauging how many people might be willing. We don't know who's ticked what.
Yeah.
We won't be banging on your door and saying, you said you would do this. So it's really just to get a feel for what.
And again, I think maybe as well, if there's other information that you would want to know before you would be willing, we can obviously provide that as to how potentially little or much work would be required for that. So I think we've got most people. I think my phone is probably still hooked up. So how does this look? We've got, wow, fantastic. I mean, that is incredible. So I think this really, we've got some other questions that we'll ask later on, which may support how we move forward with this. So I might leave that just there, but that is great to know. So the next thing is obviously asking you, what types of projects would you potentially support? So we've got various different project types that Justin's already mentioned. These can be, very mechanistic in nature, such as, why fat tissue doesn't work and why this causes the symptoms that are observed. There's obviously therapeutics, where we're looking in a at least preclinical setting to test or develop new treatments, such as the gene therapies. We're also interested in potentially looking to identify diagnostics. So, for example, finding new factors that could be used to improve diagnosis. We're also very keen about awareness and diagnosis, working with Professor Semple for Scotland. Obviously, that's where we're based. We don't really have an understanding of the prevalence in Scotland. But again, this is the forum to ask all of you, are there things that we've clearly not thought about and that are important? So I'll just give you a bit of time to, as I say, I think this one you can potentially do a number of options. So again, this was almost like a potential ranking that you can have multiple options for your answers if you wanted. How are we doing for time? 24.
Because I don't think it's appropriate for me. If you scroll down, I think there's a submit if you didn't see that at the bottom. Yeah.
Perfect. Okay, so let's have a look. Okay, excellent. So the other I find very interesting, because obviously these are the things that we're putting funding in for. So the next question, if other, what should we focus our research on? So this is an opportunity, again, I think you can submit multiple words. I think we found there was a limit of 20 characters, I believe, for this. But again, this is just to gauge an insight into things that we've not thought of, or again, things that we may be able to work on in the future, but potentially the tools that we have at the minute and the models that we have, we may not be able to answer those questions. So like Becky showed earlier, this I think will maybe give us a bit of a word bubble. Okay, we're getting up there.
Next time, George is going to learn some songs.
Yeah. Some dance.
Yeah.
Okay, I think in the interest of time, if you've got any final words, and we might wrap this poll up because we've got a few others. Okay.
Did anyone write when's lunch?
Right, let's have a look at what we've got. Wow, excellent. Okay. We will assess all of those.
Really helpful.
Yeah,
Yeah.
fantastic.
Very good. Yeah.
So we will go away and have a think about those. And again, future discussions. This was just an engagement just to see what was going on. So I will hand back over to Justin, who is going to talk a bit more about additional community engagement.
Yeah, so it's really about just, again, you know, some ideas that we have, but we realise that what we think might be a good idea is not necessarily what you would actually like. And it's really important, I think, if we're going to try, what we like to do is to try and make sure we're using the opportunity to apply for funding where we can, to involve people living with lipodystrophy more. There's no point in doing that for things that you don't want. So just a couple of things that we sort of came up with, and we'll ask you a bit about this in a moment. So one is to, you know, from the research side, putting together some kind of advisory group who might be able to on a more regular basis, that doesn't mean necessarily more frequently, but at least just on a more structured basis, give us feedback on things so that we're not asking for that, you know, acutely in the moment, but rather it's a process that's going on all the time, and that whether there'd be a willingness for, it wouldn't be a huge number of people, but obviously it'd be great to have as many as possible, but, you know, some kind of advisory group that can give views on grants. We wondered about trying to run occasional, maybe twice a year, something like that, but again, it would be guided by what the community would like. Some kind of lab meetings. We might join up with others, like other groups here who've presented some lovely research, and it could be that we could even join up with others and do it as a joint enterprise. But certainly from our perspective, to have kind of lab meeting where we present in an appropriate way the research we're doing and try and get some feedback, but also try and just keep you informed of what's going on. And then the third thing, which is kind of related, but also which Rob's mentioned already, and Rob has been doing great work there, you know, contacting patients and spreading the word across, because we believe there's not, you know, there'll be many undiagnosed cases in Scotland, but how do we reach people? And I think what we wanted to try and do is draw on your experience, which we've heard about, you know, already, but about what made the difference and any tips we can get from you and how we might go about as researchers if we want to help that process, you know, where should we put that information out? So we've got a couple more questions. So the first is, if we did try and set up some kind of advisory group, what's the interest in that? So if people would be happy to, how do we just tap forward when we're ready?
When you're ready for the poll,
just go forward, yeah. Okay.
Yes.
I have your permission to vote. We're still moving. Right, it's 34 out of 35. Okay, good. And wow, well, I think we'll take that as a yes. So thank you very much for that. And I'm sort of sensing that it might be difficult to tell this must be focusing.
Virtually, yeah.
Yes, yeah. So the idea would be, please come to Aberdeen. Yes. You're very welcome to come to Aberdeen.
Very welcome to come.
And I promise we've only got, I think, one or two more questions for you. So. Are we good? I think that's. Are we happy with everybody? Yeah. Excellent. Okay, that's really helpful. Well, it's fantastic. What's really helpful for us, particularly if we're then going to go and try and make the case for this, is to have some numbers that we can tell people. So that's really, really, really helpful. So On to, I think we've got one question after this. So really, it's just if we are going to try and do something more in Scotland, taking your advice for what we do, where do you feel that the greatest benefit might come if we're going to go on? But then, and then obviously, sort of, it'd be great to hear maybe. Yeah, so it would be wonderful to hear, in conversations afterwards, perhaps about how we might do that. So obviously, we're going to be working with Rob on this to try and do what we can. So it's really. You can answer your own. Yeah, you can if you want. It's just another. Yeah, we're okay. Yeah. I was looking at that clock, so we're not quite at that time. Okay, should we say that's 34? Yep, excellent. Well, okay.
Media, excellent. Okay.
Cool. All right, and then I think we have one more, and we'll just move on to that. So there are a few others there. So if people are willing to offer any suggestions of others, that would also be great. So I think, is that live?
Yeah.
Yes, that's live. Yeah. And then I promise you we'll leave you in peace. So. But obviously, we'll just collect a few quickly now, and then we can finish. But if anyone has any suggestions of things, obviously we'd love to hear from you. We've got emails on the last slide, but please do get in touch. And I'm not seeing loads. Has everybody stopped typing?
You've got core in Scotland. Do you know what the industrial activities in that area? Because
There's a core in South Wales of people who've got lipodystrophy genetically through that
You mean just where that pattern when Rob showed
We're genetically, and also the great thing with the South Wales thing is coal mining. Is there coal mining up in Scotland? Is there something externally or environmentally which could have affected? I mean, there's very little detection of it. I'm not saying it isn't down in Cornwall, but there's very little detection of it. We had problems to get diagnosed in Plymouth, and down in Cornwall there's hardly anything.
We were in our 70s when we were
diagnosed.
Wow.
Yeah.
So imagine the number of doctors we'd seen beforehand.
But I just wanted to, if our environmental things, there might be a core of Cornish, and that's two Celtic groups as well.
Yeah.
Cornish are also highly Celtic and have mining as well. So
I suspect that sort of strip across Scotland, that's the central belt, may well be as much to do with the number of people, the sheer number of people there, therefore more likely. But certainly, you're right that also does map to the coal mining areas and things.
Yeah, Celtic and the mining.
Okay, I think we'll
wrap up. We'll wrap up. So, but that's an interesting comment. Yeah.
Excellent.
Good. Yeah.
Fantastic.
Great to have some comments. Right.
So that's us, you'll be pleased to hear, but just want to say thank you all so much for participating. This talk was really inspired from us joining last year, and we're delighted to be invited back, so thank you very much.
Oh, thank you.
And thanks to Lisa.
Just before we go, does anyone have any questions for Justin and George?
Thank you. I found that really interesting. I
I think there's only 3 of us here today with my type of lipodystrophy. Obviously, it's not a genetic, it's an acquired type. So what research is being done to find out what's caused that? And is the gene therapy that you're doing, is that going to be beneficial to us?
So I think what I'd say about this, I don't actually know a lot about research into acquired lipodystrophy because it's not a lot of research that we've done. I would say that it's true that where we're doing research on the genetic types and how they work, clearly where the specifics of that may not be so relevant to acquired lipodystrophy, but I would certainly argue that a lot of the work we're trying to do, looking at using our mouse models to look at our preclinical models to look at therapies, that those would all be relevant for acquired lipodystrophy. So the work that we do trying to look at how the mechanisms of how the disease, how the fat dysfunction causes the symptoms would certainly be very relevant. So yeah, it's something we're very mindful of, but it's true that the causes is not something that we particularly work on. But,
yeah,
do you want to
I would just say that the gene therapy that we've focused on is primarily for the genetic causes of lipodystrophy. However, the techniques that we're using, if we can understand how we can target precursor cell types, we may be able to develop that technology to stimulate adipose tissue development in non-genetic causes. But again, I think that there needs to be a far greater understanding of how those conditions occur, and there would have to be additional measures put in place in order so that if we were to regenerate adipose tissue, that it wouldn't have any potential future negative impact. So there is potential. It's complicated, but I think the more research that is done could potentially help with development in other forms of lipodystrophy.
Hi, thank you for this and a really interesting talk. And I mean, it's always great to see the advocacy of people with lived experience in research. I just wanted to add a suggestion on top of the advisory group and people being involved in the lab sessions, which is a really great idea, but obviously not everybody has the commitment and not everybody wants to do that or has the confidence to do that. It could be daunting for people. My research is more in mental health, so we actually have people, doing surveys. And something I've come across a lot in my PPI work is people with lived experience get quite frustrated of providing data or being involved in research and then never being told the findings. They kind of, it puts them off, to be honest. They think, why have I spent my time providing data and then never known what's happened to that? Obviously with mice, that isn't so relevant. But I thought, having just something like a newsletter to keep people updated of the progress you're making. You said research takes a very long time, but when I've suggested that to advisory groups, they've actually been really keen just to have, those little really informal updates that they can read at their own pace and their own time and just, I guess, know that research is happening, even if it takes years and years and years. And then I also had a question for you, because obviously you're advocating for people to be involved kind of in the beginning of the research life cycle, so in the grant phase. Again, from research that I do, I know that it tends to quite drop off from there with lived experience. And again, I understand the research you do. I collect survey data mainly in my research. It's quite different. But do you have any plans to kind of keep that advisory group throughout the research life cycle? So even, for example, I do things like when I do research, when I do analysis, I tend to then take the findings in the lay summary and take that to people with lived experience and go, why do you think I found this? What do you think I mean? And to get all of those different perspectives, they say things I would have never thought of. And actually, it just strengthens the overall research and makes it much more meaningful to them. So in a really long-winded way, I was just wanting to ask, do you have plans to keep that going throughout the research?
Yeah, I think they're fantastic points. And I think we would love to have a more developed dissemination of our work. And again, I think this is where we work together in order to achieve that, in the development of the projects and then updates as to where projects are going. Science is very messy. You can propose something and things change. And so I think, like you say, even providing an update as to, well, we've reached the end of AIM 1, and we didn't find what we had observed, so now we need to take a different tact, and we've actually got a new research angle from that. And so I think, yeah, providing that information would be great. So yeah, I think we can definitely look to...
Which we would always be happy to pass on.
Yeah.
Let us go.
Yeah, I'll let you go for lunch shortly. I just wanted to say that this is something that, as patient advocates at Lipodystrophy UK and other patient charities, have been advocating for a really long time to make sure that patients are involved from the beginning of the research cycle, not just at the end or when people need to put in a grant proposal so that they can show they're working with the community but then don't actually get involved. It's that we can inform and input into what things should be researched. So it's really lovely to see that that is happening, and we've been working with the people that have been speaking this morning for several years, and the situation is improving, so it's really great. And thank you, Neve, I think your suggestion was fantastic. You know, it is often, we don't always get feedback, and when we do, as Siobhan said, we share it, but we don't always get the feedback for what the study has found. And actually having input for how we might reflect on the results is also really valuable. So thank you for that. And, you know, we continue working with you. So thank you very much.
So that is the end of the morning sessions. We do have lunch, which is where, if you stayed, you had breakfast this morning, and we be back here for 2:30, please. Yeah. Well, yeah, that's fine. No worries. Make sure you get in the photo. I'm going to try and get everyone to the front for a photo now before it all starts, and then hopefully we'll get everyone in. Although there's some staff.
Hi everyone, I hope you enjoyed your lunch. In a couple of minutes we're going to do a group photo of everyone because some people will need to leave before the end, so it'd be nice to get a picture of everyone that's gathered. So if you would like to be part of a group photo op, then please come up front and we'll have a picture of all of us together. Thanks.
If I'm in a team meeting, I've had to change my background. Two ones at the back. Yeah, exactly. I don't want to be in the I don't really want to be in the No, I don't want to shuffle around. Like almost.
Shuffle around a bit more. So if you kind of step it up. That's it.
I don't know if we can't take it without punching it. Imagine that. When I was a youngster, everybody else was kind of like 25 feet, but it's nice to have it.
Next one down the back.
Should we do a silly one more?
Yeah, the adults on the other side.
She wouldn't dream of that.
You couldn't escape it.
Come on.
Yeah.
Nice try.
Do we want to do our L for lipodystrophy now? So right hand,
Thank you very much. Do you guys want a drink or anything? I will go. I'm running in.
might get one inside you.
Are you off now? Thank you. Good afternoon, everyone. Welcome back. Hope you enjoyed your lunch. Hi. So joining us now, we have a personal stylist, Susie Hasler, hopefully.
Yes, I'm here.
Oh, hi, Susie.
Hi. Okay, I will take over from here. Thank you so much for having me today, and I'm really gutted that I can't be there in person with you all, but thanks to modern technology, I can still be with you today. And it sounds like you've had a really lovely day planned, and I'm taking over now with a bit of talk about body confidence and personal styling, and how style and clothing is accessible and can be enjoyable for all, even when your confidence is feeling a bit low. So just before I get into it, I thought I'd just introduce a bit about myself so you know who you're working with today. So I'm Susie, I'm based in Sussex, and I have been styling for the last 14 years. Now, I went into personal styling because I just thought that all women deserved to feel amazing in their style. And I felt like, you know, sometimes it can be a bit of an intimidating process going into a shop and not knowing what suits us, not knowing what colours suit us, not knowing what necklines suit us. And the choice overwhelm is huge. So I wanted to create something that really empowered people and made the whole process both enjoyable and inclusive. And for the last 14 years, that's exactly what I've been doing. And I've now got a magazine column, and I work with clients all over the world online. So it's been a journey. So here's how I can help you today. Now, I understand how life gets really impacted by low confidence. And after speaking to Siobhan a couple of months ago, she was telling me how much lipodystrophy can really affect patients' confidence with a lot of the body changes, and that can be huge. And when you're lacking in confidence about your body, it can really hold you back from living life to the fullest and maybe putting yourself out there and enjoying things. And your confidence can be changed. There's lots of small gradual actions that I can help you with that will give you the tools to enjoy style every day and hopefully start building a bit of confidence. So the life-changing benefits of working on your style. Now, it can seem like a really frivolous thing when we think about clothes and when we think about style. And, you know, I've had a lot of people over the years that have said to me, oh, you just shop all day. And it's absolutely not the case, although I do shop all day with clients. Style and taking an interest in your style is such a powerful form of caring for yourself. It's a really powerful way to connect to yourself every day. It's a way to show up for yourself every day that shows you that you're worth taking the time for. So often we are putting everybody else above us, all these other people on our to-do list except ourselves. And when we start taking an interest in our style, colours that suit us, and what we love to wear, prints that might make us feel a bit more fun and a bit, you know, just more confident. It can really build a really deep connection to yourself and a really strong relationship to yourself. It can also unlock creativity and self-expression. So I always say to clients and people that I work with that there is no wrong when it comes to style. I think so many of us worry that if we walk into a certain shop or we wear a certain colour or we try something new, that we're going to be told that we're doing it wrong and that style isn't for us. And it can really hinder people from, you know, having that fun with their style. But by doing so, you unlock that creativity and you start to express yourself in a really personal way. And this does take time. It is a process and it's never an overnight thing. Now, what I think is really important is to talk about what happens when we lose confidence. And I think the relationship that we have with our bodies is huge. I think if we feel we're lacking in confidence, it can impact so many areas of our life. And having spoken to Siobhan a couple of months ago, she was saying that this is a really big thing. And hopefully this is something I can help you with today. And hopefully this will also show you that you're not alone, because these feelings are so common and a lot of people don't talk about them. But the privilege that I have of working with thousands of people is seeing that this is actually a really common feeling. So hopefully this will reassure you a little bit as well. Now, when we lose confidence, and maybe we've never had confidence, you know, sometimes it's something that we've just never had, it increases that self-awareness and the discomfort of being seen. So this is why a lot of people, when they're lacking confidence, they tend to gravitate towards really dark colours. So quite often this would be black, it would be grey, it would be colours that make them feel like they're not going to be seen, not like this bright yellow jumper I'm wearing today. The feeling of being seen and noticed is a real fear for a lot of people. And when you lose confidence, you tend to just want to shrink into the background. So anything you can do to hide yourself, essentially. When you lack confidence, you are also more likely to avoid social situations. Now, that can be anything from a party, a wedding, a family gathering, or even just seeing a close friend for a coffee. Sometimes when that feeling of overwhelm with your confidence and your self-image is so low, the bigger it becomes, you know, the more it infiltrates into all areas of your life. And eventually that can lead to complete withdrawal and isolation. And the earlier we can spot this, the earlier we can just notice when we're starting to feel that way, the more we can hopefully stop it in its tracks. And with confidence, it's never linear. It's always going to be up and down. You know, there's always going to be times that there'll be times when you feel a little bit more confident, a little bit braver, and other times you might not. But just spotting those feelings when you feel like you're starting to go out less or want to see people less, quite often that's when you have lost confidence, and we can hopefully find some tools to help you stop that in its tracks. So this also then filters into what we wear. So when you're lacking in confidence, there are lots of things that I see, lots of patterns that I see with clients that I work with. The first one is always black. Now, black is often used as a bit of a cloak of invisibility. So if a client that I'm working with is feeling like they're lacking in confidence, the last thing they're going to want to wear is a big pattern, the colour red, the colour yellow, because it's going to make them feel like they're more visible and they're going to be seen. I think black is actually quite a handy colour if worn intentionally. I think black can be a really sophisticated colour. I think black can be a really handy neutral for jackets, trousers, etc., basics. But I'm interested to know how many of you use black as a cloak of invisibility, because this is so common. Can I see a show of hands? I've got you on a little screen. Can I see a show of hands of anyone that wears a lot of black? Yeah. Yeah, it's really, really common. And the beauty of black, it's not a case of hiding it from your wardrobe, getting rid of it. It's making it work for you in a really good way. So you can add a bit of colour to it. So for example, you can, if you're wearing a black dress or a black t-shirt, for example, let's start really basic, a big baggy black t-shirt that you're not going to be seen in. A way to start lifting it a little bit is maybe just adding something to it, whether that's a scarf or a jacket in a slightly different colour. So start trying to change your relationship with black and utilise it, but try not to use it as a cloak of invisibility. So the second thing is oversized clothing. Oversized clothing, it offers a real sense of safety and a real sense of security, because firstly, if you have low body confidence, you're generally going to feel more comfortable when you're wearing something that is too big, too baggy. And it's another way that you can almost hide underneath it. This is something I see all the time. And if you're wearing black and you're wearing baggy clothing, it's a way that you can hide and no one can see you. And what I completely appreciate that using these clothes, using these safe clothes, it really can bring comfort, because if you are feeling really lacking in confidence and that's the only way that you can leave the house and face going to the shops that day, that's absolutely fine. But when this is prolonged, when this is a daily occurrence and eventually you start to almost disappear, and that can really disconnect you from your own identity. It can disconnect you even more from your confidence, and it can really disconnect you from your style. So these are things to maybe just note. If any of these are coming up for you, it'd be really interesting to know. Just have a little think if these seem familiar. Trying to do the next one. There we are. Okay, so there are really small ways that we can build confidence. And it's not going out buying a whole new wardrobe. I'll actually rarely recommend that, which seems counterintuitive as a personal stylist, but I often don't think people need a whole new wardrobe. It's about building a better relationship with yourself and building a better relationship with your style and building a connection to yourself. And that can be done in many ways. So I would recommend building one new daily habit, just one, and it doesn't have to be something big. So, for example, I was speaking to a client this morning who was saying to me, her day, she's 71. She said she doesn't work anymore. And she said her day just consists of taking her dog for a walk. And quite often she doesn't leave the house or see anybody. And she said she doesn't see the point in getting dressed, doesn't see the point, but isn't feeling great in the process. So I said, well, why don't we start thinking of ways that you can add something every day? So a piece of jewelry, for example. So in the cup holder of your car or in a little dish by your front door, leave just a pair of earrings or just a necklace, and have it somewhere that is within easy reach. It's not in a tangled up drawer. It's not going to seem like too much effort to do. It's within reach, and it becomes a daily habit. And just doing this one thing every day can start to build that daily habit of, when you get dressed every day, you always put a pair of earrings in, or you always put a scarf on. It could be whatever feels right for you. This is the beauty of it. It can be completely personal. And I think it's also important, like I said just now, it's not about big transformations, buying loads of new clothes. It's not that at all. It's small acts of self-care. And I truly believe that style is self-care. I think whether that is choosing to spend a little bit of extra time on your skincare in the evening, or whether it's adding a little bit of lipstick before you leave the house. They're small acts of self-care that you're doing just for you. And I think that's the important thing to realise here, is that you're not doing it for anybody else. I think when you're doing it for yourself, even if you're not seeing anybody all day, you're showing up for yourself. And that's huge. And that's a really strong step towards self-care and self-connection. Focus on comfort as well. I think if you're uncomfortable in an outfit, you're never going to feel confident. You're never going to want to leave the house if you're wearing things that are uncomfortable. So focus on comfort. And if that is a baggy outfit, add some jewelry to it. Add something that elevates it slightly and start to build in that daily habit. And those small daily rituals for yourself. So it's that indication that you're showing up for yourself and you're worth taking the time on. That's so important. And all of these things over time build your confidence within yourself. And after a while, you'll stop realizing that you're doing them. They won't seem like effort because they're just a part of your daily routine. Like brushing your teeth in the morning, you don't think about the fact you're going to brush your teeth, you just do it. I think another thing that's quite handy is accountability. So whether any of you are friends or you've got any WhatsApp groups going on in your group, whether you can start sharing an outfit of the day with each other and really have that accountability, that can be really useful too. So let's talk about styling. Now, the beauty of style is that you can go in so many different directions with it, and you can pick and choose what's right for you. You can pick and choose whether you go for bright colours or patterns, or whether you concentrate on cuts. You can go in any direction you like. Now, I was speaking to Siobhan a couple of months ago when I knew that I was going to be doing this chat with you all. And I was asking her some of the common difficulties that can come up with body confidence and areas that a lot of you may struggle to style or feel like, you need a bit of help with. So I've come up with some ideas today, and not all of them may ring true for you. There may be parts of them that, you can sort of mix and match together, but hopefully this will give you some inspiration. So the first one now. So the first body shape we're going to start with it's sometimes when I did my training, it was known as an inverted triangle, but I felt that sounded too technical. So I called it a strawberry because I thought it sounded much nicer. The strawberry body shape, this is where the body shape tends to be sort of broader on the top half. So you would usually take a bigger size on your top half, and the bottom half of your shape, so say hips, legs, very, very narrow, really narrow hips, and the shoulders tend to be the widest point. Does anyone in the room resonate with this shape at all? Lots of you, brilliant. Siobhan said they would be. That's great. Okay, so this is a really fun shape because there's so much that we can do with balancing out this shape. So this is with style. When I'm styling any client of mine, what I'm looking for is I'm always creating balance with an outfit. That's what I'm doing. And what I love about style is that it's optical illusions. You're not changing your shape, but you're balancing your shape, and it's really clever. So there are a few things to note here for this body shape. So probably the most important one I'd say of all is to always try and have a little bit of an open neckline. Now that would be a V-neck or a scoop neck, ideally. The reason is that when you have an open neckline, you're just breaking up the upper body. So it almost narrows the top half. It's really, really clever. So try and opt for like a V neckline dress, V-neckline t-shirt. There's lots of really good basic ones of those in M&S and Next at the moment. I was looking yesterday when I was in Blue Water. Scoop neck t-shirts. So yeah, try and open up the neckline as much as you can. Now, the other thing that's really clever is going for necklaces, because if you have a neckline like mine, if you can see, I've got a bit of a higher neckline here. Now, adding a necklace to a higher neckline, so if you've got, say, a t-shirt like this at home that's got a high neckline, adding a necklace on top, it creates that V shape, so it breaks up the neckline. So you can choose either just a standard, really simple chain, or you could go for a long pendant necklace. So again, see what feels right for you, what appeals to your taste, your loves, your personality. The necklaces are super handy. And the other thing I'd say, we really want to go for detail on the bottom half. That could be texture, it could be patterns, it could be prints, it could be a little bit of lace detailing. There's lots of skirts in the shops at the moment that have got a lovely lace kind of hemline, really, really nice. Anything that has a bit of detail on the bottom half is going to be an absolute winner for your shape. One thing I would avoid when it comes to the top half, because we want to try and balance out this shape a little bit, we want to try and avoid stripes on top. Now that would be horizontal stripes, so that classic, what would be called a Breton stripe. The reason being is that if we add a stripe to the top half, it's going to add width to the top half, which is obviously what we don't want to do. Now you could do that on the bottom half. If you saw a stripy, there's lots of summer stripy skirts, that would be perfect. But what we don't want to do is put that on the top half. So just be cautious of that one. That's one print I would avoid. Fun footwear. Now, I don't know how many of you have been in the shops or scrolling online lately, but everywhere at the moment are colourful trainers, red trainers, pink trainers. I've got yellow trainers on at the moment, which you can't see, unfortunately. But fun footwear, it could be a bright colour, it could be a sparkly sandal. The brighter, the more fun, the better, even if it's a leopard print trainer. So here are some visual examples. So obviously we've got the colourful trainer here on the left. That's really nice. That looks great with a pair of jeans, as in the photo. But you can also wear that with dresses, you can wear it with skirts, you can even wear it with like a nice wide leg trouser and get that really nice smart casual vibe. Leopard print jeans are everywhere. This is a really good way of doing print on your bottom half. So you could do a floral pattern trouser in the summer, you could do a leopard print jean. Again, see what feels right for you, but you can really get away with that detail on your bottom half. We also have texture here of pleats, so pleated skirts. Often there are dresses that have a pleated skirt part to them. Anything that has that little bit of extra volume, a little bit of extra texture is going to be really cool, like a tulle skirt as well. That's really nice. And lastly, on the right, we have this V-neck dress. So you could do a wrap style dress or just a simple V-neck dress. But what we're doing here, we are just breaking up that top line. That's really important for your shape. So that's the best way to style a strawberry shape. Now, let me just grab a sip of water. Okay, the next shape we have the apple shape. The apple shape is actually very balanced. So the shoulders and the hips tend to be in line with each other. Their overall frame is quite narrow, but the fullest point on the apple shape tends to be around the tummy and the bust. Show of hands if anyone feels they have this shape. I think I can see a couple there. Yeah, I've got lots of clients with this shape. So apple shapes tend to, with an apple shape, we want to really enhance the fact that they already have that natural balance. And the best way to do this is with all-in-ones. Now, dresses, jumpsuits in particular are really good for this. So that could be a shorter dress, it could be a midi or maxi dress, it could be a jumpsuit. Anything that's all in one is going to really enhance the fact that they've got that lovely balanced shape. Much like the strawberry, they are really good in an open neckline. So something that I wouldn't do with one of my apple clients is to add too much detail on the top half. So they're better with something that's opening up their necklines. That'd be a V-neck again, a scoop neck again, the necklace trick, absolutely try that. Anything that's a wrap style, so you get lots of wrap style cardigans at the moment, wrap style tops, wrap dresses are really good because the wrap over style is good for skimming over the tummy area. And it also really creates a lovely waist definition as well, which is lovely for the apple shape. Prints and patterns are super handy as well. Usually bigger prints, I'd say, work better rather than like a small floral. You know, I'd go for like a bigger print or one that's got it's a bit more spaced out from each other. And actually footwear can make a really big difference with an apple shape. I would tend to go for a shoe that has a bit of a thicker sole. Really good for balancing out the shape, which is what this is all about. And here are some visuals. So obviously we have the scoop neck on the left. That's showing off the really nice neckline. Then we have the chunky trainer second to the left. So you could do a bright colour or you could do a white trainer. I'm never a massive fan of a black trainer. I just don't feel like they style outfits quite as well. So I'd always opt for either a white trainer or a colourful trainer. And that would be for everybody, is the advice I'd give. Got a jumpsuit. So jumpsuits can be all different types. You can get really dressy jumpsuits. I've worn jumpsuits to weddings, for example. Or you can get like this one. This would be classed as a boiler suit because it's got long sleeves. That's the difference between a jumpsuit and a boiler suit. So that would be really good for their shape. And then we've also got this wrap style dress. So that dress is perfect because we've got the print. The print's nice and big. The print's spaced out from each other. And it's got that lovely wrap over style that's creating the waist. So the next one we have is the pear shape. So my pear shape clients, their problem area tends to be their legs. That's the area that they struggle with. They're not so keen on things like skinny jeans. They really struggle with things like that. And they tend to be a bit narrower on their top half. Does anybody resonate with this body shape? Couple there I can see at the back. So with a pear shape, this is the opposite of the strawberry. So they tend to be narrower on their top half. And we almost want to do the complete role reversal of what we did with the strawberry shape when we create balance with a pear. So with a pear shape, we'd always do a higher neckline. So that would be a crew neck like this. It could be a roll neck in winter, like a roll neck jumper. I would go for stripes on top with a pear shape, really good. Purely because we're trying to add that balance to their top half. The stripe is going to widen the top half. So it's a really clever optical illusion. And also texture is really handy on top. So that could be a cable knit jumper. It could be a broderie anglaise blouse in the summer. And I'd go for minimal volume on the bottom half. So I would probably avoid things like pleated skirts. I'd avoid that added texture and the added print on the bottom half, just because we're trying to create that balance. The best cut for a pear shape is always a wide leg. It's a really good cut. And this cut has been really popular over the last couple of years with wide leg jeans in the shops, wide leg trousers, and they're super comfy as well. So if you're really hot in the summer and you don't want to be wearing shorts, a lot of my clients feel really uncomfortable wearing shorts in the summertime. So wide leg cuts are really good for this, like a wide leg linen trouser, for example. And we want to try and accentuate the waist as well. So here are some visuals of things I would recommend for a pear shape. So we've got a slogan t-shirt, or you can do, like I've got a graphic jumper here. Anything that has a little motif or a graphic on is really good for a pair. Tailoring is really good as well. So that could be shirts, it could be blouses. Blazers are brilliant. Blazers are really good for all body shapes, to be honest. They're really good for making jeans and a t-shirt look really elevated. But blazers and anything that's really that sort of sharp tailoring is really good for a pear shape. And then we've got the texture here as well. So we've got the cable knit jumper. That's really fab for adding a little bit of structure to the top half. And then we've got the stripe as well. So as we can see here with this striped top, if you're a pear shape, you can also add a bit more to it. So like in this photo here, you could add a pattern scarf to it, do a bit of a pattern clash, or you could always do a colourful necklace with the stripe. So the more texture, the more detail we're adding to the top half, the better. And then the last one that Siobhan said, these are our rectangle body shapes. Now the rectangle shapes tend to be, again, they're very balanced, but their overall frame is very slight. They don't tend to have obvious waist definition. Does anybody resonate with this type of shape? I think I can see one. So with the rectangle shape, we kind of add all of the other pieces together. So we add the pear shape and the strawberry shape together. So with this shape, we want to try and add as much detail as possible, because this is going to, it's a really good way to sort of add shape, add curves. So higher necklines always work really well for a rectangle shape. That could be a crew neckline. It could be a roll neck jumper in the winter, but higher necklines work much better than a V-neck. Stripes on top, much like the pear shape, but also, unlike the pear shape, we can do what we did for the strawberry and add texture and structure to the bottom or the top. So we could go for a pair of white jeans in the summer, which adds a bit of detail to the bottom half. They're not so good in the chunky footwear, so the chunky trainers I probably would avoid for a rectangle shape. But the key is with a rectangle is the more detail, the better. That's the key here. And ideally smaller prints. So whereas the apple, we wanted to go for those larger prints, the prints that are a bit more spaced out, I would be looking for a rectangle shape to be going for those smaller, like a ditzy floral, as opposed to a larger floral. And these are just some visuals. So rectangle shapes work really well with drop waists because it creates dimension, which is, you know, I wouldn't want to go for a straight up and down dress with a rectangle shape. I'd want to be adding some dimension there somewhere. So drop waists are really useful. They're really good with ballet pumps as well. Lots of ballet pumps in the shops at the moment. Lots of cute colours, got suede ones, you've got leather ones. Rectangles are really good in layering. So you could do like this lady has here. We've got a sweater vest over the top of a dress, but you could also layer shirts underneath jumpers as well. So layering works really well for a rectangle because we're just adding more detail. And the skirt on the right, this is a skirt that's cut on the bias. So again, we're just creating a little bit of dimension with the rectangle shape. Now, what I would love to stress to everybody is that as much as sometimes it can feel like clothing is and that shopping in itself is a really exclusive experience, it's a tool that absolutely anyone can use. It really is. And as I said at the start, there is, and I say it twice because I think it's so important to emphasize it. There is no right or wrong. I genuinely mean that. There's no right or wrong. I think the only way to do it wrong is to dress in a way that doesn't feel like you. It's so important to dress in a way that you love, because I think you're just you're going to build a better relationship with yourself and using it to your advantage. So you can use, like I said earlier, if you love black, that's absolutely fine, but maybe look at adding some accessories, or maybe you love a pattern, maybe start trying to clash patterns together, you know, see, just, it depends on your particular style. Something I think is a really interesting thing to think about, and this is something that I really love, I love to encourage clients to do, is to create a unique style hook that sings to you. Now, when I talk about a style hook, this is something that you wear all the time, or something that people then start to associate with you. So, for example, for me, I always wear hoop earrings. So whenever anybody sees any funny quote about hoop earrings or anything like that, they tag me in because they're like, oh, Susie, in your hoops. Diane Keaton, the late actress, always wore hats, always wore suits. You had Anna Wintour, the ex-Vogue editor, who always wore sunglasses. There are lots of celebrities, lots of people in the public eye who have that unique style hook. And many of my clients have really enjoyed creating their own over the years. So some of my clients, their thing is leopard print, and they'll always wear something leopard print, whether it's a headband or a belt or a bag. There's always leopard print somewhere. One of my clients loves lime green. So anytime I see anything lime green, I always think of my client Charlotte. So maybe start having a think. Is there something that you'd love to create that is uniquely yours? A style hook. It's a really, really fun way to start playing with your style. I'd also like to encourage you to be open-minded about where you shop. I think so many of us worry about shopping in places that are too young, too this, too that. And I can assure you there's no age limit on shops. There's no siren that will go off when you walk into a shop. It's always good to be open-minded. Even if you walk in and walk out again, you've still gone in and you've had a look. And even if you just get inspiration, that's a win. And I think gaining inspiration from all around you, I love nothing more than people watching. I love seeing how people put things together. When I'm watching a program, I'll always be inspired by colours or how different characters have worn things. Inspiration can be gathered from all around you, and that could be whether that's the art that you love, whether it's the music that you love. These are all ways that you can start to develop your own sense of style and what you love. So how to get started? So as I said earlier, we need to start small. We don't want to go in there all guns blazing, because I think it's really important that you go at a pace that feels right for you. And maybe that is going and having a mass declutter at home. Maybe having a big overhaul is right for you. But in my experience, most people start with a more gentle approach. It's a case of getting curious. So have a little look in your wardrobe and just start getting curious about the pieces that you always reach for. You know, why do you reach for them? What is it about them that you love? How can you make them look slightly different? How can you wear them slightly differently? So my client this morning, who I had the video call with, she was saying to me that she said, I've got all these really nice dresses that I wear in the summer, and in the winter I just live in jeans and I'm really sick of it. And I said, well, why don't you in the winter, so now, because I know we're in the spring, but it feels like winter, why don't you start looking at layering things underneath the dresses? So you could do like a long sleeve thermal t-shirt underneath your dress that no one else will see, and then leggings underneath the dress. And then that's a way to make it wintry, add a pair of boots. So maybe start looking at ways that you can get a bit more playful with your wardrobe. Quite often you've got all the tools already. Quite often you may be missing something. You might find that you've got lots of pattern, you've got lots of sparkly things, but you don't have the basics to mix in with that. The basics are quite often, I was saying to my client that it's a bit like making a cake, and you've got all the nice stuff. You've got the icing, you've got the sprinkles, you've got all the fun stuff that goes on top of the cake. But if you don't have the butter and the flour, you can't make the cake. And the basic pieces are the foundations of your wardrobe. So just start having a look in your wardrobe and get curious. Have a regular check-in with yourself about your style. Notice the days that you feel good, or you feel, you feel fun in your outfit, or notice the days that you don't feel so good and check in with those as well. And the more you check in with yourself and the more you get curious, the more you start to understand what feels right for you. And like I was saying earlier, I truly believe in accountability. I think any time that you can get a little WhatsApp group going, or just a close friend of yours that you can say, do you mind if I just share some outfits with you? Make sure it's someone that's really one of the cheerleaders in your life. I mean, I like to think, I can see lots of you in the room here, whether you could create a little group between some of you. You could have 5 days wearing a bright colour and all share a photo to the group. It's really useful for accountability, particularly for people that, a lot of my clients don't leave the house all day. And actually that accountability of having a group that you can post to every day gives you that purpose and showing up every day. And what I'd love now is, when I do these sessions, there are so many questions that come up. I love a Q&A session. I love helping as much as I can. And if there's anything you'd like to ask, I'm here. So does anybody have any questions? Trying to see this. Oh, there we are.
Hi, Susie. Thank you very much. Really appreciated. I'll start things off. So one of the things a lot of the people in the community struggle with is quite muscular appearance and leaving women feeling less feminine. So how would you style that in a way that makes people feel more feminine?
I think I would look for, to add touches of femininity would quite often be a print. So that would be things like floral prints. I think fabrics can be useful as well. So silky fabrics, whether that's like a nice satin shirt or something like that. There's some really nice silky skirts in the shops at the moment. I think prints can be really useful. So that could be polka dots. Polka dots are really associated with femininity, as are florals. And you could maybe go for touches of those. Pearls as well, little pearl earrings. I'd go for those as maybe, instead of, say, like a hoop earring, go for those slightly more feminine touches. But I think fabrics and prints, I think, are two of the most powerful things.
Thank you.
Hi. I think I fit into 3 of those categories, like strawberry and rectangle and the apple. And I'm going to be 60 this year, but I've never been able to wear a skirt that's, like a wrap skirt, anything that needs a waist, because I just look like a barrel. I just look like a barrel with a skirt, and I've got no waist. So I've just sort of, I've just always found it hard to style myself, and then I've just done my own style over these years, because I used to watch, This Morning, and they would say, oh, this style will suit everybody. And I'd sit there waiting for the style that was going to suit me, and there never was one. So
is it the waist area that you struggle with most?
Yeah, because I've always looked. I've been asked for the last, I don't know how many years, 40 years, if I'm pregnant.
Oh, that's so tough. I'm really sorry.
It's like, how do I do? What do I do about? Well, I do my best and say thanks for thinking that. I'm a grandmother.
Yeah. I'm sorry about that though. That's never a
That's
nice thing for
my
somebody.
struggle, but I didn't obviously know there were so many people until I was diagnosed that this is a thing, I guess, you know, that we do struggle with the tummy bit, isn't it?
Do you know which sort of skirts you've tried so far? Is there a certain style that you have tried?
Do you know my trick? What I've done is I've worn short skirts to show my legs because everyone, you know, the way they look, the muscular, you know, they look muscular, and then sort of things that are like maybe Bardot dresses and things, so off the shoulder, things that then sort of I just dress from there to there without having a waist, and that's what I've got best with for me, that I think I look best in. But I'll give your ideas a try. But I think I'm past it now.
No, absolutely not. Never. I mean, I actually think something that could work really well is maybe going for something that's more fitted on the bottom half. Because I'm thinking in terms of proportion and balance, which is how I work, rather than something A-line that we're going to tuck into. I don't think that's going to work. I think you're better with something a bit more close fitting. Maybe like I was saying about the skirts that are cut on the bias. They're really good for kind of skimming over the tummy. They also create a waist as well.
I don't think, not on me, when I've not liked that for myself. I do wear like the tight stretchy skirts, or I wear tight jeans, and now I wear thick leggings under trousers, like baggy trousers, and then that actually works as well, layers. And then when I get hot, I can just take the layers off.
Yeah, definitely. Have you ever tried tailored shorts instead of a skirt? There are some really nice, like smart black shorts that can work instead of a skirt.
Do you know, the thing with my shape is I'm like a 12 on top, and then I'm a 6 to 8 on the bottom. And then you need it stretchy to fit your waist, otherwise it's too baggy on your bum and legs. So it's really hard to find. When I find things, I'll buy 2 or 3 colours, you know. But it has to be tighter, and then you need a stretchy waist sort of thing.
I think you're doing the right things, and I think the shorter, like you say, the stretchy, like shorter skirts are good. I think maybe a bit of extra texture could work really well. Do you know, like the tulle skirts that have got that mesh skirts? I think that could work really well for you as well. And they tend to have more of a stretchy waistband, so they'll be a better fit.
Because of my height, I'm like 5 foot, so I end up wearing those skirts as a dress. I just pull them up, and because the waist, it will sit, and that's how I've tried to, I've just had to find my way through this life. But
yeah, I think it sounds like you're doing all the right things. Honestly, it does. I think I would maybe just play around a bit more with texture, prints and patterns, try and add a little bit more to the bottom half, because it sounds like we can balance things out a bit more with some more detail on the bottom.
Yeah, I do. I mean, I've got cargo pants I wore here that are full pockets and everything. I do vary. I'm not a straightforward person, but when I find something, I buy a few of them.
Well, I think it sounds like you're absolutely on the right track.
Hi, Susie.
Hi.
Just a quick sort of top tip, really. I think with the rectangle, the inverted, or the strawberry, and with the apple, today's fashions at the moment are very much like tuck in, and that's something we really struggle with, because we've either not got a waist, we've not got hips, so everything either falls down, or you've not got something that can really define. Have you got any tips for how to combat that kind of fashion?
Yeah, definitely. And actually, I think the whole tucking in thing is actually becoming less popular now. Actually, the styles that are more popular now are untucked. I would say if you're going for tops that are untucked, I would always go for a more fitted bottom. So my golden rule is if you're going to wear something looser on your bottom half, I'd go for a more fitted top half. And if you want to go for a looser top half, go for something more fitted on the bottom. And that way you can get away with things that are untucked, because I'd say 80% of my clients don't like tucking things in. I think it can be really uncomfortable for a lot of women.
A couple more questions.
Hello, I'm what you might call a big strawberry, both in terms of having a lot packed around my abdomen, but I'm also tall. So I find most women's tops are simply too short for me. So I end up having to buy men's t-shirts, and that really restricts my colour palette. Do you have any suggestions?
Yeah, that's really tough. And you know what? I'm tall as well. I'm over 5'9", and I actually think tall clients have the fewest amount of choices out there. There's a really good website I can recommend called Long Tall Sally. Long Tall Sally have got, it's a shame they used to have some shops, like in-person shops, but they've got a really good website now. Long Tall Sally are really good. Also Next do a tall range, New Look do a tall range, and there is where else would I recommend? There's a brand called Hush. It's kind of like, it's a bit more premium, it's sort of high-end high street, but the fit of their clothes works really well for curvy women, and it works really well for tall women as well. And they do quite a good range of colours.
Thank you. I have to say, Long Tall Sally doesn't really do tall, curvy women. They're a bit tall and slim. I've tried them.
Oh, definitely try the others then. Try Next Tall and check out Hush as well.
Hi, I really enjoyed that. I think there was definitely some things. I was looking at my outfit thinking I've done well today, because I was definitely have applied some of the things without realising it.
Oh, brilliant.
And I think it's definitely finding the right thing where you feel good, and where you find something where you don't feel like that, and it's accentuating the bits of your body that you like, which we all in this room knows what it's like when you wear something that works for your body. Also kind of the tall, I think strawberry, I've always said I'm quite up and down, but I think probably from that slightly more strawberry, but I kind of find that dresses are really helpful, and also the V-necks. One of the things I really annoys me, sometimes I'll see something that's brilliant and it's a shirt dress. I never look so ridiculous as something that's a shirt dress, because it really it emphasises your straight up and down, and it also makes, and it emphasises your stomach. They're absolutely a nightmare, and they're everywhere. So I'm just going to say dresses can be really helpful, but avoid, from my experience, I don't find those very helpful. But I think it's definitely given me some things to focus on for future outfits. So thank you.
Oh, you're so welcome. And I echo what you say about shirt dresses, and even shirts in general. I think the issue with them is that they never put enough buttons. So what happens is you end up so many gaping issues with shirt dresses. There's a really good website I can recommend. It's quite a small business. It's an independent business called Popsy Clothing. They do dresses quite often. Most of them are V-neck dresses, lots of prints, lots of patterns, really comfy. So if you're looking for dresses that, have a bit more shape to them than a shirt dress, Popsy Clothing are really good. I'd recommend them.
And just before you go, Susie, you sent me some little cards, and I've put them in the goodie bags for everyone. So if you could maybe just explain what they are.
Of course, yeah, thank you. So I created these cards a while ago. They're called compliment cards. And I think we've all been out and about when we've seen someone in a really nice outfit, or seen someone with a nice pair of shoes or whatever, and you really want to tell them that they look nice. And quite often it can be scary going up to someone and actually telling them that. So I created a compliment card, which is designed to just pass on the joy. So if you see someone that's wearing a nice outfit, hand them the card, and the card literally says, "You look fab today." And it's so lovely seeing how happy people are when you give them the card. And the idea is that they then pass on the card to someone when they see a nice outfit on somebody else. So it's basically spreading the joy. So you can pass one to each other in the room, or, you know, keep it for next time you're out and about. But it's all about spreading that joy and confidence around women, because I think we can do so much to build each other up along the way.
Thanks so much, Susie. That's really interesting. We're just going to take a couple of minutes because we just need to get some chairs set up at the front. So don't disappear, but obviously just maybe stand up and stretch your legs just while we rearrange things for our next section. For everyone else to pass around. Yeah, so you just put it and then they can pass it up and down and you can keep right one. Right, needs water in it.
Just sit one end and they can, or should I sit in the middle? Or sit on one end?
I think sit on the end and talk to me.
I apologise. I was quite got it, to be honest. I was thinking, I just thought of you and thought, so what did you learn? Florals? Florals fit you best? So florals. Yes. So florals. What are we talking about?
Where's your phone?
So what are we doing here?
Coming up. Come up.
So the grandmother.
Lily.
What's here today? So I'm terribly late. I thought somebody else was going to introduce. What's you?
I'll be Rob. I don't want to remember.
No, I know you are.
Okay. We've got one microphone for you guys. Okay. So just share it along the road. We'll stop with Catherine.
Yeah, we'll start with. I'm really shy and retiring. You do know that.
We good? Okay, thank you everyone. So we've had a great couple of sessions so far, and we've found in the past that our patient story sessions have been the most popular and really valuable for people. We've really enjoyed doing that. As you know, Louis spoke last year along with Rosie, and that was a fantastic session. And so we've decided to extend that a little bit and just change up the format a little, so to make it a little less, hopefully, intimidating for our speakers, rather than getting them up on their own to present or talk to you. We're going to do it as a kind of fireside chat. So I'm going to kind of ask some general questions, and we'll pass it down the group to speak. And then at the end, so we're going to cross this across the break. So we'll do some questions first, we'll have a refreshment break, and then we'll continue after that. And at the second half, towards the end of that, we'll do a Q&A session from the group. So it's really good if you've got any questions for anybody up here, for myself, that would be fantastic. So try and get involved if you can. We have Catherine with us, Lily, Louis, Michaela and Craig, but they're going to give a little introduction to themselves. So let's start with just saying that, you know, these are personal individual journeys. Nobody needs to share anything they don't feel comfortable sharing, but just respect the fact that these are individual experiences. Nobody's given advice to what you should be doing. They're just sharing their story and their journey, and respect the fact that it takes a lot to come up here and talk to a room full of people, a lot of which are strangers, okay? So be kind. We're here to respect each other, so no judgment on bodies, treatment choices or coping styles. And we'll have one voice at a time, so speak up, say what you want to say, but then give an opportunity for other panel members to speak. And as I said, if there's anything you're not comfortable talking about, you don't need to talk about it. We can move on. Okay, so let's start with introduction to the panel. So maybe you could just give us a kind of quick 1 minute summary of whether it's you or someone in your family that's affected, where you are in your life, and you know what your family dynamic looks like, what your connection to lipodystrophy is, and one thing you wish people understood sooner. And let's start with Catherine.
Hello, can you hear me? Is it working? Okay. My name's Catherine Ellison. Where am I in my life? I'm a crone. So I am a grandmother of 4. I turned 60 last November, although my granddaughter says it's 6 because 0 doesn't count, so I'm going with that. I work full-time for the NHS. I'm a very busy person. I have lipodystrophy, partial familial lipodystrophy type 1. I was diagnosed about 25 years ago, and it's been quite a journey. Anyway, here's Lily.
Hi, I'm Lily. I'm 18 and I currently go to college and do creative media. So I make films, which some of you might have seen on Facebook. I have familial partial lipodystrophy type 3, and I was diagnosed when I was 16, and I live in Pembrokeshire in Wales.
Hi, I'm Louis. I'm 16 at the moment and I'm in 6th form. My favourite subjects are politics and anthropology. I have generalised congenital lipodystrophy, but that's part of a bigger condition called MDPL syndrome. Yeah, I think that's it.
Hi everyone, my name is Michaela and I am a mom to Louis. I've been parenting for 16 years. well, almost, 17 waist. And I've got a daughter, Jessica, over there, who I've also been parenting for a little bit longer. I guess in terms of lipodystrophy, a big part of that is supporting Louis with his lipodystrophy and his medical conditions and advocating for him, which I'm sure we'll talk about a little bit later. So I think we're probably at that transition stage now of Louis going from children's services to adult services. So we're kind of in the middle of negotiating that and moving over. So,
Hi, I'm Craig, Louis' dad. Where I am in my life, probably I'm lucky in my career that I can work from home a lot, which allows me to support Louis with taking him to and from school and making myself available. So I feel I've been lucky in that respect. But that's one of my main focuses.
Great, thank you very much, everyone. I suppose, just in case there's somebody who doesn't know who I am, you've probably all heard my story a million times, but just in case you don't know, I'm Becky. I'm the founder and chair of Lipodystrophy UK. I was diagnosed about 25 years ago when I was 17. I'm, by trade, a molecular biologist scientist, which helps kind of understand a little bit about how this condition works. That's me for now. So I'm going to let everybody else do the talking for a change. Okay, so let's start with road to answers. So everybody has a different journey to diagnosis. Lipodystrophy can change appearance and bring significant metabolic complications, and many people experience delayed recognition and long diagnostic journeys. So let's go back, think to pre-diagnosis and talk about the earliest signs that you experienced that you now know are related to lipodystrophy. What did you first notice, or what did other people notice? And you've got the mic, Louis, so you're going to have to go.
To be honest, for me, I was diagnosed quite early on in life, and so I don't actually remember that much. So I'll probably pass over to my parents because they can tell you more about what they noticed.
Thanks, Lou. I'm going to pass to Craig. So I guess we probably started noticing Louis maybe not thriving quite early on. So I do remember at the 2-year check probably was when we started asking questions, noticing that he was a little bit smaller than, children of his age. And I guess for us, it was about doing the work ourselves, and we had to push for lots of appointments, which was something that we continued to do. It was really difficult. No one really wanted to listen at such a young age, but I think as parents, you know your children and you know that perhaps something isn't quite right. So I think we would often go to see a paediatrician and we would get told, we would go with some of the things that we were concerned about, and we would often get told, well, come back in 6 months, let's monitor that and see how it goes, and come back in 6 months. And it was really frustrating, and I think probably not having the confidence so much in Louis' younger years, we would feel frustrated but perhaps not challenge that. And I think that as the journey went on, that was something that we definitely did better and did more, and still continue to do that. So I think for us, advocating and feeling like doing our research before we go to appointments is really important, and going with asking what we want from that doctor. So referrals to other services, I think. I think actually we also met someone who had a different condition, and I think she gave us the confidence to ask questions. So again, she spotted some signs in Louis when he was younger, and it kind of resonated with her and her son, and she told us about her story, and I think that just gave us the confidence then to start asking more questions and being more direct. So,
and that's it, isn't it? It can be really difficult because often people are made to feel like they're making things up. What are you worried about? Or told that you're just not compliant as a diabetic, and it's trying to remember that as the patient or the parents of a patient, you are the expert. You know your children better than anybody. You know yourself better than anybody, and not to be allowed to be dismissed. That's easier said than done, but yeah, it's difficult.
Yeah, no, for Sure. I think one of the stories that probably sticks in my mind more was relating to Louis' hearing loss. And we noticed when he was getting colds and was a bit fluey, his ears would get blocked and he would lose quite a significant amount of hearing. So we pushed for tests, which again took a long time. And when we did eventually go to that service, it was more of an adult service. It wasn't really set up for younger children. And then Louis got accused of lying. And it's just really disheartening, you know, and he told Louis, he said, you know, stop lying, otherwise your mum's going to take you outside. And it was, yeah, it's really difficult when you're coming up against things like that. So, yeah.
What about you two? Do you want to share something?
I think looking at my childhood, maybe about when I was about 7 years old, you can really start to see in pictures my face getting more fat. Especially compared to other people. And another thing was hunger. I would eat, like at lunchtime I'd have seconds and I'd have pudding, and then I'd, on the way back from home, I'd have a sandwich, crisps, and then I'd have a massive dinner, you know. So that was, but that, because obviously when you're a child, you don't, that's just normal because it's like, oh, you're just growing and or it's baby fat. So that obviously wasn't a massive concern, but then I think when I started to see something wrong was probably I've started to get symptoms for diabetes, and I had quite bad acanthosis, which if you don't know what that is like dark skin under your arms and things when you have diabetes. That, and then I had all the symptoms for type 1 diabetes as well. So I think that was probably the biggest thing.
I was, when I was 28, I was diagnosed with type 1 diabetes. I was popped in hospital for a week and they gave me an orange one day. And I said, what's that for? And they said, that's to practice injecting yourself. So I ate the orange and just injected myself. It seemed like a waste of an orange. But the thing was, I bent needles because I've got no fat on my legs. And it became very apparent very quickly that I couldn't inject in my legs, I couldn't inject in my arms, so I could inject in my massive stomach. But after I'm 60 now, so that was 28, it's a few years ago now, I ran out of places to inject, and I'm struggling still to find where I can inject because I'm lumpy. And it's quite hard, but it's, you know, needles bend. So I'm bound to injecting here. But my biggest problem was that when I was first diagnosed, and you know, once I got beyond eating the orange, I was injecting regularly, but it wasn't working. So I'd be told that I was non-compliant, that I was a bad diabetic. I'd go to an appointment, they'd get the tape measure out. The tape measure would have to get longer and longer. And I got really down about it. And I was sent to see several counsellors because I was being non-compliant. I've never been non-compliant in my life. Until I got to the point where I thought, I'm not going to take any more insulin. And I lost quite a lot of weight. My blood sugars were off the ceiling, but that wasn't good enough either. So I started taking insulin again. But, you know, after 30 odd years of diabetes and insulin, I've got retinopathy in both eyes. I've got no feeling in my feet. I've got the sort of autonomic digestive issues. And you know, long-term anything, you get side effects. And I create plenty of insulin, I just can't use it. And it was really useful going and seeing Dr. Steers and her team, who said to me, you're massively insulin resistant. And it was like, I am? Oh, so that's why it doesn't work with me. And despite I injected 7 times a day at one stage. And it never worked. And I used to get really down about it and be told you're a bad diabetic. And it was horrible. And then eventually I was told I ought to consider bariatric surgery. And that's been a whole new ball game. I've been rejected 6 times currently because I'm not fat enough. I have a BMI, if I stand on normal scales, of sort of 34-ish. When I was put through a DEXA scan, my BMI is 43.7. And I have, as I say, it's 53 inches. It's not a waist, it's a girth. So, and that's where I am. And I've been trying to get accepted by various NHS trusts for however many years and being rejected repeatedly. So I've had to go down the private route, and I'm still on that private route. And I spoke to a really lovely private surgeon who said, "This is ridiculous. I want you to go back to your GP, and because you're a tall girl, I want you to bend your legs slightly while they measure you." I've now been accepted by the NHS. I've lost about 3 inches, I think, so I've lost a lot of height. But the problem is 2.5-year waiting list. So I had an appointment last September, and my next appointment's July. And I've now been told that I potentially have liver failure. And so I'm a kind of an interesting, every time I go somewhere, they find something else that doesn't quite work. And it's just like, oh, well, whatever next. And people say, well, you're so chilled about things. But every time you go somewhere, they find something else, and, oh, you're very unusual. Oh, you're quite a complex patient. It doesn't make life...
Fed up of being unusual.
Yeah, I'd quite like to be normal, whatever that is, but I don't really know what it is. So life's been a challenge, but, there's lots of positives to take from it. And I had diabetes tattooed on my wrist a few years ago, probably about 25 years ago. And the guy who did it said, "Why do you want this on your wrist?" And I said, "Oh, I just quite like the net." He said, "Was it?" And he said, "Well, do you like the word or something?" And I went, "No, it's because I am actually diabetic." But that's been a conversation starter. And I'm not a shy and retiring person. And it's really good because the amount of, oh, my grand's got that, or my so-and-so's got that. And it's a conversation. It always terrifies me, though, when people say, "Well, if you had a hypo, I'd just have to give you insulin, wouldn't you?" Which makes me very nervous. But it's been an education, and there's lots of positives I can pick from it. And I've tried to make sort of life an interesting, positive experience. And, every time I get told all this, that, and the other, I did say to the hepatologist, "Well, you've got to die of something." She was terribly apologetic. But because, life's like that, and everyone's got some story under there. I would like everyone to know, however, I am not pregnant. That's why I let my hair go white. Obviously, I'm too old anyway. But for years and years, people said, "Haven't you had that baby yet?" And there were days when I was feeling quite flippant. I'd say, "Oh, no, I'm not pregnant, I'm just fat." And other days, it crushed me. And I'm sure we can all identify with that. So, but it hasn't all been a negative story. I'm still here. I'm still making fun and having sense of humour about life. So it's not that the downward spiral, but, it has been a challenge.
Thank you, Catherine. I want to ask a question to our young people on the panel. So, I'm saying I'm in the same category as you, Catherine. Lily and Louis, can you talk us a little bit, if you're comfortable, about how puberty or young adulthood intersect with changes in body shape or health, and what did you need at the time?
And I think when you're going through puberty or not, and everybody else around you is going through similar changes, it's a time where differences become really apparent because, there are kids in my class that, 6'2", and I hadn't even crossed 4'10" yet. And when you're smaller, it's not as noticeable, and then suddenly everybody else shoots up and my neck aches every day. So I think that's really difficult, but also as people grow up physically, they also hopefully grow in maturity as well. And I feel like as I've gotten older, the way that I can look at my own condition and how other people look at my condition has sort of come to be more similar. And I feel like you get less of the stares in school, you get less of the intrusive questions. And I think for me, I've really enjoyed being in an environment where I'm surrounded by older people because there is just that more maturity there.
And I guess it helps that you're such an advocate in school, right? You talk about your condition in schools. Do you want to talk a little bit about that?
Yeah. So I'm part of school council, and we get to choose a charity each term. And I thought, why not choose Lipodystrophy UK? So we did an on-school uniform day and cakes out, obviously things like that. But I thought, instead of just raising funds for the charity, why not actually do something in line with the charity's ethos? And so I thought we can spread awareness. And I'm lucky. I'm in a lucky enough position in school to be close with a lot of people and have a good support group. And so me and a lot of my friends who are also in the school council did some assemblies to my year, and then eventually we extended that to other years. And we just explained what lipodystrophy is. I think when you can come to terms with your condition and figure out ways that you can help yourself and other people can help you, it's really important to communicate that to other people, because in those assemblies I could say, you know, I might be struggling to walk on this day because X, Y and Z, could you just give me more space in the corridor, or things like that. And just the complete attitude change that people had to me in school was so amazing, because I just felt respected, and like raising that awareness was really helpful.
Yeah, by letting them know you're destigmatising it, and
Exactly.
rather than just remaining ignorant and therefore not being aware of what your needs are, and because they don't know, they poke fun. Actually, it's giving them an opportunity to mature a bit and be more mindful of interacting with you. That's fantastic. So thank you very much, Louis. That's brilliant. Yeah.
And I think that is one of the things with a lot of people in general, is that most people, when they stare or when they ask questions, they're not being malicious. It's usually just comes from a place of ignorance. Like, most people aren't intentionally pushing into me in the corridor or anything like that. It is just a culture that is there. And so if you can destigmatise that and raise awareness, then that will make positive change.
Perfect, thank you. Lily, what about you?
I think it was difficult as a teenager, especially being a girl, because there's obviously a lot of milestones that come with being a teenage girl. So obviously menstrual cycles and things, and it's like you don't meet the target, you know, later, you haven't started it yet, you're not growing, and then you get facial hair and it's like, oh my gosh, what on earth is happening? And it's so it's very difficult, especially with how cruel teenagers can be. I think girls do put a lot of pressure on themselves with their appearance, so that does make it difficult. And I also struggled with finding things to wear, because I had quite a big tummy and a big face and things. But yeah, it was quite difficult. I forgot what I was going to say.
Well, that's perfect. Thank you. That's really helpful. I'm going to pass it down to the parents in the group. Can you talk to us a little bit about what advocacy looks like for your son at school, with clinicians, at home?
I think we've been very lucky with Louis' schools. I think it was definitely a factor when we was looking at schools that we looked for one with a good environment. But I think the most important thing is engaging with the schools early. So even before diagnosis, we knew there were differences with Louis, so we had those conversations with his teachers and the senior leadership team within the school. And one of the, I think, most beneficial things we've done for Louis was special measures for his 11 plus and exams early on. So we met with the headmaster, and there was a feeling that because Louis was achieving, that he didn't need additional measures.
Probably working twice as hard as everybody else in order to do that,
yeah,
right?
especially with the hearing loss and the fatigue. But we explained the condition, and we put a strong case forward, and we argued that it was for Louis to reach his potential, not just to achieve. And I think having that in place has been passed up through the school system, and it's helping him now.
Fantastic. Lily, did you want something to add?
So I was very lucky because when things started to get, like the fatigue and things started to get a lot worse, my mum started working at a special educational school. So for children with like anxiety. So it was only had 20 people. So I was able to go there and be with her, which was great because I was the oldest one, so there were no pressures of looks and things, which was great. But I think something that I really struggled with was the tiredness, and because my diabetes wasn't treated properly, so my blood sugars were high, and I really struggled with my GCSEs because I think my mum wanted me to do maths and English early because in case anything happened. So yeah, I did. I've only got 3.5 GCSEs because I was so exhausted I couldn't learn properly, and I think that was a big thing that affected me. I think thankfully I live in such a small area, but I think if I was living somewhere else with a lot more people trying to get into colleges and things, I think it would have been much harder. So I've been quite lucky in that sense.
And again, it's upsetting because people will look at you and think, well, you know, what are you talking about, fatigue? I mean, you're 16, 17, 19 now, but, you know, they don't understand it. And on the surface, you look like any other teenage girl. And that lack of understanding really has a massive impact. And also that will then affect your self-confidence because they're telling you these things and there's no provisions in place to support you. But hopefully you're in a better place now. Yeah.
I used to be really sporty, like all the time, sports all the time. And I found that as I got more fatigued and I started to gain more weight and things as I got older, I found that a lot of doctors, because I obviously got more muscle pains and things, and a lot of doctors would immediately think, oh, you're just lazy, you know, things like that. And I actually do still get that. They don't understand that if I try and do things like that, my will, like, I mean, the other week I went to the gym for the first time in God knows how long, it was the lowest weight on the machines, and I've now got a massive bruise on my arm because it's pulled it. So, you know, I can't do what I used to be able to do. So it's quite difficult.
And that's part of the frustration, right? You kind of have to adjust to what your new normal is, particularly in subtypes where it doesn't necessarily present itself that well before puberty, and then after puberty, all of a sudden, you notice the difference. So in Louis' situation, you knew there was something different early on. Not that that makes it easier, but at least you're not changing, right? Whereas with a later onset, all of a sudden you can't do the things you used to do, and that's really tough. Catherine, looking back, what do you wish you'd known earlier about health monitoring, self-image or support?
I wish I realised I was so insulin resistant, because that would have explained why, however much I battled, I was just always being told I was a bad diabetic, and that really did impact me because, you know, I was always a high achiever when I was younger. I was a good athlete. I was a good student. And I've never been one of those people who sort of deliberately went out of my way to be difficult, unlike my younger sister who excelled in that. So I remember my parents, I begged them to send me to boarding school when I was a kid. Begged them because that idea was just perfect for me, and yet they threatened my sister with boarding school because she was so badly behaved. And I always thought, how unfair is that? So for me that was difficult because, you know, and I went through life sort of with 2 quite small children, not the most supportive husband. Still not the most supportive husband, I hasten to add. But you know, and as a result, he doesn't have a clue, and he's, you know, as long as it revolves around cars and wheels, that's his life. And so I've always had to get on with it. My family are all in Australia, and I've, you know, and I've got some close friends, but I've had to do everything independently and just get on with it. And that's fortunately the sort of person I am. but that the idea of failing and being told you're rubbish as a diabetic and I was going to end up with everything and I was going to die early, and they didn't hold back. And at one point I was taking 1,500 units a day and it didn't work. And now I know why. And that was revelationary to me, you know, really made me realise that actually I wasn't a failure. I was just somebody who couldn't cope with it. My body doesn't cope with it. So that was what really was helpful to me.
Thank you. Obviously, most people in this room have had a really difficult and long diagnostic journey, and I just wanted to do a quick show of hands. How many people here have had a diagnostic journey longer than a year? What about longer than 5 years? Yeah, see, almost everybody still kept their hand up. Yeah, and beyond. Yeah, unfortunately it's very common generally for rare diseases to get a quick diagnosis, and I think the average is roughly 7 years, which is obviously very difficult because in the meantime you don't have answers or you're potentially told that you're making things up, etc. But that's why advocacy and kind of raising awareness hopefully will decrease that time in the future for people, but there's still a lot of work to do. So talking about living day to day, lipodystrophy management is often multifaceted, so lifestyle, metabolic monitoring, medication, specialist input. What does a good day look like for you, and what makes a day harder?
That's a really good question. I try not to give myself too many expectations, I'll be honest with you. If I can get through the day, I have a really demanding job. I work for the NHS. Generally, I work from home, which is wonderful, because the idea of going into the office means I have to get up particularly early to get there, and that way I can park underground. If I can't park underground, car park, I have to walk, and I can't walk very far since I had my bilateral foot reconstruction where the metalwork's all broken and I've got no feeling in my feet. So that's why I look like a drunk person like this, because I can't feel my feet. But anyway, so for me, if I have to go into the office, it means a very long day. I work in Oxford, I live in Bicester, and it can take 2 hours to get home at the end of the day, which is just horrendous. But I work with a wonderful team who get it, or get most of it, and just sort of say, you do what you need to do, which is what I do. So mostly I work from home. You know, my whole day is very full. Lots of referrals, lots of stuff going on, as you could imagine. But at the end of the day, I walk my dogs, and that's my switch off the computer, get out. I'm now using a buggy, but I've got all of my greyhounds running along beautifully beside my buggy. But just to get out, so that for me, if I feel I've had an effective day work-wise, and then at the end of the day I go out, I don't care if it's raining. You know, we go out, I get a change of scene, I get outside. And because I work from home, it can be very isolating. So I see lots of other dog people, which are my kind of people. And we all sit there and talk about dogs. And so that's a good day for me. But then if I have WI stuff in the evening, I'll have to have a rest before I go out. Otherwise, it's a bit embarrassing falling asleep everywhere. But generally, you know, I do well. I cook my food from scratch because I don't like processed food. So, and sometimes I have to think, well, I've got this, that, and the other. And so I forward plan things, and I do find that's really helpful. So, you know, if I have to something comes up, that can throw me a bit.
Yeah.
But forward planning, trying to get the rest in. And as I say to my team, I've got a lady who's suffering with quite significant sort of exhaustion at the moment and fatigue, and I keep saying, pace yourself. And that's the one bit of information I'd say to people. Pace yourself, forward plan as much as you can, but get on with it, because life's for living.
Yes, thank you, Catherine. What about you guys?
Okay. I think a good day for me, I'll just do the average college day because that's a bit easier. I think, well, I'm quite bad. I wake up 5 minutes before I'm supposed to leave, so I get as much rest as possible. And then just go to college. I usually have a better day if it's sunny because I've a convertible with a roof now. It's lovely. Yeah, so I'm very lucky because at college I have, I'm pretty much in the same room every day. I have a disabled spot, so I don't have to walk far. it's in a different building away from the big college, and I have a lovely seat which is soft. I don't have to bring in things, and it's great. And if I've had a nice, I think the main thing for me that makes my day good, even if I'm feeling absolutely dreadful, is if I laugh. And if I laugh, and if I have a good time, then I pretty much forget about it. So
that's a really good tip.
Yeah, but if I do have bad days a lot. I would say bad days. I get very ill a lot of the time. I don't know whether it's lipodystrophy related or not, but I think as long as if I exert myself too much, like overexertion, that will affect me. If I've pulled muscles, it can affect my sleep and things. So I think as long as I'm getting a good night's sleep and not doing anything, overdoing anything, I think that's important. But also, I think it's really important to listen to your body. And, you know, if you can't do something, don't do it. Because even if it's to please other people, I mean, I've had friends where it's like they want you to do something and you just do it because you don't want to lose it. If they were your real friends, they wouldn't be making you do these things, then they'd understand. So find people that understand you.
Thank you, Lily. That's a very valid approach, and actually a lot of people come to that a lot later in life, so I'm impressed. Louis?
Yeah, so I think first I'd acknowledge that there isn't a day where my condition doesn't affect me, because even like I barely ever have a sleep through in the night because I always get woken up by a cramp. Even when I wake up, I can't use a normal alarm. I have to use an alarm that shakes my pillow because of my hearing loss. And so like literally even just sleeping and waking up, which is like the most basic thing that you can do, is affected by my condition. And so I think those constant reminders of how you're different and the way that you process in the most basic of human experiences is different, that can really be disheartening. But I think that for me, what makes it a good day is when I can find stuff to do despite that. So like, if I have a good sleep, despite maybe having cramp once, that's great. Because I struggle with a lot of fatigue, I don't do PE at school. And I'm in year 12, so I don't do PE anyway anymore. But like in year 10, 11, I didn't do PE then. And that was really difficult for me because when everybody else was going into the changing rooms, I would just have to walk past them, and I could literally see every other kid turn a corner that I knew I would never turn. And it was really disheartening. But actually I ended up going into the sort of SEN rooms, and I could get work done. And I actually met one of my best friends through that because they had a leg injury. And so I'd sit in the S rooms with her. And it would genuinely be the highlights of my day sometimes because I could just go there, be with my best friend, maybe get some work done. She actually taught me how to crochet. So I might not be doing PE with, you know, the vast majority of my class or my year group, but despite that, I found outlets and ways to cope and other hobbies and things like that. And so I think when I can enjoy, even if I can't enjoy everything, when I can find stuff that I do enjoy, even if it's different to other people, that's what makes a good day.
That's fantastic. Thank you, Louis, for sharing that. I think that, yes, fatigue is a massive problem through the community, which hasn't been very well understood. It's started to be more understood now, but we still don't really know the specifics of what causes it and how much of an impact it has. And I myself really struggle with fatigue, and I find my job currently is quite demanding. I work quite long hours, and I can basically sleep all weekend to try and recharge from the week. And then I do feel a bit sometimes like all I do is work, eat and sleep. And that's, you kind of can easily fall into a pattern where I'm just too tired, I can't do anything. And it's trying to find that balance between recharging, which you need to do, but also keeping the fun things, because that is so important. And even if it's a low impact activity like the crochet, that's something that you're doing for enjoyment. You enjoy it, it's spending time with your friends. And that's really valuable. And something we've talked about previously at these events is the spoon theory. So again, if you're not familiar with the spoon theory, that is applied to a lot of different rare disease conditions. And basically what it says is you have a finite number of spoons and they represent packets of energy. And once you've spent your spoons, you don't have any more energy. And so you need to decide what activities you spend that energy on, so that when you get to the end of the day or halfway through the day and you've spent your spoons, you've spent them on things that you need or want to spend them on. And sometimes that means saying, do you know what, actually I can't do that today. I need some time. I need to take some time to recover, recoup and recharge. And that is sometimes very difficult, particularly when you're young and all your peers are off doing things and they want you to come out and join in. And I found that really hard myself when I was at university, because people don't understand. But the key is to talk about it, because they never understand if you don't talk about it. And like you said, the right people that care about you, if you explain it to them, they will take that on board and they'll be your biggest advocates. So it's finding that balance, but it does take strength. And sometimes we don't have the strength to do that. But you guys all seem very strong, so we should take some lessons from you. Okay, so I'm relying on Siobhan to tell me when we're over time, because I have no idea. But just jump in, because we'll come in after the break anyway. But I wanted to ask you, what has been the most helpful from the healthcare teams and what hasn't? So advice that they've given, or, you know, kind of recommendations. What's worked well for you and things that actually, no, that was really bad advice.
Yeah, I mean, I think, well, we've had a bad experience with a healthcare team recently. I have hormone differences, so I have to get testosterone injected. And there's been a real confusion, even with like my endocrinologist, with what that looks like in the future. And I've really struggled with my injections because I have no fat for them to be injected with. And so like we're discussing alternative treatment plans where I can get injections that have longer periods between them, and things like that. And it's been really difficult because information has been quite scarce. And actually even specialists in hormones won't know everything about all the treatments and things like that, which is something that I really struggle with. But I think what we learnt from that experience is that you do have to research what you want before you go to an appointment. And I know you mentioned this earlier already, but it's really important to know that healthcare professionals won't know everything. And it's really good to have an idea of what you want to achieve from appointments or from long-term plans, because you need to work with your healthcare professionals rather than just completely relying on them or doing all the work yourself. Like, you have to find a nice medium in the middle.
Yeah, that's really good advice, because at the end of the day, our doctors are people. They're just human beings. They can't possibly know everything about everything. And particularly if it's not a specialist centre, they might never have come across or treated someone with lipodystrophy. The key is that they listen and work with you. Your strongest advocate for your health is yourself. To be educated about it, engaged with it, and to take a proactive stance on, oh, I've heard about this, I've read about that, is that something that would help me or relevant to my condition? And maybe it's not, but maybe it is. And being able to engage in a two-way conversation, because at the end of the day, nobody's going to be more invested in your health than you. So that's brilliant, thank you.
I guess from the perspective of a parent, again, it's difficult, and I guess what we've done in medical appointments is trying to support Louis to advocate for himself as well from a young age, and that can be sometimes, you know, talking about what's going to happen at the appointment before it happens, and you know, Louis can sometimes go into an appointment and he can advocate absolutely perfectly for himself, but I think there's also been some traumatic times which have made you shut down, and he hasn't been able to speak up for himself, and obviously then we've been in there to jump in for him, but I think, yeah, my advice in terms of medical appointments is speaking beforehand, thinking about what you want, trying to encourage Louis to advocate for himself, and if he can't, then being there to jump in for him. So, yeah.
I've had quite a similar experience actually, especially with advocating for myself. I think I used to not be able to do it, and I used to just believe what doctors tell me, and because we trust them a lot, and it's but I feel now that we need to we are like our own doctors really, because we have to do so much research and things, and I think it's better now that I'm a bit older, because I've started to be a bit more argumentative with things, so that's good. Still hasn't gotten me anywhere at the moment. Still having a bit of issues. What was the question? What works and what doesn't?
Yes, what has been the most helpful thing from healthcare teams, and what hasn't worked?
So I think the best thing was when I was, although it took a long time to diagnose, the best thing was when I was at under paediatrics, because obviously everything's connected. And I think because I'm in Wales and we don't have Addenbrooke's near, and there's been a lot of miscommunication, especially when going across to adult services, because they just don't understand. So again, I'd say I think it's really important that you all advocate for yourself and you do a lot of research before going into each appointment, and you know what you're going to say and you have proof for things. And a really important thing is, if your doctor disagrees, make sure that you're asking them to put it in a letter and giving a proper explanation as to why. And that's actually been very helpful. So
that's excellent advice, and also put them in touch with Addenbrooke's, because they might not take it from you as a patient, but hopefully they would listen to the clinical experts.
I'm really lucky. I feel really lucky these days, because I see myself and my consultants as part of a partnership now, coming along and joining in with Lipodystrophy UK opened my eyes. Not only did I meet people who look like me, which was hysterical, and Carol and I, the first time we met, we're going, oh, you look like me, and it was a real eye-opener. But, you know, I self-referred myself to your team, and I can't say how wonderful I think they've been, and you coming along here is brilliant, because it makes us feel that we're being listened to, and it's a two-way thing. I'm under a lovely chap called Professor Frederick Carper, who's in Ocdem in Oxford, and I've been under him quite a long time. And, you know, I had the flu really badly over Christmas, and I had an appointment with him at Ocdem, and I missed it. And he phoned me up and said, Catherine, are you okay? It's not like you. And I said, oh, I'm really poorly. I had chest infection, sinusitis. And he said, don't worry, I'll make another appointment for you. And I mean, he's just lovely. I adore him. But he has listened, and we've talked about things, and he's advocated for me. And I think the world of him, but he's, you know, such a great guy, and he listens and he puts forward ideas. And, you know, he was one of the first people I ever saw who didn't say to me, I think you've got Cushing's disease, which I think I'd be tested 5 times for. And he said, no, you've got this and this, and we need this. And my biggest problem is insulin. And I need to be off insulin, which is why I'm trying to get the bariatric surgery. But it's been, for me, once we got over the just keep taking more insulin, it's been revelationary that actually, I have got a problem. And the reason the insulin doesn't work isn't because I'm not taking it, it's because it doesn't work. And that was revelationary for me. So I'm really grateful that I've got a great GP who, we have long chats about things, and she says to me, well, what do you think? What are your thoughts on the matter? And I've got this hepatologist now who I think is great, and we're trying to work out what's going on with my liver. I was in at the clinic a couple of weeks ago when they first decided that I needed to have a biopsy for my liver, and she showed me a letter. And you medical people are always like this, and I work for the NHS, so I'm aware. And it said, patient denies consuming alcohol. And I've never drunk alcohol in my whole life, but that's another story. And it just makes me giggle, because I know that's how consultants write. But I did say, you know, it is true, I don't drink alcohol. And she goes, no, we get that. But the very fact it said that just made me giggle. But I know how it is. But, you know, it's another day, it's another consultant, it's another adventure, if you like. It's another, you're very complex. But it builds a picture, and that's who I am and how it is. But I feel that I'm not fighting the world anymore, because I have consultants and doctors who I feel support me, and I feel it's a partnership. And if I want to, and I think it's a good idea to write down little questions and to go along, and I go in on my own because I'm quite comfortable doing that. But it's really good to actually have those questions that you think about and have a discussion, because, you know, the medical professionals are interested in you as well. And, you know, and I'm also always saying, is there anything I can try? Is there this? Is that? And Omar, I've spoken to, I don't know how many times, because I keep, we were looking to see if I could do any of the trials. And he said to me, I phone you so often. It's wonderful, because I feel that he listens to what I have to say. And he says, we'll see if you're not, because you're on this or that or the other. But it feels like it's a partnership to me, and that's a real improvement in how life was for me for a long time.
Thank you, Catherine. And that's actually something I want to pick up on after the break, but we're running a little over, so we're going to stop for a short break, and then we're going to come back and continue the conversation. Thank you to our speakers so far. I think we want to be back by 5. Where's Siobhan? 5 o'clock? 4:45. So you've got 20 minutes. Hopefully that's sufficient. To be honest, we could sit and talk all evening. So thank you very much. Oh, I know, but it wasn't the agenda. No, it was my fault, because I didn't say that. I said, I'm going to do that. I could just, this is going to go on Oh, yeah, sorry.
I do feel we should have a little fire with some marshmallows.
Fire? It's already roasted. I know. Hopefully we'll get some questions.
Yeah, sometimes people have to go away and think about questions, don't they? So it's great fun. I just try not to talk too much, that's my biggest problem.
Ladies, we're going to have to shoot. Really appreciate the date. My daughter's hitting that sort of tolerance threshold. It's quite a long drive home.
Oh, is he already?
He's been in that for 2 hours.
I'm glad you've enjoyed it.
next time.
Thank you very much.
Stay in touch on the website.
Thanks for coming.
I think that this is probably the best part, in a sense, personal encounters, isn't it? Because you're relating it to your own situation.
Exactly. Connect with the stories. It's
great work. Keep it up. Thank you very much.
I'm sure they're staying tonight. I'm sure they're staying tonight. Yeah, I think so. Yeah, I mean, I wish they wouldn't make me cry. I sat there and my eyes are filling up with tears, and then Richard's like, "Don't start, because then I'll start." It's just, I think he's living. He's just so. I don't know how he does it. He just seems to have the perfect answer for everything. Yeah, but he's still only 16-year-old kid. I said to Rich, how's that kid only 16? He is amazing. I just. He just amazes me every time. I'm just like, he can't be 16. There's no way on earth he can be 16. It's just, but yeah, at the same time, my eyes. It is uncomfortable.
Nice to meet you. You're lovely. Yes, I'll go for it. Okay, like, to hear from you. And then you try to take credit. Imagine how I felt.
Another thing
well, I'm not like that. You get me. And she might have small another sweet house as well. What living I said, well, when I got this, I said, oh, we've got a lot of here. I said, what problem? I said, on 3 occasions. I said, if I comply with it, I'll be dead. I said, so, but I'll tell you. That's what's killing me.
yes, exactly. 5.5 years ago, they put me on insulin. I had an ECG done, perfectly normal. Then they said, no, you need to go on insulin. And then they had practice nurses coming to inject me twice a day. There's so much insulin, I put on 2 stone. And they're like, after many months,
I put 2 stone in a month.
Yeah, maybe it was a month.
They changed me to human one.
Yeah, I was on that.
And I just
Do you know what happened 6 months later? I'm in Harefield, I've been evaluated to Harefield Hospital to have an emergency triple bypass. And then I got septic shock in a multi-organ failure, in a coma, brain death coma, last week surgery, they've been switched the machine off, set on and because I died a couple of times, so I want the rest. And my life metabolism rate is like 5% when you're that far gone. And they've got my eyes. And they asked the family, they couldn't find a donor card. And they wanted my daughter was like, what do you mean organised? He said all their organs have failed, except for my heart, which was being fixed. And they said, oh, there's a young girl with all his eyes. You're hearing stories like that now, aren't you? There's stories around about them harvesting, so you need to sign that thing that you're donor to a donor, really, because they exist to have it. And they said to switch the machine off, and just in Zoom call, that's 12 of my family and friends with me, and my friend saw my iPhone speaker and told the nurse in attendance, oh, do you have a HSP? But like, no, that's an involuntary action. And then, a little bit later, they're there trying to pray for me, everyone, like my niece put out like a Facebook post, and all these people start praying for me to wake up. I'm not surprised. This was that's really sad. It's better as we can. Sorry. Gosh, it's really bad. Meeting Jackie has made my life very good. Oh, good. She that cares. Oh, she's that's what I've got involved in this. Yeah, I learned so much. Yeah. Good. Oh, well, thanks. You want me to go to the tea? No, got the brain line. I thought about it while I was packing, and then I didn't stop. But this is Carolyn, who I met, and we were both looking at each other going, I recognise you. Would you excuse me? Yes, I was, because I thought she was so, I did that every time, but I thought it was so far off the track. I know, I snored. No, you're perfectly quiet. That makes a change. Only when I looked at you, you slumped back a bit. No, you went backwards. Yeah, I did. I was thinking, poor young man sitting here. What? But no, I thought she was good. She didn't realise it. I said what I could say without being direct, you know, what it is the same day. Does it work putting us in the waist? No. What waist? It's what waist? Yeah, I haven't heard. Yeah, I wear child's clothes on the bottom, because I'm at size 8 to 12. Yeah. I can go into Primark and get I wear size 12, do you? Because I'm 22 exactly. Yes, because the I'm going to the shop she was giving me, they just don't do wide enough. They might do the tall enough. Yeah, but the length. Oh, was you talking about the tall and I was the one who asked. Yeah. Because I found them very disappointing. Yeah, well, no, I learned all that things before I was diagnosed. I was not a swimmer, but I was saying that when you started.
when the mics run out of battery when they're live. Yeah.
I'm just surprised there are
Yeah, it's a little bit aggressive, that noise, isn't it? I can't quite understand why it's so intense, but I feel there's just a lot of
frequencies going down.
Yeah. SM58's XLR's done.
You could actually have SM58.
Yeah, to be fair, you
They're always like comedians.
What's your name? I'm Jane, I'm James's auntie. And I'm Joanne, she'll be in a minute. Oh yeah, yeah. Joanne's, yeah. You enjoying it? Yes. Yeah, probably too much for you to take in, really. So I recorded some little bits. Yeah. Oh, you've got to. Yeah, you can. Yeah, that's the best way, that. Isn't it, Jimmy? Something about your thing. Well, I didn't realise a picture. I thought I left my jacket. It's not right. It was like, oh, Mum's got hers. And then, well, we come out this morning, because I've got a separate room from them. Come out this morning, and on one of the bollards, there's a jacket. She didn't even know she'd missed it. And then we were going back in here this afternoon, and his hat's there. So now I'll leave it. I've left my top on the other side of the sink, and then someone, I don't know how that top got on top of it, but well, I just yeah, there wasn't anything there when I put it down, and then it was, but I just thought it was Mum's belief. You know, the clothing. What's the let's go to the, not dark. Oh, the conventions. Yeah, Comic-Con. Yes. We're there in April next month. That'll be Liverpool Comic-Con. It's the one. Is it November? It's all swollen behind the eyes. Getting better, yeah. So it's next to me now. On the way, after we got concentrated, we're going to Charles, Star Wars, let me do that. Don't anything out of mischief.
Sometimes it's deliberate. I've got mine will be at my house when I get
I've started to make my own popcorn now. I didn't realise how easy it was. It's so cheap. It's like, they don't use that much. I use my own popcorn instead, and it's like you only need a tiny bit of it. Yeah, it's fine. Yeah, I look like a weirdo going to the cinema. I go to the cinema like at least once or twice a week, and I look like a massive loser because I have my own little Ziploc bag of popcorn. I forget the question in a way.
So do I, always.
I think I should write it down. I'm going to, what I should, right, I'm going to get a post-it. I'm going to get a writing thing just in case, so I can make notes because I forget the question midway through. Yeah, so there's one in here.
Right, I think we're going to make a start because we're in our final session. It's been a very long day, but a lot of really useful information, and I know that this is the bit that people really enjoy the most. We want to get the most out of our panellists while we have them with us, but also appreciate that if you're anything like me, you're probably exhausted. So we'll make a start. We'll finish at 5:30, have a couple of words, and then there will be dinner at 6 for those people who are staying. So thank you, everyone. Really enjoyed the first part of the session and kind of keeping up the momentum. As I mentioned, I wanted to ask a little bit about questions. So in terms of to clinicians, specialists when you visit. So many of us find it helpful to arrive with questions, as was already mentioned. And so I'd like to ask you guys to share the kind of questions that you think are useful to use in appointments. So, for example, which specialists should be involved in care? How do you manage your symptoms day to day? What lifestyle changes may help? how do I cope with emotional psychological effects? So that's an example of the questions you might want to ask a clinician. What are the things that either you asked or that, with hindsight, you wish you'd asked at an appointment?
I guess what's really important to me is when I go and see a diabetologist or my lipodystrophy, obviously we always go through the blood tests, and I'm a bit of a numbers person, so I quite like numbers. So, and actually I was thrilled because my last appointment with my practice nurse, she wrote good control. And then I went through a whole lot of other sort of previous appointments on my, my patient ID or whatever it was. And every single one of before that was poor control. So that was a bit of a win-win. And I get quite a lot of excitement by little tiny things. I think as you get older, little things please you. So I was really happy to see that. But, to look and try and maintain my weight, which was a constant battle. I'm on the highest dosage of Monjaro, haven't lost a pound. However, I think it's really evened out my HbA1c. And as Omar very kindly said to me, but you haven't put any weight on. And that in itself is something I hadn't actually thought about, but it's a really positive feedback, so I like that. I now am the one who monitors my waist, because I used to hate having and I don't know if people still do it, and sometimes when I go to Optum, they don't even weigh you or do your blood pressure. It's not always the way now. And so I try and go to face, but I want to have the whole experience. So I want them to weigh me, and I want my blood pressure recorded because I think it's useful. Generally, my blood pressure is good. But I've had good news. I've now been discharged from ophthalmology because they can't do many more things with my eyes because they're a bit end stage, but they can't do any more laser. But it's stable. And it's that word stable I actually get a bit off on. So when they say, oh, you're stable, we're only going to monitor you now, I was beyond thrilled. So it's the little tiny things. But I do things, as I say, I used to get so depressed about the tape measure, and I now monitor that myself because I want to know what I am. And I felt like a small child having my girth measured every time. So that's something I've taken charge of. But I'm actively involved in wanting to know what my numbers are. And that is important to me. So that's what I personally want to know, and I like to monitor where things are.
It's quite a difficult question, I think, for me. I think it's quite important to so bad. I think it's quite important to obviously be in charge of yourself, and in a way, I think sometimes you need. I don't know if I'm going to word this right, but I think sometimes you need to go into appointments asking questions you already know the answer to, because in that, I think that in that sort of way you'll know how the answers that you're about to receive are going to be proper answers.
Can you give an example of what sort of question you'd go and ask, knowing the
answer?
Sorry.
I mean, no. I mean, I'll just tell the story. Recently, I went to the diabetic team, my new diabetic team, who I've only known about a year. I've seen once, and so she doesn't know my history very well. And I have tachycardia, so my heart rate goes up when I do exercise and things. I struggle with exercise, and I've been trying to find out why. And so I went to the GP, and he thought maybe autonomic diabetic neuropathy because of my history with diabetes. And so I looked it up. I looked at the symptoms. I've got a few of the symptoms. I think that would be a very reasonable diagnosis. Obviously not to self-diagnose, but so I go to the diabetic team to ask, knowing that there is a big possibility, and then they say there's no possibility. And that sort of, sometimes you have to know the answer to things for things to move forward, in order to get referrals and.
How did you deal with that when they said there's no possibility? What did you do?
I sort of had a bit of an argument with her, I'll be honest. Nothing too manic, but I said, why not? And you've only known me these 2 years where my blood sugar has been perfect. You have not seen before. You have not seen the struggle. And I told her, because I was diagnosed when I was 12. That's not that. And then I was diagnosed with lipodystrophy when I was 16. So there's 4 years having high blood sugar. But that was also, obviously, she's acting as if it's as soon as I've turned 12. You don't know how long it's been before 12 either. And I find it's really difficult because they don't understand lipodystrophy. They think that, like in the letter, I asked them, because I always say now, if I don't agree with something, can you tell me why and put it in a letter? Which has been absolutely great, actually, because they sort of reveal everything that they don't know in the letter. Because in the letter they put that I'd had high blood sugar for a brief time post-diagnosis, so maybe when I was about 12, a brief time. And then in the appointment I asked, what would you consider high blood sugar? And she said, 15, just very high, 15. I was like, my blood sugar was over 20 for a long time, I mean, when I was diagnosed with type 1 diabetes at 12, my fasting blood sugar was 30, so I don't think it's fair, so anyway, long story short, that was not short.
Sometimes I wonder what my doctors think of me, because I sound a bit like a petulant child in an appointment, because I'll just be going, why? Yeah, but why? And I think understanding why doctors are suggesting what they're suggesting, or why something's happening in your body from a professional that hopefully knows more about the medical processes of your body than you do. I think the more understanding that you have of that, the better. So I do end up just asking why as much as I can, so I have an explanation. And I think that also links to Lily's point, because if you're not sure why they're suggesting a certain treatment, or you think that they might be misguiding you inadvertently or not, asking why and having the understanding of why they're doing it is really important, to understand where they're coming from and what you can do to change that if you need to.
That's great, thank you, Dewey.
I think it's hard to say a specific question, but if you go into an appointment knowing what you want to get out of it, and perhaps you might have to force that issue, but if you know what you're looking for, and then you can ask them around that question as part of that. I think looking at the diagnosis journey, Louis' mum done a lot of research and felt we needed to go to a geneticist. The specialists we were seeing were quite reluctant to make that referral. But once we learned that you needed to force the issue and push that through, I think diagnosis came after one appointment. So I think it's important just to know what you want to get out of an appointment before you go into it. So it might be discussions before, give it some thought, maybe note down some information so you don't forget what your actual aim is. So
Yeah, that's really good. Writing down questions, because once you get in there, it all goes out your head. You don't remember, and actually you might have had half a dozen questions you've been desperate to ask for this one appointment you've been waiting for months for, and then you forget, right? So writing it down is a really good idea. And I think your point of knowing what it is you want out of it when you go in is also a really good suggestion. And it's essentially about taking ownership of your own treatment, isn't it? And as we said earlier, you're your best advocate. So by being informed as best you can, asking the questions, you'll also find, I mean, like anything in life, you get good doctors and you get bad doctors, and they might be good diagnosticians, but might not have any bedside manner, right? But the good doctors, and they are out there, and the Addenbrooke's team are part of that. But there will be locally good doctors also that will listen to you. And the more that you engage in that two-way conversation, they will respect you for that. And they will make sure that they bring the answers to the next appointment because they know you're the patient that's going to ask the questions. So, yeah, that's always a good thing.
I think just to add on that as well, some of the experiences we've had the option of, if you have forgotten anything, emailing us and ask us questions, and that's always really helpful because, like you said, you do just get there and forget everything. So, and I think some of the other positives when I think about appointments is people speaking to Louis and asking Louis's permission before they, you know, maybe
Who can prod.
Exactly. And actually, you know, we've come to the conclusion that sometimes we don't feel that that's always necessary, particularly if it's the same thing every time. And, you know, it's more about what they're getting from that as opposed to what Louis is getting from that. And sometimes that can be a really negative experience. So I think what we've come to the conclusion of, sometimes Louis' frame of mind is he can do that and that's okay, and sometimes he can't and that's okay. And for him to say, actually, in this appointment, that's not okay, has been quite changing for Louis, I think. So, yeah.
That's a really important point, and I think Lily wants to come in on that as well. But I think that, you know, on the one hand, my attitude has been very much, well, nobody knows much about this, and so if I'm not going to help them learn, then they're never going to know much about it, right? So I always try to make myself open to those types of requests, and now better than it used to be, that you always get asked, is it okay if a colleague can sit in, they're learning, etc., etc. But sometimes you feel like a specimen. You feel like, I'm not a human being, I'm just a curiosity to you. Oh, aren't you fun? You're interesting. And yeah, well, that's not always how it's put, right? Yeah, yeah. Exactly.
Thank you. I think as a teenager and body changing, I think that can be even more
Insensitive.
difficult. Yeah. So,
and it is okay to say, no, I'm not prepared to do that. No, I don't want another colleague sitting in. No, I don't want to be in a fishbowl and observed. I'm here to get what I can out of this appointment. And then other times you might feel more comfortable with it and be willing to do that. At the end of the day, it's got to be what's right for you.
Just quickly, I find that what helps me is, well, you may not be able to do this based on where you live, because I know GPs it's a bit difficult to get appointments, but if you can, what I found is finding a good GP and just sticking with them and having that same GP every time, because I mean, I've got an amazing GP who's gone out of his way to learn about lipodystrophy. He talks to anaesthetists, he's sorts everything out pretty much, and it's really helpful to have that, because obviously unlike pediatrics, as adults, every different department is, you know, they don't talk to each other, so it's good to have that one person that just understands.
That's great, thank you very much. I want to talk now a little bit about identity, body confidence, relationships, mental health. As we all know, lipodystrophy can involve visible difference and self-perception challenges. As we've spoken about today and on our website and our Facebook page, we do signpost visible difference support resources, so like the ACT-based tools that we were talking about earlier, for people that are struggling with the social and psychological impact of looking different. Many people tell us that the emotional side can be just as challenging as the physical with lipodystrophy. And so I want to talk a little bit about that, where we feel comfortable. So for those who are comfortable sharing, how has your relationship with your body changed over time, and what helped you move from survival to acceptance, if you have?
Age helps. I've spent a while living with this body now. And I used to be really depressed about my stomach because I figured you could see it coming before I arrived. And when you look down, I can just see this massive stomach. And I say that, but my stomach isn't that massive, but that's how it feels to me. And, you know, buying clothes is always a nightmare. I added to that, I'm quite tall. It was just a nightmare. And I've now got to the point, next brought out these wonderful slim leg jeans I rave on about. and they fit me, and they do them in long, and I love them. And my son pointed out I had about 30 or 40 pairs, but that's by the by. But you know, being able to dress in a way that you feel comfortable does make a big difference. You know, I found I can wear dresses now. I find that's because I learned about fake tan. And I've got people comment about my legs because they're like Russian athletes. They are solid, sculpted muscle. And I like my legs, but they look bloody awful in a dress unless I colour them in a bit. So I discovered fake tan, and that's been life-changing. And if I can get long enough dresses, I'm actually quite comfortable in them because somehow I can pretend my stomach doesn't exist too much. So things like that. And I think age, really, you do grow into yourself a bit. And you know, I actually am now at a point with my white hair, I look like the sort of wicked witch of the West or something, but I'm actually quite comfortable with my appearance, which I really wasn't for a long time. And it's revelationary because, and I've also got to the point, and you do this as you get older, I don't give a toss anymore about a lot of things. And I used to watch Grumpy Old Women when I was a bit younger, and I aspired to the ladies in that. I am now a grumpy old woman, and I don't care anymore. But you know, I did go through that phase when people thought I was pregnant all the time. And it sounds so pathetic because nobody was being unkind or unpleasant. It was just one of those throwaway comments that just dug really deep sometimes. And now, as I said, growing my hair this colour, that's sort of, people don't say to me now, oh, you must be pregnant. And they just think, crikey, she's got a bit of a stomach on her. But I can live with that because I know the truth and I talk about it, and I'm a really open person. And I think that helps because I believe in educating people and sharing experiences. But I do think age has been, I think when I was younger, and mine sort of came on sort of in my 20s, 30s, I think if I was a teenager and I was struggling with this knowingly, I think I would have found that much more challenging. But as I've got older, definitely the grumpy old lady's thoroughly enjoying sort of standing out, and I genuinely don't care. I have days when I just think, God, I wish I had a waist, you know. I dream of a waist, but it's never going to happen. But I can cope with that because there's lots of other positive things. And I think lipodystrophy has in many ways enriched my life because I look out for positives. I've met some brilliant people, somebody included, and it's actually, I think, been fantastic. And that's why I wanted to be a trustee, because I've met brilliant people. It's given me so much. And that's why I want to get involved with the organisation and the charity, and they've worked so hard. But actually, as a result of that, I think that's really given me a broader outlook. So that's my excuse.
I think that, well, from the ages of about maybe 9 to, I think maybe even from last year, because I think treatment has helped a lot with image and being on the right medication and things. You know, I think, sorry, I think that, I know how it is, and it is hard when you've got, you know, a big tummy and a big face and people saying nasty things, and obviously there's only so much you can do to make yourself feel better about yourself. Did I say that right? Yeah. But I think it's a big part of it is just trying to accept the way you look, and just, I mean, if people are judging you, then they're a bit weird then, aren't they? I mean, you know, so I think a big part of it, you know, finding the right clothes that suit you, and I mean, you can wear whatever you want, who cares, but, you know, that sort of thing. And I think hairstyle is also quite a big thing. So I used to have, you saw me with long hair, I used to have long hair, and I used to hate it, it was curly. I used to stick it back in a ponytail all the time, and I don't think that helped my round face at all. So I think hairstyle is also quite a good one to, if you're struggling with your image, I think that's quite a good one to look at as well. But yeah.
I think coming to terms with my condition and how it affects my body is a process that I'm still very much in the middle of. And so, yeah, I don't know the extent that I can impart any wisdom. But I think one thing that helped me, and I actually, when I saw the stylist on the agenda, I was really excited, because there was a period of time where I did dress in black, and all I wore was baggy black tracksuits, and that was it. And that was a phase that lasted a good few years.
Were you a goth?
Yeah. And then there was just, I don't even know why, but there was just one period of time where I just started wearing different clothes, and it definitely wasn't as calculated as making balance on different halves of the body or anything like that. It was just wearing brown clothes instead of black.
About not hiding.
Yeah,
that's exactly.
And one thing that really helped me with was staring, because I'd wear like trousers and like a vest jumper, and so it was a bit out there, like it wasn't the most usual outfit, and I probably got the same amount of stares before and after, but when I was in a bit of a weird outfit, I attributed the stares to the outfit rather than to my appearance. And I was thinking, oh, they must just be looking at what I'm wearing. And
That's more comfortable, right?
Yeah. And so it gave me a bit more confidence in my body, because I had something to just play off the stares, and it was like, I didn't take myself as seriously or take any of the other people's reactions to me so seriously.
That's fantastic. And I mean, it's also allowed you then to kind of express your personality in the way that you're dressing. And I think what's fantastic about you two is that you're so young and you've come to this realization already. You know, it took me a really long time to get to a point. And I mean, even now, you know, I kind of, some days I have good days and I'm confident or happy with the way that I look, and other days I want to wear black, baggy, you know, or not go out at all. And you know, we're always going to get that. You know, that's just the way mental health works, right? But it took me a really long time to get to the realization that, you know what, I really don't care what other people think. If they care about me, they will value me regardless. I don't value their opinions, and therefore am I allowing their opinions to upset me? And quite frankly, I'm too hot to be wearing, you know, all these layers or, you know, all these things in the middle of the summer because I'm trying to hide my arms and my legs. And that kind of is what won over my kind of confidence issues. And I still get those issues, but it's being kind to yourself and recognizing that actually, particularly as teenagers, almost every teenager you come across, if they're honest, feel exactly the same way, and they're all trying to not be the one that's standing out. So actually, it's really normal. It doesn't make it any nicer, but it is actually a really normal thing.
Do you know what I think of you?
Yeah.
You've always got amazing lips. Hasn't she? Yeah. Honestly, I always think...
You've got to use the things you've got, Catherine.
Yeah, that's your look, and I always think of you and your amazing lipsticks.
Thank you very much.
I don't think of you in any other way, apart from your wonderful curly hair. But the lipsticks, I just think of you as walking lipsticks. I think legs. Sorry.
It's after a kiss.
It's your trademark in my mind.
Oh, well, thank you very much. And again, it's about having that hook, right? Wasn't that what she said? That's my hook.
That's your hook. Brilliant.
Also, sorry, could I just add something? I think if you have a good personality, it actually makes people look past what you look like. And, you know, obviously, if you look at people, you don't care, do you? So... yeah.
And in the grand scheme of things, it really doesn't matter. And that's a hard lesson to learn, and it takes a long time to learn it, but it really doesn't matter. And the people that are worth knowing and who you value will value you, and everybody else, well, take it or leave it, it's their loss. So I wanted to ask about how do you handle, so we've all had this, unfortunately, how do you handle comments, staring, or assumptions? How do you deal with that?
Oh gosh, I hate starting. I'll be honest, I don't usually manage because it's so difficult. You know, I mean, I've had a lot of comments and nasty comments. I still get them. And I think the important thing is to remember, again, they must be, if they care that much to go and tell you and to make yourself feel horrible and make you feel horrible about yourself, then they must have something extremely wrong with them, because that is not normal behaviour. And I think, yeah, they're just projecting. And I think a lot of the time what you can do is, what I like to do is I like to, if someone says something horrible about me, I like to look at them and I like to think what I don't like about them. And that sort of makes me feel a bit better, because they're probably very insecure about that. I wouldn't tell them unless they were that horrible, but we won't go into that. But no. Well, I mean, I think what I usually do is I think of when someone's horrible to me, I think of something really good to say about 5 minutes after I've walked off. But yeah, I think it's just important to just stay positive and remember that a lot of you, I'm telling you now, a lot of you probably hate the way you look, but I think a lot of us, it's not as bad as we think it is. I think a lot of us actually look very, I know it's not very good to say normal, but I think you do look very normal and you all look very beautiful.
Yeah, I'd say for me it just depends who it is. And yeah, if it's like a really small kid who probably doesn't know better, then I'll probably respond to a stare with a funny face or something like that, yeah. Yeah, and just see how they react, and that's actually really funny and entertaining, because some of them will do it right back, and then some of them will run away. And then obviously, as there are instances where it's more serious than that, and it is someone being rude. And sometimes it can happen in the most unexpected of places as well. I've noticed that actually places that are supposed to be family friendly and like inclusive is actually where it happens the most. And I was in Cadbury World with Dad, and that's probably the time that it happened the worst. And it was just a whole family, and they were all staring at me, and I kept making eye contact with them, and like, surely they would have got the cue, but they just didn't. And it was like a little bit of a museum sort of thing, so you were walking around, and so the whole time, like, we were stuck in this like flow system close to them, and it was just awful. And it was really difficult, like I really struggled, but actually having Dad there to support me and talk through it and escape from it after, like, I still, even though I really struggled that day, I have such fond memories of that whole trip and all of the stuff that we did after that and before that. And so I think it's combating that negativity and surrounding yourself with people that can support you. Yeah.
Thank you.
I was just feeding off what Louis said. I think from a parent's perspective, it's so difficult to be watching people stare at your child and seeing how upsetting that is for them. And I think for us, like Louis said, offering that safe space for Louis just to talk about those feelings and about what that means about that person compared to what that means about Louis, I think for us is really important. And I think sometimes I'm a parent who wants to have lots of solutions and come up with lots of ideas, but actually what I found is just letting him talk talk is really important. I mean, you have had some therapy, and I think that that's been played a huge part in Louis coming to terms, or still coming to terms with his diagnosis. But what I want to say is days like this is just so important, because Louis is with people, his people, who get it, who understand him. And I think it's something that we look forward to, don't we? Because it's a place that Louis feels really happy. Yeah, sorry. It is, and just thank you, because we know it's all really hard work. So thank you for everything that you do for that, because it does make a huge difference, and that acceptance, is really important, and being around people who can support Louis with that, yeah, we really appreciate it. So thank you.
Thank you. And I think that's the key, right? Because I think with young children, they'll often stare because they don't know better, and it's not because they have anything malicious behind what they're doing. They just are staring, and actually it's on the parents. That is a learning opportunity for the parents, and too often they don't take that opportunity, which is a shame. I think depending on how you're feeling, sometimes you can confront it, you can look and smile, and sometimes that just makes people realise they're staring, and then they'll kind of, oh gosh, and they won't continue to stare. And sometimes, if you're feeling confident enough, go up and speak to people and say, well, is there something you wanted, or is there something wrong? Or if it's a little kid, talk to them and say, well, yes, I have lipodystrophy. That means, I don't store fat properly, but that's okay, because I can still do lots of things, and I can, play with my friends, or whatever it is, that kind of context of how they would understand it. I think it's very difficult, because sometimes you're able to do that and sometimes you're not. And so sometimes when I get that, I will, either be frustrated and kind of glare at someone, or I look at them, make eye contact and smile. And other times I just want to go, I just want to get out of the situation. And as a woman with lipodystrophy, I have been asked on multiple occasions if I'm trans, and I find that very upsetting, because that's very insulting. It's something that's very personal. I'm going to guess. And even if I was trans, they've got no right to come up and say that to me. That's really rude. And actually, that's about other people and their ignorance. And even though it still hurts, recognising that the problem isn't you, the problem is them. Lipodystrophy is nothing to be ashamed of. It makes life more difficult, granted, but it's not everything of who you are. There's so much more to you than just lipodystrophy. And like Catherine said, actually, for a lot of people, lipodystrophy has allowed us to do things, meet people we never would have met, things we never would have done without this condition. And so, sometimes it's hard to be positive, but it is important to try and capture the positive, because there are lots of good things that come from it. And actually, just because you might be limited in some aspects of your life, it doesn't mean you can't do things. It does not mean you can't achieve things. We have a whole room full of people who do fantastic things, and the next generation coming up and showing us how to do it better. And, we're here as a community to support each other, and that's why we're all here today, because we know how important it is to meet other people who look like us, who understand what we're going through, who you don't have to explain yourself to, who understand when you say, oh, I'm going to have to have a nap because or, oh God, when is dinner being served because I'm absolutely starving. They get it. There's no judgment, right? And that's why these forums are so important. There's so many more things I want to talk about, but we haven't got time to do it. And I think we could probably talk all night, which is, would be wonderful, but not what anybody else could manage. But I guess in the last couple of minutes, we've got 5 minutes before the end of the agenda, it would be really good if we could get some questions from the audience for anybody who would like to ask the panel a question, either a general question or one directed, for example, to the parents, where you'd like to understand something a bit better.
Thank you, and thank you so much for all being up there, because I know that must be really difficult to answer questions like that. And it's been really, really helpful. But my question is basically, what one thing about managing your condition would you say is the best advice you've either received or that you'd like to pass on?
So from my perspective, and we move down the line, it's to be your own best advocate, fight for what you want, what you need. Nobody's going to do it better than you. And trust yourself.
Ditto.
I was going to say exactly the same thing.
I'd say just take your time, figure out what's right for you, and yeah, repeat what was already said.
Ditto.
I think they're learning to say no, or if you don't think you need that appointment, you don't think there's something worthwhile, or you're not comfortable with something, then say so.
Hello, I just wanted to ask, so I'm just starting this journey, so I've only recently been diagnosed, maybe the last 6 months, but I was diagnosed with insulin resistance when I was 20, but it's just more lipodystrophy since my pregnancy 5 years ago. So for someone starting off in this journey, what advice would you give? And also for some of the symptoms like the extreme hunger or the fatigue, what tried and tested tips do you feel have worked?
Yeah, that's a really difficult question, because obviously everybody's different, and obviously you will need to be in touch with your healthcare professionals to kind of help in terms of actual treatments. However, similar to what we've already said, be your own best advocate, learn as much as you can about the condition, and while there are medications available to help, the best thing you can do is to have a balanced diet and exercise, because that helps improve your insulin sensitivity. It helps remove the excess fat that is being stored where it shouldn't be, which will help your organ function. So eating a lipodystrophy-friendly diet is really critical. Now, that is also easier said than done. When I was first diagnosed, it was before the Addenbrooke Centre was established, and I was told by a dietitian, well, you can't eat carbohydrates because you're diabetic, and you can't eat fat because you've got lipodystrophy. So I guess that just leaves protein, and that was the advice. I mean, that was shocking. So thankfully that is not actually the case, and there are things you can do to have enjoyable meals and still eat well. And actually, as part of the charity, we've put together a recipe book that's outside, and we would encourage everybody to submit recipes they found that work and are kind of lipodystrophy friendly. Send them in to us, because we want to create more of these resources for people. But just take ownership of your own treatment.
I concur.
Yeah, I think that I think piggybacking off what Rebecca said, it's so important to find the right treatment that works for you, because it will change your life. I mean, I was on insulin and metformin for years, and it didn't do anything. And then as soon as I start Mounjaro, for me that worked amazingly, and it's probably been the best. It's been like a godsend, really. I mean, it's been the best thing ever. And so it's just finding out. It might take time. You want to find out what your, the balance of things, the amounts of things, But it does. You can get there, and I mean, I'm quite a good example, because my blood sugars are like that, and my weight is maintained now, and my fatty liver's gotten better, and I'm still on Mounjaro, but I don't have a massive appetite anymore. So it's things can change. So
yeah, I think in my opinion you've probably already followed the best piece of advice, which is to make contacts with people with lipodystrophy, because if you have those contacts, all of the practical advice comes next. So honestly, just go around after this, if you haven't already, and get everyone's phone number. And then, yeah, I think that's it.
My advice would be take the positives and really think about that, because I think sometimes we can get a bit bogged down with the negatives. And I probably shouldn't say this, but one of the positives we often have is that people think that Louis is malnourished. And now when we go into restaurants and we're out somewhere, he will end up with most food on his plate. So so we spend lots of time looking at the positives and you know, trying to laugh about things. I think for us as a family, that's really, really important.
I don't think I've got anything to add to that. No. Thank you.
Actually, this
It's just so important to us. It's a mental lifeline. You're not alone.
I was just going to actually kind of on that back, just kind of say, I'm absolutely blown away. This is the first time I've been here and feel I've learned so much about myself that I didn't think I would possibly know. And I'm also blown away with everyone that's standing up there and speaking so eloquently. Some people literally half my age that are doing a much better job than I would. So I think you should all have a round of applause because you've all been fantastic.
I just wanted to ask, for people, it's all very positive, and it's good to end on a positive, but what positive things do you do for yourself when you're having a bad day? So if you're feeling like, woe is me, and why me, and depressed and feel like the future looks bleak or whatever it is, what do you do to stop that, and how do you support yourself, because you can't always have support from services for that? So what do you do personally, because there might be people here still feeling a bit depressed about the whole thing, even though it's a very positive event?
Thank you. Yeah, that's a very difficult question, and depending on how you're feeling, depends on how able you are to do the things that you need to do in order to get you out of that funk, right? What I find, and this is something Lily touched on earlier, is that do something that makes you laugh. So when I'm really feeling low and I don't want to do anything, I'll watch Brooklyn Nine-Nine, which without fail will make me laugh, and I'll always feel better after watching it. So I might not have the energy to go and meet a friend or talk to family or, you know, do a crafting activity that I enjoy. I might not have the energy or capacity to do that. All I can do is hunker down in bed. So what I'll do is watch something that's funny. But spending time with people that you love and love you and support you is the best medicine.
It's that window of going out with my dogs. I know it sounds a bit boring, but I love that because I'm out in the fresh air. You can't help but laugh when your dogs are being ridiculous. One of them caught a squirrel recently and pranced around with it, with their greyhounds. She didn't know what to do with it once she killed it. She just wandered around with it, and the others were like, oh, whatever. But I've got one of mine, which is an absolute dipstick, frankly. He's a donkey. And he's, you know, just does silly things. But I never, ever tire of when I watch them all rushing off together, usually after a squirrel. And they just take your breath away with the speed, hope they don't hit a tree, you know, hope they don't run over that person with their pushchair. But, you know, that for me, it really lightens, because they're my world and I love them to bits. And you know, and I have a hard job, but looking forward to going out, even if it's raining. They've all got coats and fleeces and pyjamas and all of that. So I like to colour coordinate them. But just getting out there, and we always meet other dogs. And, you know, someone's dog is always doing something stupid, or someone's trying to nag me for a treat. But it sounds silly, but that is just, for me, it just takes everything away. And you're sitting there thinking, oh, God. One of mine fell in the river because he came screaming down the hill and forgot to brake. And then, and oh, honestly, it was hilarious. And then he then tries to style it out like he meant to.
But they're great fun. Mine love other dogs, and we get all the little dogs come rushing over to say hello. But for me, that's my community. So that for me is so important. And when I was in surgery and wasn't able to walk or get out at all for 6 weeks after my surgery last year, that's what I missed, was getting out with the dogs. So, and seeing everybody. So that's mine.
I think, from when you're trying to distract yourself, when you're feeling physically down, I think obviously laughter is a great way. I like to, if I can, I find that this will not work for everyone, and this, obviously you have your limits, but if you feel like you can maybe try, like sometimes if I'm feeling quite ill, I'll push myself to go into college, and because I'm so distracted talking to people, I'll end up feeling much better. And then from a mental perspective, if you're feeling down because you just are feeling like you hate the way you look or whatever it is, I think it's important to. I think a good piece of advice that I followed is when you have the chance, push yourself to do things you find uncomfortable, like talking to people. I mean, a few years ago, I could barely speak to a stranger because I just panic and things, but now I can literally talk to anyone. So doing things like that is really helpful, and just pushing yourself. I mean, I did this little community fashion show. I was a model for a fashion show. And it was terrifying, but I pushed myself to do it, and I had a great time. And I wouldn't have thought to do it unless I'd pushed myself, because I was worried I was going to stand out and things. But there were loads of people who looked like me, not like me, to all sizes. So I think it's pushing yourself is such a big part of it. You need to sort of train yourself.
Yeah, I think when you have a lot of negative emotion, there's a few different pathways you can choose, because you can choose distraction or trying to get through something. A lot of the time I choose to more try and process those feelings, and there's a lot of different ways that I do that. My favourite is writing an angry email. So whatever's made me feel negative, even if it is the way I was born, my condition, I will write a very strongly worded, passive-aggressive, email, letter, whatever it is. And yeah, it's just a way to get your emotions out authentically, but also you're still having some satire and making some amount of fun of it. So yeah, I find that to be a happy medium between distracting yourself and processing your negative emotions.
I'm glad I haven't got any passive-aggressive emails from you. I'm sure one will come soon. I think from a parent perspective, I think again, sometimes it can feel really difficult as a parent, and I think last year we got the opportunity to meet another family who had the same condition as Louis, and we've been able to stay in touch, and I think for us that's just been so invaluable. When things are feeling tough, we can go to them and have those conversations, and likewise, other people who are in early stages of diagnosis, if they can come to us and have that support, that is really helpful. And I think just being in a room and being able to talk to people about, some of the stuff that Louis is going through, and hearing someone else say, yes, we feel that too, has been really powerful. So just being in contact with other people is really helpful.
I think we always help each other as well. So we probably process things at different paces. So it's being there for those people close to you. And Louis doesn't always hit send on those emails either.
Yeah, I've got a few in my cupboard. Maybe I'll get them out.
Thank you very much, everybody. It's been really a privilege and a joy to sit here talk with you. We could go on forever, but unfortunately we can't. But thank you for coming up, sharing, being vulnerable, sharing your stories with everyone. I'm sure it's very much appreciated. And yeah, I just think you're all wonderful. Thank you so much. So that draws to an end our agenda for today. Thank you so much for joining us. And for those of you that have been here before, thanks for returning. And newbies, thank you for finding us. I'm so glad you did. Hopefully we'll be doing another one of these patient days next year, depending on whether we can get funding. But please stay in touch, join the Facebook page, look at the website. There's lots of resources available. Reach out to us, reach out to the Addenbrooke's team. And yeah, don't be strangers. Thank you very much.